Assalamu alaikum and hello and welcome to the 2022 Emirates Thyroid Congress. This is the pre-Congress symposium section. After the symposium is finished, we will begin the official opening. For now, I would like to thank Merck, who are the pre-Congress symposium sponsors, for helping us to deliver this pre-Congress session. The title is Euthyrox New Formulation, Outstanding Better Health. And the speaker is Dr. Salman Razi. He's a senior lecturer in endocrinology at Newcastle University in the UK and a consultant endocrinologist at Queen Elizabeth Hospital. He has more than 80 peer-reviewed publications and book chapters related to thyroid dysfunction. He's a member of the editorial board of the JCEM, Thyroid Frontiers in Endocrinology, and Journal of Endocrinological Investigations. He's also a member of the British Thyroid Association. He will be delivering the Merck Symposium titled Euthyrox New Formulation, Outstanding Better Health. Thank you.
Good evening. It's a real pleasure to be here with all of you for this virtual Thyroid Congress. And today I'll be talking to you about the new formulation of levothyroxine and how it has the potential to orchestrate better health in our patients. So there are some of my disclosures. And as we all know and experience, there are a number of challenges when we manage our patients with hypothyroidism. First of all, starting from the beginning would be, how do we make a diagnosis and confirming it? Once it's diagnosed and we start treatment, how do we maintain euthyroidism both biochemically and clinically? How do we control TSH with symptoms, which takes a priority? And how do we manage associated or related conditions such as the lipids, such as the weight, and so on? And then there are these other groups of patients that are typically at higher risk of developing issues or problems, such as children, such as people with thyroid cancer, such as pregnant women, and so on, who need careful management of their condition. So we'll try and cover some of it today. So the global prevalence of hypothyroidism is outlined here. As you'll see, there are lots of gaps in the literature. There are many, many countries around the world where we do not really have any data as to how many people may have the condition. We do have data for a lot of Europe, for China and India and Australia and the US and Brazil. But unfortunately, as you'll see here in the middle of your screen, Middle East, there's hardly any data that tells us what it is in the general population. There are lots of reports about hospital populations of people with this condition, like such as type 1 diabetes and so on, but not across the general population. And once we start treatment, we know that levothyroxine has been and remains the gold standard of treatment. It's relatively cheap, it's easy to administer, it doesn't have very many side effects. Absorption is up to 80% in healthy fasting adults who don't take any other medications. And once you take it every day, then both T4 and T3 levels are maintained. Then that is because its half-life is relatively quite long, about a week. And then after treatment started, it takes about 6 weeks generally to achieve stable TSH levels subsequently. We haven't got a lot of data for elsewhere, but in the UK, levothyroxine prescriptions has been increasing, and I believe it's a similar story in the US. So in 2005, roughly 2.4% of the population was prescribed levothyroxine, but in 2014, it was closer to about 3.5%. And that equates to roughly 2.3 million individuals. That was 8 years ago. It's very likely to have gone up even more since then in many other countries. Why is the dose of levothyroxine important? Primarily because of all the relationships and associations that we have seen. So people who have both low or high TSH whilst on levothyroxine have been shown to have higher risk of cardiovascular disease, higher risk of cerebrovascular disease, dysrhythmias, particularly with over-treatment where the TSH is low, fractures in pregnancy, premature delivery, depression, and so on. These are all higher in people who have higher or as well as low TSH. Again, doesn't necessarily mean that that is what is causing these outcomes, but it just goes to show that we should try and aim to have TSH levels as much as we can within the reference range. So if you think about an individual patient, and one such patient that comes to my mind is this lady who's 36 years old, who was referred by her GP to my clinic with a high TSH despite being on 225 micrograms of levothyroxine. She was diagnosed with primary hypothyroidism when she was 24 and had been stable on 125 micrograms every day for a number of years. And over the last 9 months, the GP had to repeatedly increase the dose as the TSH levels remained stubbornly high. She said that she was taking her medications every day. She didn't miss many, if any, doses. She hadn't had any new medications. She denied taking any other over-the-counter supplements, such as iodine, such as selenium, iron, calcium, anything that might interfere with this absorption. And she didn't really say that there had been any major changes in her diet. She certainly hadn't stopped eating or drinking one thing or the other. Things had not really changed very much. And she said that she continued to take her levothyroxine 1 hour before breakfast, as this is what had been advised, and this is what she had always done. So that hadn't changed, she claimed. When she came to clinic, her TSH, yes, was still high at 8.5. Free T4 levels were within the normal range. Screened for malabsorption, such as celiac disease or pernicious anemia, was negative. And when she was asked about what brand of levothyroxine she was taking, she didn't know, as it was prescribed as levothyroxine, the generic drug, by her GP, and it was dispensed by a pharmacist. So she would generally just take whatever was given to her. Why is TSH important? Well, it is important because of the relationship it has with T4, or free T4 in this case. So for every 2 times change in T4, we get 100 times a change in TSH. And this is true for most people. It isn't true for everyone. It can be influenced by age, it can be influenced by smoking, it can be influenced by T2 antibody status, by body weight, and so on. But for most people, this is a rough estimation that we need to have in our mind. So if somebody's free T4 doubles, then you would expect to see the TSH go down by 100 times. And if somebody's free T4 halves, then you'd expect to see the TSH go up by 100 times. That's the average, as you'll see from this scatter plot here. So what are the main causes of high or abnormal TSH levels in people on levothyroxine? The first one here on the right-hand side is poor compliance. That has to be the main reason. Every person that takes any medication long-term, such as statins, high blood pressure medications, diabetes medications, knows that it's very difficult to remember to keep taking it every day. And there are people who do not see it as being absolutely essential and may stop taking it for a period of time and only start taking it before they know they have a blood test. And that can cause problems with the results. The effect of food and other drugs, we've talked about that, such as calcium, such as iron, the timing of the administration, whether you take it in the morning, whether you take it late afternoon, whether you take it in the evening, in relation to food, in relation to what you drink, coffee, milk, those kind of things. Some people might need different doses. So generally, the dose of levothyroxine is about 1.6 microgram per kilogram. And if somebody has lost a lot of weight, the dose requirement would go down if they have put on a lot of weight, the dose requirement would go up. We've briefly touched upon gastrointestinal disease, such as celiac disease, such as pernicious anemia, and any other malabsorption conditions for that matter. Something that we'll think less about is inappropriate storage. Where is the levothyroxine being stored? When it is in the pharmacy, it is under a controlled environment. It is in a dark, temperature-controlled place. When it is in someone's home, it may be anywhere, from the kitchen to the bathroom to the bedroom, in a hot place, in a cold place, in a place filled with moisture. It could be anywhere. So we don't really have any control over that. And I'll come to that in a minute. But that can have an influence on the ability of levothyroxine to stay at its exact dose. And switching between levothyroxine products. Not every product is exactly the same. There will be some variations. So even between the same brands, between batches, variations will be there. Not a huge amount, but there will be some. But between brands or between different products, there will be some variations. So 100 micrograms of brand A will not be 100 micrograms of brand B. Brand A might be 105 micrograms and brand B might be 95 micrograms. So it could mean a whole difference of 10 micrograms for that person if they switch from one to the other. And that we don't really think about a lot, I must say. So, as I said, some of the factors that affect the stability of levothyroxine, one is the excipients. Excipients are the inert substances that are added to the tablet to make it bulkier, to make it more stable, to make it last longer without losing its power. The packaging, usually airtight and light-resistant containers are better than blister packs. The temperature ideally should be between 15 to 20 degrees Celsius. So if it's, say, in Abu Dhabi or Dubai or Sharjah, wherever you are, if somebody keeps the levothyroxine outside in the sun in July or August, then the temperature is on average about 50, 55 degrees, you can expect the levothyroxine to degrade much, much quicker. Or if they keep it, say, in Finland or Iceland or Siberia at minus 30 degrees Celsius, then again, the degradation would be much higher. Humidity has a big impact. If somebody keeps it in the kitchen or the bathroom where the humidity is going to be very high, then, and if it's exposed, it will degrade much quicker. And therefore, being exposed to oxygen and light will also have an impact. All these things may make a difference over a period of time. So if you start taking a tablet that's been exposed to oxygen and light and high temperature and high humidity, then if they take the same medication for 6 weeks, so a 100 microgram tablet might only have 60 or 70 micrograms in it, and therefore they're not really getting the same dose. So those are the kind of things we need to be mindful of ourselves and also be able to convey that to our patient, because not very many people think about the other reasons for why the TSH might not be where you'd expect to see it. So why was this need to have a new formulation? So new formulation, I'm sure you'd have experienced yourself, has been launched in the UAE by Merck. And basically it was to address new regulatory requirements for products from the drug regulators. And the reason behind that is because WHO has classed levothyroxine as what's it been classed as? It has been classed as drug of not concern, but drug that requires to be handled carefully, and fluctuation in the daily dose of 10 to 20% may be clinically significant, especially in more vulnerable people, such as children, such as older people, pregnancy, and so on. And the reason being, if there were tighter specifications of the shelf life of the product, so over from when it is manufactured until its expiry date, if you know that the specification was going to remain within a tighter range, then it should lead to less problems. So in example, in most countries, the specification is 95 to 105% of the stated dose, whereas in the UK it's 90 to 105%. I don't know why it's slightly lower in the UK. We'll have to ask the MHRA that, but that is the case. And therefore, the new formulation was required to ensure that patients receive a more precise dose to treat their thyroid condition. So the objectives were to improve the pharmaceutical stability, and two, to ensure the potency specification over a shelf life of at least 18 months, but ideally longer. Generally, the expiry date is usually 3 years after manufacture with the recent new formulation. So the word I was looking for was narrow therapeutic index. So the WHO has classed levothyroxine as a narrow therapeutic index drug, and therefore they require more stringent regulations compared to other drugs in terms of both the accuracy and stability of the amount of active drug in each tablet. And I said before, it has to be between 95 to 105% over the shelf life of the stated dose. So the active ingredient remains levothyroxine sodium. That hasn't changed. The shelf life is 3 years, as long as it's protected. If you keep it, as I said, out in the sunshine in 50 degrees Celsius, then it will not remain at the stated dose for that period of time. The other thing you'll notice is that it has maize, crosscamelose, gelatin, mannitol, magnesium, and citric acid, and that is different to what it had before. The previous version had a bit of lactose. Now, the advantage of taking out lactose is that it increases the physicochemical stability of the product. And secondly, people who might have lactose intolerance will have had problems with absorption of levothyroxine, and therefore that might not be an issue anymore with the new formulation. So as you'll see here, the new formulation compared to the old formulation has tighter specification. The old formulation could have been anywhere between 90 to 110%. So what that means is 100 microgram tablet could have been 90 micrograms or 110 micrograms. So imagine you had one batch that had 91 micrograms of levothyroxine, then you bought a 100 microgram tablet, or the next batch could have 110 microgram, and that would be legal. But for the patient, it would mean a difference of almost 20 micrograms between the two batches that they obtained. It usually didn't amount to that, but that could be the indication, or it might mean even between different brands. So that has been changed to a slightly tighter specifications, 95 to 105. So even if one batch had 95, the other one had 105, the difference would only be about 10 micrograms and not 20, as with the previous extreme example that I've just given you. So how do we know that the new formulation is similar to the previous one? As per the regulatory requirements, Merck has had to do two studies. One was a bioequivalence study, and the other was a dose-form proportionality study. The bioequivalence study basically means showing that the dose of the new version is very similar to the dose of the previous version. The dose-form proportionality means that the various doses in the new formulation, such as the 25, the 50, the 100, and so on, would have exactly the same within each tablet. So they wouldn't be any different. So the 50 wouldn't be different to the 100, 100 wouldn't be different to the 200. In terms of how much is released, the dose obviously would be different. So if you look at the bioequivalence study, which is comparing the new formulation with the old formulation, and you can see the graph for yourself here, you'll see that these are healthy volunteers, young people who took 600 micrograms of the new formulation, had blood tests over 72 hours, had a washout period, and then took the new formulation and the same thing done over, and they had the total T4 levels checked again. And if you graph it out, you'll see that almost mirror each other. They are practically on top of each other. And you'll see that the area under the curve, the ratio of that is almost 100, which is within the parameters of what was required by the regulator. Now, this confirms that the new formulation, in terms of the amount of levothyroxine it has within it, is exactly the same as the old formulation. What about the dose form proportionality study? In this, there were 3 groups. One group that was given all groups were given 600 micrograms in total, but one was given 12 tablets of 50. The other one was given 6 tablets of 100, and a third group was given 3 tablets of 200, and their levels checked. In reality, it was the same group, but given over different time periods. And you can see here that the level of total T4 achieved in their blood was practically the same. You'll see that they, again, are almost superimposed against each other up to 72 hours. Some slight changes here at 36 hours, but within the first 12, 24 hours and up to 72 hours, very, very, very similar. So what about safety? That shouldn't be a concern in any case, because this is not a new medication, the same old levothyroxine, but the excipients have been changed a little bit. But the regulators require safety to be shown, and both formulations were well tolerated, as we know from our clinical practice. Treatment emergent adverse effects were similar. Headache was the most frequently reported drug-related TAE, but it could have been the old or the new formulation. But imagine if somebody has a normal thyroid function and given 600 micrograms of thyroxine, they might have a little bit of a headache. 204 subjects completed the study as expected, and only few withdrew due to the side effects. Again, none of the side effects were mainly in relation to the new formulation. They were equal in both. So what we think is that the usefulness of the new formulation is particularly high in the high-risk patients, such as we've talked about before, in children, in older people, in people with thyroid cancer, in pregnant women, and in people just like Mrs. M that we saw at the beginning, who have a history of difficulty in achieving normal TSH levels. And it might be due to the fact that they're either not storing the medication properly, or they might be being given different formulations by the pharmacist on various occasions. That is difficult to know. But if everyone has much tighter specifications, the range of TSH that goes up and down will be hopefully much lower. So almost towards the end, to summarize, tighter specification should lead to decreased variability of the active ingredient, facilitate fine-tuning of the dose for each individual patient, particularly in high-risk groups and the more vulnerable patients, such as the elderly and the pediatric and the cancer and the pregnant ones. It should allow patients to receive a much more fine-tuned dose, which is more reliable and consistent over their treatment period, which would, in most cases, would be forever. And based on the bioequivalence data, comparing it to the previous formulation, efficacy and safety should be no different. And the benefit-risk ratio should remain pretty much still in favor of the medication. So in summary, the bioequivalence has shown similar efficacy. Dose proportional studies have shown it is very similar across the various doses. Tightened specification should optimize stability and therefore should allow for a more predictable level of the drug to be provided to each patient, so that a more exact dose is delivered, and therefore patients should be receiving more reliable and consistent doses of levothyroxine and help them achieve euthyroidism within a minimal time duration and then remain maintained at that state. As before, the same broad range of strengths of the medication are still available for you to prescribe. And the other thing to remember is that you don't necessarily need to do any TSH testing when you switch from the old version to the new version. And the switch itself is pretty much straightforward. So thank you for your attention and participation. And I hope to look forward to meeting all of you personally at some point in the future. Thank you.
Thank you to Dr. Salman. for the pre-Congress symposium. We will now move to the main opening for the 2022 Emirates Thyroid Congress. Before I introduce the moderator for today, I'd like to thank the sponsors and the audience. We have almost 1,000 people registered. You will attain 9 CME for this course. You will see to submit questions on the live screen. There is a box on the right hand side. Please type your question and they will go directly to the moderators who will put them forth to the audience. And then you'll see a little tech support man in a yellow coat. You click that, you will go directly to our tech support team for any technical issues. I will now like to introduce bear with me. I would now like to introduce Dr. Eiman Seddeeqi, who's the staff endocrinologist at Shaik Khalifa Medical City, Abu Dhabi. She's assistant professor at the UAE University. She's president-elect of the Arab Thyroid Association. She completed the internal medicine residency program and a fellowship program in the endocrinology at the University of Toronto, Canada. She's board certified in internal medicine from the United States and Canada. And she has an endocrine fellowship certified from the United States and Canada. Dr. Eiman, the floor is yours.
Thank you, Gerard. And dear colleagues, a very good day. As a chairman of the Emirates Thyroid Congress, and on behalf of my colleagues, committee members, Dr. Irfan, Basha, and Dr. Yogesh, it gives me a great pleasure to welcome you to our 3rd annual Congress. During our Congress, 2 days program, we will be delivering a cutting-edge program where advances and recent discoveries in the field of thyroidology are highlighted. We will be also addressing special population category such as thyroid diseases in pediatrics and in pregnancy. Our program will feature plenaries, experts in the field panel discussions, case-based discussions, and local research work presentation. The Congress will focus in depth on thyroid neoplasm and functional disorders, as well as minimally invasive surgical procedures. All that will be brought to you by high-class leaders in the field of thyroidology in order to form a pleasant educational experience and an unforgettable experience that takes into consideration best evidence, technology, and experience. Without further ado, we shall enjoy our first session.
Hi, Dr. Eiman, can I take over?
Absolutely. Take over, please, Dr. Basha.
Okay. Thank you. It gives me great pleasure to introduce the first speaker. This is Professor Devendra Chowka, who's a surgical oncologist. He's a professor and the head of Division of Head and Neck Oncology in the Tata Memorial Center in Mumbai. He's also the officer in charge of the Homi Bhabha Cancer Hospital and Regional Cancer Center in Vizag. He's been instrumental in spreading the expertise and in reaching out to the cancer services to various parts of India. So they started units in Vizag, Chandigarh, Sangur. He's the secretary of the Foundation for Head and Neck Oncology. He's a national cancer registry coordinator. He's written many chapters in all head and neck, including the mouth, major salivary glands, total laryngectomies, laryngopharyngectomies. He's also written extensively on the pediatric thyroid cancers in India. He's got more than 100 publications. He's a very passionate cricketer. He's also a very well-known philanthropist. He does charity cancer missions in various parts of India. So can I welcome Dr. Chowka? The floor is yours.
I think Dr. Choker just got momentarily disconnected. I believe he's rejoining us now. Thank you.
Yep.
Dr. Choker, are you there? Dr. Choker, can you turn on your video and microphone, please?
Hi, sorry, give me a minute. I'll just be on. I'm just trying to share my screen. Oh, you can see my screen? Okay, great. All right, there's some problem. I lost connection temporarily. I couldn't get back. So I'm sorry for that. And I'll be on in a minute. Yes, I am. All right. You can see me now. I'm sorry for that. Just lost my connection and there were some problems connecting. So I would like to thank the organizers, my good friend Yogesh, for inviting me. And it's really an honor to be a part of this August panel and talk to all of you all today and learn from everybody. So it's great. So the first topic given to me is surgical challenges in management of medullary thyroid cancer. As we all know, medullary thyroid cancer is not a very common malignancy. It accounts for around 3 to 10% of thyroid malignancy. However, the prognosis lies somewhere in between well-differentiated thyroid cancer and poorly differentiated or anaplastic. So it's not as good as well-differentiated, but it's not as bad as the poorly differentiated or anaplastic thyroid cancer. Strictly speaking, these don't arise from the thyroid gland. They arise from the parafollicular C cells, which rest in the upper part of the thyroid lobe. They secrete various hormones, which are useful in diagnosis, prognostication, and as well as post-treatment surveillance. They present exactly the same way as well-differentiated thyroid cancer, solitary thyroid nodule, and sometimes with neck nodes. Locally advanced disease presents with hoarseness, dyspnea, dysphagia, and sometimes you have metastasis in 10% of the cases. Surgical challenges exist both, whether it is sporadic cancer or hereditary cancer, which is and the challenges in each one of them is slightly different. Evaluation is family history plays a very important role in management of medullary thyroid cancer. So you need to take family history very diligently. FNAC is usually diagnostic, as I said, because they secrete hormones and peptides. Calcitonin and CAA can be used for diagnosis as well as for follow-up. But sometimes good clinical examination will clinch the diagnosis, and sometimes the diagnosis is staring at you. So don't miss out the hyperpigmented pruritic lesions in the interscapular lesion, which points towards MEN2A, or the marfanoid habitus and mucosal neuromas, which will point towards MEN2B. So coming to today's discussion that was asked to be presented, the topic was surgical challenges in medullary thyroid cancer. And when I sat down to jot down what are the challenges that I face, the first thing that came to my mind was basic thyroid surgery. Surgery for thyroid cancer itself is a challenge. I'm very envious of people who can remove the thyroid, or surgeons who can remove the thyroid through remote access to the axilla, through the oral cavity. I'm still struggling with open surgery for thyroid cancer. But having said that, let's see what are the challenges we face with medullary thyroid cancer in particular. So I've divided this talk into the challenges that we face with regards to extent of surgery, extent of lymph node dissection, timing of surgery in familial. By that, I mean the timing of prophylactic surgery in relatives of people with having hereditary medullary thyroid cancer. We'll also look at what are the challenges for surgery for the primary disease when patients present with metastatic disease. I'll not be talking too much on pheochromo and hyperparathyroidism. That's not a part of this talk because I'm going to concentrate only on medullary thyroid cancer, but just touch upon that a little. Coming to the first part, the extent of surgery. As we all know, medullary thyroid cancer is different, has a different biology as compared to well-differentiated thyroid cancer. It does not concentrate radioactive iodine. It does not respond to thyroid suppression, and surgery is the only curative modality for medullary thyroid cancer. And that must be kept in mind when we go about treating medullary thyroid cancer. It presents with high incidence of lymph node metastasis, and it is multicentric. Well, not all are multicentric. The Knutson's two-hit hypothesis tells us that sporadic cancer are usually solitary and unifocal, while hereditary cancers, because of the germline mutation and the somatic mutation which transform these cells, these are usually multicentric and bilateral. And that is important when you're treating these tumors, because in hereditary cancers, as the genetic alteration affects the entire C cell system, these are usually multicentric and bilateral tumors. And hence, there is absolutely no debate in our minds that if it's a hereditary cancer, you need to do a total thyroidectomy. We'll talk about neck dissection a little later when I come to that. But clearly in hereditary cancer, if it is a proven hereditary cancer, you need to do a total thyroidectomy. In sporadic, on the other hand, they are multifocal in about 10 to 15% of the cases. And then the question comes to your mind is that why do a total thyroidectomy for 85% of patients who are not presenting with multicentric or bilateral disease? Can we do anything less? And this was first reported from this paper from Miyuchi's group, the same group from Japan who told us about observing subcentimetric papillary thyroid cancers. And they reported patients who underwent a hemithyroidectomy and were incidentally detected to have medullary thyroid cancer. So the FNAC diagnosis was not confirmed. They underwent a hemithyroidectomy and MTC was detected. They did not they did not rush in to do a completion thyroidectomy. They observed these patients because these patients were sporadic. They did not have huge metastatic disease, and the calcitonin had come back to normal. And when they observed them, all of these patients achieved biochemical cure. And that spurred them on to do a prospective study in patients with sporadic, unifocal, small medullary thyroid cancers. And they did a hemithyroidectomy in these patients with central compartment dissection, and they reported an excellent biochemical cure rate. And that's the language now that the ATA guideline is using, saying that implying rather that you need not rush in to do a total thyroidectomy in all cases of hemithyroid if it is incidentally detected. So if you incidentally detected medullary thyroid cancer, if it is small, it is unifocal, you're sure it is sporadic, and you're sure that the calcitonin has come back to normal, then there is a case in point to observe these patients diligently and not rush in to do a completion thyroidectomy. Now, having said that, this is just a debate. Whether the question is whether can we now open up a new avenue of debate. We have debated for a well-differentiated thyroid cancer all these years. We've not come to a solution yet, whether a hemi or a total is to be done. And now we are bored of that. So now we want to debate in medullary thyroid cancers. But the problem in medullary thyroid cancers is that when you operate a medullary thyroid cancer, most of the time you do not have the red report with you. More importantly, if the calcitonin is raised, you know this is aggressive disease. So for a unifocal small tumor with normal calcitonin, if you have the red report, there may be a case in point to do a hemithyroidectomy. But as of today, this still needs further evaluation for the study. As of today, for extent of surgery for the primary, total thyroidectomy is the way to go, be it sporadic or be it hereditary thyroid cancers. The next challenge in surgery is the extent of lymph node dissection. And we know that the metastatic rate is high for medullary thyroid cancer, both in the central compartment as well as the lateral compartment. And this rate increases as the size of the tumor increases. Of course, there is a stepwise metastatic pattern in thyroid cancers. It goes to the ipsilateral central compartment, then the lateral, then the contralateral central, and then the lateral compartment, mediastinum, and so on and so forth. Of course, you get skip metastasis as you get in well-differentiated cancer. Exactly the same, about the same percent, about 10%, you have skip metastasis to the lateral compartment. So how do you tackle these? How do you decide what extent of lymph node dissection are you going to do? The extent of lymph node dissection depends on location and size of the tumor, your imaging and clinical findings preoperatively, intraoperative assessment, and there are some reports or some people who base their extent of neck dissection on preoperative calcitonin levels, and we look at that. So let's look at what are the compartments that you need to clear in medullary thyroid cancer. And this Dral's classification tells us that the central compartment is level 1. It is divided into ipsilateral central 1A and contralateral central 1B. And that is where the dilemma, that is where the debate lies. For a small unifocal medullary thyroid cancer, are you going to do, when you call a central compartment, does it entail clearing both sides of the trachea, or does it entail clearing only the ipsilateral side? And we'll try to solve this debate a little bit later. Level 2 is ipsilateral lateral, level 3 is contralateral lateral, and level 4 is superior mediastinal nodes. Now, why is this debate? Why are we debating whether to do ipsilateral central or contralateral central? Of course, the recurrent laryngeal nerve is important, and you don't want to damage both nerves. But the more important problem is the parathyroid glands. If you see the guidelines, the clearance is from the level of the hyoid to the level of the brachiocephalic, from carotid to carotid. And if you're going to do such extensive dissection, even if you preserve the parathyroids, if you see and preserve the parathyroids, sometimes it may be very difficult to preserve the vascularity of the parathyroid, and that is one of the surgical challenges that you face when you're treating medullary thyroid cancer. And there's some who say that you need to remove all these 4 glands and reimplant it. Some say remove it only on the side of the disease and preserve it on the opposite side. The philosophy we follow is that if you closely look at your medullary thyroid cancers, all the medullary thyroid cancers that you've operated, majority of the nodes are below the inferior thyroid artery. This is true for not only medullary, but also for well-differentiated thyroid cancers. Yes, you have prelaryngeal nodes, you have pretracheal nodes, but the paratracheal nodes are majority of the times on the lower part. And therefore, you can always preserve or try to preserve both the superior parathyroid glands on the vascular pedicle. The inferior glands are the one which are at high risk, because when you're clearing the central compartment, sometimes you can cause vascular damage to the inferior parathyroids. So if you can see them very early in your surgery, take them laterally on their pedicle, well and good. But if you can't see them, or if you're going to damage, if you think you've damaged the vascular supply, then it's better to remove these parathyroid glands and reimplant it. As I said, some people base the extent of dissection based on the calcitonin levels. So if the calcitonin level is low, less than 20, they say that the incidence of metastasis is not high. As the calcitonin rises, the incidence of metastasis or the compartments that are involved are higher. So if it's up to 50, it is the ipsilateral, central, and lateral. The moment it goes beyond 50 up to 200, you need to address the contralateral central, the contralateral lateral about 200, so on and so forth, and mediastinal nodes above 500. It's not only calcitonin levels, but some people also have a combination or base their the same decision on a combination of calcitonin levels with the size of the thyroid nodule. So let's look at lateral neck dissection, and then we'll sum up what we do with neck dissection. Well, lateral neck dissection is not much of a debate, though ATA guidelines doesn't have clarity on the lateral neck dissection, but generally most people will say that you will observe the lateral neck if it is clinico-radiologically negative. Now, in practice, we don't do that, because when you have a positive node in the central compartment, the chances of having level 3 and 4 nodes are higher. So in my practice, at least, and we can debate this in the panel, we do clear central compartment and lateral compartment. Yes, you will base your decision a little bit on the aggressiveness of the disease that is at presentation. So what do we understand till now about neck dissection? Central metastasis is rare if the tumor is small, if you picked it up very early, but that's very rare. Less than a centimeter and calcitonin is less than 20, then you can do just a total thyroidectomy and just inspect the central compartment. In all other patients in medullary thyroid cancer, you must address the central compartment. There is no consensus on the lateral compartment by the ATA guidelines, and that is guided by imaging, preoperative clinical assessment, the calcitonin levels, and your intraoperative findings. Mediastinal nodes are cleared only if they're clinico-radiologically involved. So that's the guideline for mediastinal nodes. And of course, you must try and preserve the parathyroids. So what do you do? So how many people would do ipsilateral central versus a bilateral central? Well, in our practice, what we follow is that if the ipsilateral central is positive in medullary thyroid cancer, and we differ with well differentiated, and I'll come to that in my next talk. But in medullary thyroid cancer, we will do a bilateral central compartment if the ipsilateral central compartment is positive, because there are reports that calcitonin normalizes with extensive, the more the extensive dissection, the higher chances of a calcitonin coming back to normal, and that is one of the prognostic factors. And we can talk about this in the panel, but that's what we follow. If ipsilateral node is central compartment positive, we will dissect the contralateral central compartment in medullary thyroid cancers. Now let's look at the timing of surgery. And as I said, the timing of surgery, I will talk in relation with prophylactic surgery. Now, prophylactic surgery is to be done when the disease is not present, or you have to pick it up very early. And there are some guidelines or some criteria for doing prophylactic surgery. And medullary thyroid cancer, or the familial medullary thyroid cancer, fits into all of these criteria, or most of these criteria. There is a genetic mutation with complete penetrance. MTC is 100% penetrance. The diagnostic test to detect the mutation is great for medullary thyroid cancer. You can replace the function of this organ very easily. The only point that I can debate on is that the precancerous organ can be removed with minimal morbidity and virtually no mortality. Virtually no mortality is correct, but minimal morbidity is something that we need to debate on. And there is a reliable test to determine the postoperative cure, which we have calcitonin to determine that the patient has been cured. Now, depending on the codon that is mutated, the ATA has recommended classifying these tumors into highest risk, high risk, and moderate risk. They tell us about the aggressiveness, but they also tell us at what time you have to time the prophylactic surgery in relatives of these cancers. And again, this entire debate of what is the timing of surgery is because you do not want to operate very early. You do not want to operate children before 2 years of age. Their parathyroid glands are absolutely indistinguishable from the surrounding fat. They're translucent. The nerves are at risk because they're very small, and these nerves are you just touch the nerve and they can go into palsy. So it's very important that you delay the surgery as much as possible, and that is helped by these mutational analysis. Also, if you cause hypothyroidism too early and the replacement is not correct, then they can have developmental problems. So this is the debate. This is the challenge for prophylactic surgery, and there are clear-cut guidelines as to when you intervene in prophylactic surgery. So for the highest risk, you do it soon after birth. And the statement for central compartment that if you cannot see the parathyroids and the calcitonin is not very high, that means you've detected really early, or really it is prophylactic, then you do not do a central compartment dissection in these cases. For high-risk patients, you delay the surgery, you monitor the patient with ultrasound and calcitonin, delay the surgery a little bit, but do it before 5 years of age. And for a moderate risk patient, patients with mutation which categorize as the moderate risk, you can do it, you can follow up the patient after 5 years and delay the surgery till the patient is a little bit older and more confident on preserving the parathyroids and the recurrent laryngeal nerve. Next, surgical dilemma, and this is the dilemma I face in my practice very often, is what do you do for local treatment in patients who present to you with metastatic disease? Now, the aim in such patients is to reduce complications at the local site. You want to look at the life expectancy and then balance risk-benefit ratio, because you want to maintain the quality of life, try to preserve speech and swallowing for whatever length of time the patient has got left. So that's a very important thing to remember in managing patients with metastatic disease. Now, this is a recent paper which looks at primary tumor resection versus no resection for patients with distant metastasis. And this tells us that primary resection has a better outcome than no resection of the primary in patients with metastatic disease. So when you're treating medullary thyroid cancer with metastasis, first you have to see the extent and the number of distant metastases. If it is widely extensive metastatic disease and the primary is not going to cause much problems in the near future, then you do not need to do any surgery, and you can give the patient a systemic therapy. If the morbidity is going to be low at the primary and you have decent control of the metastatic disease is not progressing too fast, you achieve primary control to prevent local problems from occurring. So this is a very delicate balance. Very often you're forced with what to do in this case, but the philosophy that you should keep in mind is least morbidity at the primary site and expectant outcome depending on the site and the extent of metastatic disease. Last couple of slides on, as I said, I'm not going to go into FEO and hyperparathyroidism, but FEO is a challenge in managing because it is usually bilateral. Even if it doesn't present bilaterally, in the first 10 years, it does affect the opposite gland as well. And hyperparathyroidism is a challenge because you need to preserve some function, either preserve it on the vascular pedicle or resect it and reimplant it either in the forearm or the sternomastoid, depending on which mutation is present. But that's a talk by itself. So to conclude, surgical challenges in management of medullary thyroid cancer, in the extent of surgery, clearly total thyroidectomy is the way to go for medullary thyroid cancer. There is a school of thought and there is some evidence to say that a hemithyroidectomy may be sufficient in a certain subset of patients. But to do it upfront is a challenge because most of the time we do not have the red report and the we do not know whether it's unifocal or multifocal to begin with. The neck node dissection, again, the challenge is to do whether to do a ipsilateral central or the ipsilateral plus contralateral central, and you base the decision on the size of the nodule, the focality of the nodule, whether it's unifocal. The calcitonin preoperatively, if the calcitonin is very high, you know that the nodal burden is high, and the preoperative imaging. Parathyroid preservation is a bigger challenge in medullary thyroid cancer than I would say the recurrent laryngeal nerve. Recurrent laryngeal nerve is a problem for any thyroid cancer, but when you're going to clear bilateral central compartment, preserving the parathyroid is a big challenge. And prophylactic surgery at a younger age certainly needs to be done in experienced hands, and only a few people who routinely do this prophylactic surgery should operate on these patients. Thank you very much for your patient listening. I should stop sharing now.
Thank you, Dr. Chaukar. That was excellent. I'm sure we're going to come back to you with some more questions and discussions about this. So let's switch some gears. Let's go a little bit into the endocrinology. We're going to thyroid eye disease. So I'm going to give a brief introduction about Dr. Matthias Stan. He's a consultant in endocrinology at Mayo Clinic in Rochester. Since 2007, he's an associate professor in medicine. He's the current chair of the thyroid core group for the division of endocrinology at the Mayo Clinic. He combines clinical work with his clinical research. He's primarily working in the area of autoimmune thyroid diseases, specific interest in Graves' disease, thyroid eye disease, pre-tibial dermopathy. He's been a principal investigator, a co-investigator for a number of clinical trials targeting these disorders. He's a member of the ATA task force, focusing on the evaluation and the management of hyperthyroidism and thyroid eye disease. A separate area of research involves the management of toxic nodules through radiofrequency ablation. He's also involves benign, toxic, non-toxic nodules, as well as the malignancies. So I can see Dr. Murray is here. The floor is yours.
Thank you very much. I appreciate the invitation. I will initiate my presentation on systemic therapies for thyroid eye disease. So let me share my screen with you. Hopefully you can see my screen. Can you give me a confirmation on that?
Yes.
Very good. So thyroid eye disease is one of the areas that has witnessed significant developments over the last few years, both in understanding pathophysiology and also, fortunately, in having better therapeutic tools. So in order to get to that discussion, I want to put forward my disclosures, and not only the financial disclosures, but also the fact that I'll be talking about the use of tocilizumab, which is non-FDA approved for the use in thyroid eye disease, but it's available for rheumatoid arthritis. And I want to make very clear the point that there are many terms that we use for the same disease. So Graves' ophthalmopathy, thyroid-associated orbitopathy, Graves' orbitopathy, or thyroid eye disease, it is one and the same entity. And hopefully most of the time you'll see just TED or thyroid eye disease on my slides, but sometimes GO might slip up. The objectives will go over briefly the pathophysiology that has allowed the current developments, and then standard of care will also be touched upon briefly, and the emphasis mainly will be on the new drugs that are making a difference in this field and few trials that are upcoming. Thyroid eye disease is a very heterogeneous disease, not a monolithic one. And here are pictures of few of my patients. You get a sense of the inflammation, you get a sense of the proptosis, you get a sense of the difficulty that these patients have handling just plain light because of the increased palpebral aperture. The distance between eyelids allows for so much light to enter the eye that it's uncomfortable. You see the significant eyelid swelling, and then in the inactive stages of the disease, we see the extraocular muscles being so fibrotic and scarred that it doesn't allow for normal position of the globes. You see the pulled globe on the right as well as the deviation on the left. So what we know about the disease is, as many of you know, is that it follows a pattern that was described first by William Randall about 60 or 70 years ago now, in which the early phase of the disease is an inflammatory one, and with time that resolves, but scars are left for the long run as we have many patients in the static phase. And as you see in that phase, we're not back to the baseline, but there's still a significant difference in how patients look when the disease has quieted down versus when it started. And this will be a reflection of these two phases. What you see on the left is obvious to all of us: active inflammation, the redness, the swelling, and we can also imagine the pain for this individual dealing with such a focal area of inflammation. And then months or sometimes years later, we have this fibrotic change that leads to the retracted eyelids, leads to the proptotic eyes, and a lot of difficulties in day-to-day, both practical functioning, but also social functioning related to appearance. What is the mechanism that is behind all this? And this is what has been better understood over the last 5 to 10 years. We were speculating for quite a while that the TSH receptor on the orbital fibroblast, which you see depicted here, the orbital fibroblast is the target cell for this disease as far as we know it. And it does have TSH receptors, which are definitely stimulated by the TSH receptor antibodies. But what we've learned is that the IGF-1 receptor is actually in close proximity to the TSH receptor. And once the TSH receptor has been activated, the IGF-1 receptor is augmenting the response. We do not think that there is an IGF-1 receptor autoantibody, but rather that there is a cross-link between these two receptors that really augments the response at the intracellular level, which basically leads to two pathways through translocation of mTOR and the nucleus then starting to transcribe a number of adipogenesis-related genes. So the orbital fibroblasts transform into these large adipocytes that fill the space much faster, as well as the other pathway, synthesis of what you see here as glycosaminoglycans. Most of the time it's just hyaluronic acid, and that leads to an orbit that schematically has bigger muscles and a lot more fat, and everything pushes the globes forward and makes the muscles dysfunctional. If one were to obtain CAT scans of the orbit, and I depict here a few models, These are obviously axial images, the globes as you see them here. And I inserted this image as a normal image for reference. You see the extra, and maybe I have two screens, so forgive me if my mouse was not there. Here, this is the normal appearance of the orbit. So you have the extraocular muscles that are normal in this individual. The dark areas is the intraorbital fat. And what I want you to see by contrast is what happens in a patient with thyroid eye disease, this generous, very significantly enlarged muscles that are compressing the optic nerve, which has to squeeze through this space here, and obviously associated with extraocular muscle dysfunction, which means double vision, as well as possible optic neuropathy. The other end of the spectrum in the pathophysiology is significant enlargement of the intraorbital fat, with maybe a little bit of muscle enlargement, but the main component here is fat with significant proptosis. Standard geotherapy, as many of us know, geo, again, remember that thyroid eye disease is what we're about when we say geo. Basically, local therapy, lubrication, sunglasses, these are well known to all of us. The use of selenium has some benefit in mild thyroid eye disease. The biggest workhorse over the decades past has been the use of intravenous steroids, able to cool down the inflammation, but unfortunately not a long-term solution. I would say about 30 to 40% of patients that respond to IV steroids will have a relapse in the next 6 months. Radiation therapy is occasionally used at some centers, and then when the disease becomes quiescent, surgery in the form of orbital decompression, first strabismus surgery, which means eye muscles modification, and at the very end, repositioning the eyelids for normal appearance. 3 years ago now, we looked at all the agents that have been at one point or another tested on thyroid eye disease. And the point of this slide is not to discuss all of them in detail, but just to show you that 3 years ago, we were counting 14 such agents that had either nothing or some response in thyroid eye disease. And if I were to update this slide today, or the cartoon, this was published at that point, it would be easily at 19. So very fastly progressing field in developing new therapeutic agents, or at least testing them. What is the newest kid on the block that I think we should focus on our attention on? I think the IGF-1 receptor blockade becomes obvious to all of us after we looked at the slide on pathophysiology. The TSHR receptor is synergistically coupled with the IGF-1 receptor. So we do have an IGF-1 receptor blocker called teprotumumab, and this agent made it through 2 clinical trials, which led to its FDA approval for thyroid eye disease in February a couple years ago, 2 years ago. The commercial name, as you see it here, Tepezza in the United States. This is the data from the first clinical trial. And the way to look at these multiple graphs is to understand that their main outcome was improvement in proptosis. So changes in proptosis are on the y-axis here, and this is improvement in negative, as in the eye reverting back into the orbit, measured in millimeters. The lighter line depicts the placebo group, which was about 40 patients, and a similar size group received teprotumumab. So we see an improvement in placebo. So the eyes returning back into the orbit by about 3 millimeters. It was good to see that this was also accompanied by improvement in inflammation. That's what clinical activity score reflects. And again, we see a change in inflammation of 4 points on a scale of 0 to 7. So this is of significant magnitude. And a couple other details that I think are worthwhile mentioning. Quality of life depicted in these 2 graphs here significantly improved both in the functioning scale as well as in the appearance scale. These patients are impaired just in their social interactions. They have a sense that people are constantly staring at their eyes, and they feel quite uncomfortable, understandably so. After that first trial, which I will show to you, was published in New England Journal in 2017, the group of investigators went on with a larger trial that was meant to consolidate the findings of the first. And this second trial was also published in New England Journal a month before FDA granted the approval for this drug. And it was very rewarding, both for investigators and for the rest of us involved in the field, to see that indeed these results were not a fluke, but they were sustained. And how to look at these graphs. Here they set a minimum cutoff point of improvement in proptosis of at least 2 millimeters, which is clinically significant. And 83% of the patients in teprotumumab, this is the darker line, that is the active intervention, as opposed to just 10% of patients in the placebo, reached that goal. So at least 2 millimeters improvement. And what you see on average, the teprotumumab group had more than 3 millimeters improvement in proptosis. I will take a quick sip of water. It's very dry here in Rochester, Minnesota. And to go on with our response, again, the aspect of inflammation was measured, clinical activity score of 0 or 1, that is almost no presence of inflammation. 2/3 of patients were at that phase at the end of the trial. And then again, replicating improvement in clinical, in the quality of life measured through this GO-QOL. It's a standardized instrument, and we're seeing the teprotumumab significantly higher benefit in regarding to quality of life compared to placebo, which is about a flat line here from baseline to the end. In this area, clearly a picture is worth 1,000 words. So I want you to focus your attention on the top images first and realize that we're having the same individual before the trial, and we're seeing the significant proptosis, the eyes being pushed forward, right? We're seeing the lid edema. We're seeing significant conjunctival injection. And 6 months later, we have a nice resolution of most of these features. What the bottom two pictures are meant to reflect, and these are MRIs, coronal sections through the orbit. What we see highlighted here with the arrowheads are the extraocular muscles. So this is the inferior rectus muscle. Typically, the inferior and the medial recti are the most inflamed in this disease. And what we see at baseline and what we see 6 months later are certainly reflecting an improvement, a decrease in the volume of these muscles, which it's certainly rewarding and helpful to patients, both function, but also proptosis and appearance. The arrow here is meant to indicate to us that the fat in the orbit was significantly larger before than after therapy. I'm not that convinced that these images clearly reflect that, but I certainly see the improvement in extraocular muscle volume. What we have on this is obviously the important aspect of how is the overall body system taking the blockade of IGF-1 receptor. We all know that this is an important pathway for many physiological processes. So is it okay to block it? Is it okay to go for 6 months? Some of the side effects that are reported here are certainly mild. And muscle spasms, I will say, I see this with more than 50% actually of patients treated with teprotumumab. Fatigue, fortunately, is less common, probably 10% as they reported in the trial. Rarely do I hear patients complain of altered taste, which was brought up by the investigators. But the bigger concerns have to do with changes in glucose values. Hyperglycemia, certainly a problem, particularly in patients with pre-existing diabetes or with history of pre-diabetes or gestational diabetes. So it's important to establish the baseline for these patients. It's important to monitor during therapy and adjust their treatment, which sometimes require conversion to insulin. And then at the conclusion of the treatment, hopefully be able to revert to their pre-therapy regimen. Somewhat unexpected development has been the change in hearing that's reported by a number of patients. Initially in the trials, it was listed at 10%. I think it is higher than this, but it's not significantly impacting patients' day-to-day activities. So many of them will bring this up only if asked, as the hearing might be a bit muffled. And it is not clear yet how much of that persists long-term. It seems that in the vast majority of patients, this reverts at the end of the trial, but this is an area that is under current investigation. Logistically, what we should all keep in mind is that this drug starts with a high cost, at least on our market. So it's very important for us to have an understanding of the patient's insurance willingness to support the patient through the trial. As I said, it's important also to monitor for the two potential side effects. So therefore, I always test the glucose and an A1C before initiating therapy. And I discuss with the patient about their hearing. If that is altered at baseline, I will obtain an audiogram to have as a reference point later on. Once we start treatment, we're embarking on 6 months of therapy. These are infusions, intravenous, every 3 weeks. So we need to have a reliable infusion center, and the patient needs to be available every 3 weeks for continuing therapy. And then I tend to bring them on after the third infusion to assess the response clinically, because if there is a response, it tends to be a rather early on. And given the burden on patient, the system overall, if there's no response after the first 4 or 5 infusions, I'm not convinced that it's worth to continue with the rest of the treatment. It is a drug that has generated a lot of enthusiasm, and I certainly feel that it helps a number of patients. I have particularly seen significant responses in proptosis and in inflammation, less so in the double vision that was also reported in the trials. But just as a sign of how appealing this drug is to clinical researchers, since it was open for use in the United States, and that was, I think it was made available in early March of 2020. I did a PubMed search on the date here, September of last year. There were already 101 publications on PubMed on this combination, teprotumumab and thyroid eye disease. And you see that they go in different directions. The drug was tested only in patients that had eye disease for less than 10 months. People started to treat patients beyond 9 months of thyroid eye disease. It was only tested in patients with active disease. And then the investigators wonder, is it worthwhile using in inactive disease? Questions about use in dysthyroid optic neuropathy, so compressive optic neuropathy, as well as what is the impact on inflammatory bowel disease? I'll make it clear, it's contraindicated for those patients. And is it helpful in asymmetric thyroid disease? That's something that I think the answer is yes, but we need more data there. So based on the data that I presented to you, the authors of the second publication concluded that teprotumumab in patients with active thyroid disease, and again, of recent onset, that means less than 9 months, teprotumumab was better in regard to improving proptosis, improving inflammation, double vision, and quality of life by comparison with placebo. And their conclusion was that the side effects were not a major drawback. My take after using this drug for the last 1.5 to 2 years, I think that this patient is indeed effective in patients with active disease, and I would offer it if they have at least moderate severity in their proptosis that would at some point likely lead to orbital decompression surgery, and it already affects their daily functioning. If I see this combination of factors, I think this drug is a right choice if the side effects are not a major concern. The second drug that I briefly want to touch upon is the tocilizumab. This is an interleukin-6 receptor blocker, monoclonal antibody. This was brought on the clinical scene by a group from Spain, Perez Moreiras, and you can see what they reported on an open label series of 18 patients. Significant improvement in proptosis, improvement in inflammation by 6 out of 7 points, double vision improved, and the antibodies against the TSH receptor decreased by 3/4. And the cherry on top, there were no side effects. So this is almost the ideal drug that we would want for this disease. But due diligence requires that we go from open label series, obviously, to a randomized and double blind clinical trial, which these investigators did. This is the result of an 8 centers in Spain reported few years back. And these trials typically bring us back to reality, which is what this did as well. I'll highlight here the improvement in proptosis, which was their main goal, was just 1.5 millimeters compared to placebo. But fortunately, this was a sustained response from 16 weeks when the treatment ended to the 40 weeks when the observation phase ended. And on the last couple of minutes, I want to bring to your attention agents that we might be seeing at a theater near you, as the adage goes, but basically agents that are making their way through clinical trials currently. So K170 is what's depicted here, this shuttle-looking structure that it's about to dock on the TSH receptor is the monoclonal antibody called K170 that is able to block any signaling through the TSH receptor, or most of the signaling. This has some preliminary data on an open label series, and I'm expecting that the team of investigators, which is based in UK, will bring this to a double-blind, placebo-controlled clinical trial in the near future. The second agent that likely will be discussed in the coming years is batoclimab. This is an FcRn monoclonal antibody against the FcRn protein. It is meant to shorten the half-life of IgG, particularly IgG1, which is the type of IgG that the TSH receptor antibodies are part of. So by decreasing the IgG, implicitly the TSH receptor antibodies will decline, and the expectation is that that will lead to an improvement in thyroid eye disease and probably Graves' disease. It had a setback on a trial that was stopped early last year in that it induced hypercholesterolemia. So now there is a revamped trial plan, and hopefully this will be brought back later this year. Then there are small molecule antagonists to the TSH receptors, which will thus block any signaling from the antibodies to the intracellular milieu. And then there are at least 3, I think, IGF-1 receptor blockers independent of teprotumumab that are trying to make their way forward also. So to summarize what we discussed, we've discussed that there is a significant role for the IGF-1 receptor in thyroid eye disease pathophysiology, and the activation of this receptor is tied to that of the TSHR. Step forward from that is that teprotumumab, an IGF-1 receptor blocker, is a good treatment choice that is trying to find its proper position in the management of thyroid eye disease. Clearly, there's evidence for efficacy. Certainly, we need to be mindful of its safety impact, and it will be an interesting discussion what role the economic factors will play in selecting various drugs in managing thyroid eye disease. I discussed briefly that tocilizumab, an interleukin-6 receptor blocker, is potentially useful. It is certainly available, but the data is more limited than with teprotumumab, and I'm happy that this field has the potential to expand rapidly with new drugs which are currently being tested for thyroid eye disease and likely for Graves' disease as well. I want to thank you for your attention, leave you with this image of the Mayo brothers in front of Mayo Clinic, and I look forward to your questions, probably through a conversation by email, since I will not be available later this afternoon for you, morning for me. Thank you.
Thank you very much. That was very, very interesting. I'm sure we will be in touch on the email. We do some cases, both in terms of medial and lateral decompressions. I'm an ENT surgeon, so I prefer to do the medial test. We did have an oculoplastic surgeon who was doing the lateral ones, but thank you for leaving your email, and have a good day.
We'll be happy to communicate later. Thank you for the invitation to present. A good day to you all.
Thank you. Right. So moving on, let's switch gears again. So now we'll be going into a little more of surgery again. So may I introduce and invite our next speaker, Professor Gregory Randolph. He's a professor of otolaryngology and a Claire and John Bertucciani Endo Chair in the Thyroid Surgical Oncology at Harvard Medical School, and surgeon at Mass Eye and Ear Infirmary. He's trained at Cornell and Harvard Medical Schools. He served as the director of General Otolaryngology Division and founded and directs the Division of Thyroid and Parathyroid Surgery. Dr. Randolph has a thyroid and parathyroid surgical practice. He sees patients and operates both in Mass Eye and Ear Infirmary and the Mass General Hospital. He is focused the bulk of his research on recurrent laryngeal nerve anatomy, and preservation and monitoring during thyroid cancer surgery, focus on the importance of laryngeal examination, recognition of lymph node metastases, and revision cancer surgery. He has more than 250 peer-reviewed publications. He has led thyroid and surgical missions to thyroid surgical regions and units in Russia and St. Petersburg, in Guangzhou, China, Kenya, rural India, in the Chernobyl region of Ukraine. As a founding steering committee member of the World Cancer on Thyroid Cancer, he is co-chaired 2017 and he co-chairs the 2021 World Congress. He founded and directs the Harvard Thyroid and Parathyroid Surgical courses for surgeons and directed international surgical courses in Italy, India, Germany, Switzerland, Russia. He's received board certification from European Union's Board of Surgery and Neck and Endocrine Surgery. He has published his famous books on surgery of thyroid, parathyroid glands, and also recurrent and superior laryngeal nerves. He's the director of International Affairs of American Academy of Otolaryngology and Head and Neck Surgery. He served on the board of directors as the academic's president. He served as a treasurer on the executive board of the American Thyroid Association. He currently serves as the chair of the Endocrine Surgery Committee, surgical liaison of the American Association of Clinical Endocrinology. He's the chair-elect of Endocrine Surgical Section of American Head and Neck Society and board of directors of International Thyroid Oncology Group. He is the founder member, along with Dr. Henning from Germany, as a global international neural monitoring study group, which is generally looking at publication and standards and guidelines for nerve monitoring in thyroid surgery. He's now serving as the president-elect of the International Thyroid Oncology Group, which is a global group of renowned medical oncologists and endocrinologists focused on the basic research and the clinical trials for advanced thyroid cancer. So can I invite Dr. Moore?
Hello, everyone. I'm Greg Randolph. I would like to welcome you to the Emirates Thyroid Virtual Congress 2021. I want to thank Dr. Seddeeqi and Basha. And hello, everyone. I'm Greg Randolph. I would like to welcome you to the Emirates Thyroid Virtual Congress 2021. I want to thank Dr. Seddeeqi and Basha and more for their kind invitation for this presentation. I'm Greg Randolph. I'm at Harvard Medical School and the Claire and John Bertucci Endowed Chair in Thyroid Surgical Oncology here in Boston. And I would like to present a topic on a surgical approach to advanced thyroid cancer. I have no relevant disclosures other than funding for an ASI research trial that we're conducting here for advanced thyroid cancer. So one of the issues that we have here with aggressive disease is that we kind of know it when we see it. So for example, there are many different flavors of it, though. Here is an example of a young male, 12-year-old male with a RET fusion medullary carcinoma with tracheal compression. Here is this patient, same patient with lung metastasis. So most would agree this is aggressive disease. We have a different variant, though. Here we have another example of advanced disease, a 77-year-old female with a hobnail variant of PTC with very aggressive lateral neck disease, which required actually spinal accessory, jugular vein, vagus resection as part of her treatment. This is a different version of aggressive disease. This is a 26-year-old with an aggressive CCD-C6 RET fusion PTC. It's kind of a solid variant, fusion-driven PTC. And this was adherent to the vertebral artery when she presented. So this is another flavor, many flavors of aggressive disease. This is that same patient. So you kind of know it when you see it, but there are many different definitions. Here's another example of aggressive disease. You see the incision on her neck. She had received about multiple previous surgeries. She had received about 600 millicurie of RAI and now has skin involvement. So here is her CAT scanning. This is, again, recurrent disease that is aggressive, bulky disease extending to the mediastinum and requiring skin excision. So many flavors of aggressive disease. So what is actually the definition? Well, the Head and Neck Society just recently has had accepted for publication in the journal Head and Neck, which will be out soon, kind of an attempt to provide some guidance as to the definitions of aggressive disease. This was an author panel that was comprised of surgeons, otolaryngologists, and endocrinologists, and a very significant input of medical oncologists in the advanced thyroid cancer space. And we did a modified Delphi process to work through the different definitions of advanced disease and made a number of different recommendations. And here are some of the basic categories. We had something like 13 different definitions of advanced disease relating to the different domains of structural surgical advanced disease, biochemically advanced disease, histological molecular definitions of advanced disease, or clinical prerogative to the treating physician. And then basically made recommendations as to, for each of these definitions of advanced cancer, that molecular testing, NGS testing, is required now in order to optimize the clinician's ability to manage that advanced disease. And so we provided algorithms for that NGS or focused testing in those patients so defined with advanced disease. Because each of these targeted abnormalities that can be identified commonly in advanced disease has its own targeted therapeutics that are available. And so we've summarized in this chart for this, in this paper, the options that would be available given certain molecular lesions identified. So there are many other advanced disease guidelines. Mazie Shindo, a number of years ago, wrote for the Head and Neck Society a very excellent paper looking at the consensus management for invasion of a variety of different structures that may occur in the setting of advanced disease. And Akis has written a similar guideline statement from the Head and Neck Society on the application of radiotherapy, external beam, infrequently used in general for cancer, thyroid cancer, but used not uncommonly for more advanced settings. And then looking at the International Neuromonitoring Study Group guidelines, which weigh in on the management of advanced disease, especially as it relates to the common occurrence in advanced disease of recurrent laryngeal nerve invasion. And this paper I would recommend to all was written as a supplement in Laryngoscope, looks at the laryngeal invasion, intraoperative proximal EMG data, and non-surgical treatment options that are available that are all taken into account when one construes an optimal plan for recurrent laryngeal nerve invasion found in advanced thyroid cancer. This specific paper, which again is a supplement in Laryngoscope in 2018, looks at preoperative parameters that allow you to identify preoperatively through clinical laryngeal and radiographic data sets what patients are presenting with advanced disease. It provides algorithms for elements to consider to optimize your management of the invaded nerve, which is associated with normal cord function, which is quite common. About 45% of nerves that are found invaded at surgery have preoperatively normal function. It also provides algorithms looking at the invaded nerve management options when presenting with the invaded nerve being paralyzed, which is about 55% of invaded nerves. And then the not uncommon, unfortunately, but worrisome scenario of invasion found on an only functioning nerve, and considerations that can be that can optimize your care of the patient in that unfortunate advanced disease setting. This is the Laryngoscope supplement that reviews these options. So one of the facets that I wanted to talk about is aggressive disease often is disease that recurs. And so let's talk a little bit about what you do when disease as a surgeon recurs. And for revision surgery, I really want to talk about the importance of the preoperative kind of forensic analysis of the neck prior to consideration for revision surgery, and then talk about some of our experience here at Harvard for a management of recurrent PTC nodal disease. So first, the focus of the targeting of surgery for recurrent disease is really all about the concept of a clinically apparent nodal disease. That is that which can be identified as abnormal radiographically and routinely identified at surgery as abnormal or suspicious. And so really it's all about the ability to have disease mature to the point where it can be identified as targetable disease that can be localized in the neck by a combined ultrasound and axial CT scanning map that allows you then to map out the nodal disease and adequately address it surgically. This relates to, in turn, the ATA 2015 guidelines that discusses the importance, of course, recommendation 32 of cervical ultrasound, but also a move by the ATA towards CT scanning with contrast. Recommendation 33 in the 2015 guidelines recommends a much more pendulum swing towards low threshold for axial CT scanning to add to the ultrasound in terms of providing an adequate nodal map. And this is really when there's significant nodal disease. So CAT scan is repeatable. CAT scan shows the entire neck. It is repeatable, it sees all areas, and it can also provide information in primary thyroid cancer surgery for the thyroid primary. It provides, axial CT scanning provides definitive relationship to the nodal disease as it relates to the thoracic inlet vasculature, and exact relationship, exact position of that nodal disease within the mediastinum. Both of those information sets are really not available with ultrasound. It provides really ability to in a granular way, identify the exact nodal location within the central neck. And it really, when you are repetitively looking at CAT scans for recurrent disease, it can provide really a forensic analysis. For example, it can give you information as to whether this is a disease in recurrent nodes or is it disease in a remnant of thyroid tissue that was left. So here's an example of a 45-year-old female where disease was found in this free-floating little circular node in the central neck fat, and this was found to be recurrent nodal disease. And this is in contradistinction to this individual who had recurrent PTC in the central neck. But here you see this disease is not round, it is contained within what looks like thyroid tissue hugging the undersurface of the right cricoid cartilage. So this is disease, still PTC on needle, but this is disease that is contained within a remnant. And this is an entirely different surgical exercise in its resection. This is typically disease that is left by the first surgeon with intention because they felt that the nerve would need to be sacrificed in order to have it adequately excised at first surgery. That's common when disease is found in a recurrent setting in a remnant. And so you need to counsel the patient that the nerve may well need to be resected. And that was, this is the path report of that CAT scan finding that this is disease that is contained within a remnant of thyroid tissue. That is a very different and more morbid undertaking in the revision setting. And you can determine that by the subtle details of the morphology of the recurrence in the central neck. It is true that if contrast is used, you do need to communicate to the endocrinologist if RAI is being considered, that there is an appropriate delay that is necessary. Many of these patients with recurrent disease that I will discuss are no longer radioactive iodine avid, and so the issue is moot for many of these patients, but good communication from surgery so that surgery explains to endocrinology what you needed, the date of that contrast enhanced CAT scan, so that you can they can be aware of exactly when that iodine load was given. So basically with this ultrasound and CT scan map, we look at the neck. This is how I think of the 4 compartments of the central neck and the 2 compartments of the lateral neck. This, of course, does not include retropharyngeal or other ectopic sites, which rarely are present. And then with your ultrasound and CT scan, you determine exactly where those recurrent nodes are, and then you can arrange for surgery that targets them and does not impact on the compartments not affected. In terms of revision thyroid cancer surgery, the recurrent nodes, there are size limits that have been offered by the ATA, and we wrote this with an understanding that 8 and 10 millimeters in the central and lateral neck respectively are the lowest size limit, which can be mapped out accurately on a combined ultrasound and CT scan map. It is of note, though, that we definitely put in that not every patient with 8 or 10 millimeter disease requires surgical resection. You can find it in general at that level, but you may not need in the overarching clinical setting to operate on that patient with a number of different parameters that are important to be considered before you move forward with revision surgery. Our most recent update on revision surgery here in just about 239 patients over 16 years. First point I want to make is in this patient population of revision thyroid cancer surgery patients that we've operated on, they present as a fairly morbid group. Prior to your revision surgery, 10% have vocal cord paralysis, 12% are permanently hypopara. So these patients have already been through 1 or more surgeries that was morbid and are presenting to you with significant comorbidity due to their cancer and the surgical treatment of it prior to you even reoperating on them. This is the landscape of the patients that we have operated on, nearly 240 patients, with 66% of them, our revision surgery being the first revision surgery, that is their second surgery, but about a third had anywhere from 2 to 7 past thyroid surgeries. Our surgical outcomes from the vocal cord paralysis point of view are quite favorable, and this is, I believe, referable to our meticulous technique and use of neural monitoring during these cases. But note that new onset, permanent hypoparathyroidism will occur in about 5% of these patients. So if they already have limited parathyroid function as they present to you, with almost 12% being permanently hypopara when they walk in your door for the first time for revision, consideration for revision surgery. These are patients with limited parathyroid reserve. You go and operate on their central neck and take out tissue, you are going to be rendering them permanently hypopara about 5% of the time. However, there is some efficacy in the biochemical determination of success. That is, if a stimulated thyroid globulin is undetectable post-op, this occurs in about a third of these patients. Beware the statistics of how that relates to first, second, or greater than 3 surgeries, because the number of patients in each of those subcategories is small. But overall, in these patients, about a third are rendered cured with a stimulated biochemical definition. And this is that data, again, separated into their pre-op versus their post-op TG levels. All of these cases are done with neural monitoring. All of these cases are done with a lateral approach where the SCM is reflected from hyoid to clavicle, and the carotid sheath is dissected in that interval. The vagus is stimulated, and the vagal nerve and the stimulation of the nerve system is set up and working based on vagal stimulation as you approach the central neck. Then the lateral margin of the ipsilateral strap muscles are dissected, and they are retracted, as is shown here, as one would retract a thyroid lobe during thyroidectomy. And this exposes the rectangular shaped central neck, paratracheal region, or in this circumstance, left region 6, also called the thyroid bed and paratracheal region, and reveals, then you can overlay to that rectangle the surgical map that you have for nodal disease, as is shown here, and then go ahead and preserve the nerve and excise the nodal disease that you need to do. Some central neck revision surgery tips. Loops, I feel, are essential. It is really important to keep the field completely blood-free so that the planes are not stained. The bipolar cautery, a fine-tip jeweler's bitip cautery, is essential in that regard. You can start higher or lower than the previous surgeon's operation. And so in that way, you find the nerve in a relatively undissected plane and then dissect it through the past surgeon's scar. Keep in mind that almost every surgeon dissects that last 1 centimeter of RLN, and so that is almost uniformly quite scarred to the thyroid bed in that interval. And then, of course, for the RLN, it's very sensitive to stretch injury, and so you really don't want to dissect it off its bed if at all possible. You certainly would not want to retract it aggressively or place hooks on it. In terms of my Mayo stand for my surgery, the 2 red indicated boxes are my 2 favorite instruments or tools. One is the fine-tip jeweler's bipolar cautery that I've shown previously, and the other one is a neurosurgical pledget soaked with saline diluted epinephrine, and this provides hemostasis to the bed when there's minor oozing, and is a very helpful adjunct to keep the plane dry so that you can identify exactly where the bleeders are. In terms of general indications, the first thing is revision surgery can be morbid, so do you really need to operate on this patient? Not all thyroid cancer nodal recurrences require surgery. And also you have to make sure, do you feel comfortable doing this? Not all surgeons who perform thyroid or parathyroid surgery necessarily are comfortable with performing revision thyroid nodal surgery. And so once the surgical indication is real, you need to forensically evaluate the patient's past history. Operative note and path reports need to be examined. And you can speculate as to the degree of scarring often by looking at the details of the past operative and path reports. For example, if there is strap muscle resection at the previous surgery, or neck base combined with sternal work, or past history of external beam radiation, this will be a very scarred, complicated surgical field. Of course, you need to be assessing the larynx and the status of the parathyroids, and as I said, ultrasound and CT scan mapping. So here's an example of a patient, morbidly obese, extensive past surgery. That past neck surgery was combined with sternal work. This will complicate especially the venous anatomy of the mediastinum and neck base in a very significant way. Just some general guidelines as to things that are permissive for central neck revision surgery: lesions that are large, lesions that have shown evidence of progression, lesions that are localized well on ultrasound and CT scan. Things that are relative red lights are very, very small lesions, lesions that are stable, lesions that cannot be localized well on ultrasound or CT scan, or lesions on an only functioning nerve. Doesn't mean you don't operate in all of those settings, but you operate with caution. The several new tools now and that apply to the advanced disease space, and with this research relates to many different groups in my unit, my own research group, our residents, our fellows, and a variety of multidisciplinary colleagues who work with us on all of this research activity. And I want to focus now on a future tool which is now in a clinical trial here, that is the utilization of the lenvatinib, a tyrosine kinase inhibitor, and combining that with surgery, that is using lenvatinib in a neoadjuvant setting. So this is a phase 2 study, which is open at Mass General, Mass Eye and Ear, and will be opening later this year at MSK, Memorial Sloan Kettering, and MD Anderson. Why is this important? Well, invasive disease is occurring in up to 15% of DTC patients. It involves strap, RLN, trachea, and esophagus in the percentages shown here. We've talked about the identification of advanced disease, and we've talked about the surgery for invasive disease is meaningful because the surgery is more complex, the surgical morbidity is higher with extrathyroidal extension, and the quality of life of the patient is affected by that disease and its surgical treatment. We have limited information available on R0 rates after advanced thyroid cancer surgery, mainly because of the varying disease definitions that are utilized. We have here 2 papers, one newer and one older, suggesting, again, with that vagary of what is the definition of advanced disease, suggesting that R0 rates, gross disease clearance, is low in advanced thyroid cancer disease. And so we want to consider neoadjuvant therapy because it is may provide more oncologically secure margins and potentially less morbid, less aggressive surgery even. So this phase 2 study was born out of an understanding that there has been some neoadjuvant experience, at least in the past, with cytotoxic therapy prior to advanced thyroid cancer surgery, implying that R0 rates perhaps are higher with cytotoxic therapy. There is no TKI neoadjuvant therapy available in the modern advanced thyroid cancer space, but it has been used. That is, TKIs have been used as a neoadjuvant option for cytoreductive nephrectomy and renal cell cancer, and has also been applied to pancreatic, advanced pancreatic cancer. To refresh our memory, lenvatinib is a multiple tyrosine kinase inhibitor with VEGF activity. This is the pattern of inhibition on the human kinome of lenvatinib, shown in comparison to sorafenib. This study was born, this clinical trial of neoadjuvant application of Lenvatinib was born out of Schlumberger's SELECT trial, which was a 2-to-1 randomization of Lenvatinib versus placebo for advanced metastatic, distant metastatic Lenvatinib. And this showed a overall progression progression-free survival period expansion from 18 months as compared to 3.6 months with placebo. The overall response rate was 65%, and that is primarily by 63% having partial responses, which imply a 30% volumetric reduction. So the idea is, with that kind of benefit with metastatic disease in the lung, how can we apply Lenvatinib to the preoperative setting, where we would very much like to have a retreat of 30% or more in the majority of patients prior to surgery. It is with an understanding further that the SELECT trial has shown that Lenvatinib obtains that partial response within the first 2 months of treatment. There are side effects, but it turns out that in the SELECT trial, only 14% of patients required discontinuation of Lenvatinib because of the side effects. And so this is a phase 2 open label study. We intend to enroll 30 patients. We've enrolled 6 so far. Lenvatinib is given at 2, 4, or 6 cycles, and then the patient is radiographically reassessed to determine whether adequate surgery can be performed. The primary outcome is to look at R0, R1 rate versus R2, and a variety of stratification of that margin analysis at the different interfaces that extrathyroidal disease may have in a given patient. And so this is enrolling patients currently at MSK and Mass General, and we'll be opening at Memorial and MD Anderson later this year. I just want to give you a couple of examples in ending, looking at neoadjuvant Lenvatinib. This is a 50-year-old male looking at his initial morbidity scale. This is a numeric that relates to the degree of advanced disease, the degree of surgical complexity, the degree of potential morbidity of that particular pattern of disease. The total score potentially possible is 34. This patient presented with a score preoperatively of 22. This is his initial scan. The radiologist called invasion into the trachea, esophagus, and prevertebral fascia. This is his post-treatment scan showing a much contracted kind of pushing margin cancer. And he obtained an R0 resection. His MMM score went from presentation of 22 down to 2. This is another example of neoadjuvant therapy with Lenvatinib causing a return of laryngeal function, a 62-year-old presenting with advanced DTC, presenting with vocal cord paralysis on the left, and treated with 2 cycles of Lenvatinib, and on repeat laryngeal exam, her left cord resumed normal function after the initial 2 months of Lenvatinib, consistent with a retreat of disease as a result of that Lenvatinib. So very significant disease response. And so finally, I want to finish that preoperative treatment for patients with advanced disease is not just about Lenvatinib, that for RET-altered cancers, neoadjuvant therapy is available given the proliferation of RET-specific agents that are available. This is a study we will be starting later this year using neoadjuvant pralsetinib, which is a RET-specific inhibitor. This is a woman, I had shown her picture prior. This is an 11-centimeter mass, invasive to several different areas in the neck, including, I thought, the vertebral artery. You see the disease connecting between the lateral and central necks in the retrocarotid space with pulmonary disease. She underwent NGS testing, found to have a CCD-C6 exon 1 RET fusion. For that reason, she was started on selpercatinib, which is a selpercatinib and pralsetinib are the 2 new RET-specific inhibitors. She had a dramatic response. The 11-centimeter mass shrunk to 4 centimeters. We then operated on her with an R0 resection, and the pathologist commented that about 80% of the tumor was necrotic in the shrunken node that was resected. And so this is really pretty impressive neoadjuvant effect, allowing better surgery when it's offered in the patient with a RET-altered cancer. I want to thank you for your attention. This was the surgical approach for advanced thyroid cancer and some new tools. I want to thank again the steering committee for this conference and extend an invitation to you. We have a virtual course here at Harvard, November 2022. I've given my email address and the telephone number. We also have a World Congress set of meetings. There will be a April and October virtual meeting in 2022, as well as in-person meetings in London and Boston in 2023 and 2025. You can go to the World Congress website and look for those meetings. The April meeting has a variety of different topics looking at RET targeting, Hürthle cell carcinoma, and tumor board, as well as meet the professor sessions. I want to thank you very much for your attention, and please enjoy the Congress.
Oh, that was amazing, looking at the future, what we can do. But now, can I invite Professor Choker again to discuss how do we manage the nodal burden in thyroid cancer? Professor Choker.
Thank you, Dr. Basha. And once again, thank you to the organizers for giving me this opportunity. My next talk is on addressing the nodal burden in the well-differentiated thyroid cancer. So we switch gears from a disease which is a little bit aggressive to a disease now which has higher cure rates, and we get a lot of success in treating this disease. So I've structured my talk today with regards to looking at first we'll look at the incidence and the prognostic impact of the nodal disease. What does it do with the prognosis of thyroid cancer? Then we'll look at the debate regarding the need and the extent of nodal clearance. Following that, we look at what impact does it have, whether we clear or not clear, what impact does it have on survival outcomes such as survival recurrence, and also look at what impact it has on complications. And finally, in the talk, we'll look at some technical aspects as we did in medullary thyroid cancer. We all know that nodal metastasis is high. The rate of nodal metastasis is high in differentiated thyroid cancer, both central and lateral. It's more common in papillary thyroid cancer as opposed to follicular thyroid cancers. But nodal metastasis carries a completely different connotation in thyroid cancer as opposed to cancers of the other areas of the head and neck, especially squamous carcinomas. In thyroid cancer, the nodal metastases have a less aggressive, they're pathologically less aggressive. They have a questionable impact on prognosis. They have a very less impact on prognosis, and we'll talk on that. And that's why the TNM classification, they've just kept it as yes or no. That means if there's no nodes, it's N0. If there are nodes present, it's N+. But the problem with nodal metastasis, though the prognosis is good, why is the debate? Because we have to address the central compartment, and that's where most of the morbidity lies. As opposed to squamous carcinomas, where we go on digging to find nodes, we aggressively do radiological investigation to find out nodal disease. We want to get occult metastasis which upgrades the stage, and you have to use adjuvant therapy. It's not so in thyroid cancers. And years back, this paper from MSKCC told us that nodal metastasis does not have an overall impact on survival, on outcomes of well-differentiated thyroid cancer, except in elderly patients. And at that time, the age group was 45, following a publication, the age group changed. They changed the goalpost from 45 to 55 years. I'm not going to the detail of that, but that's reflected now in the AJCC classification, where below 55 years, nodes have no role to play in the staging system. So presence of nodes do not impact the staging system, which is the stage 1, if there are no metastasis, distant metastasis, or stage 2, if there are distant metastasis present. Nodes do not play a part. They only play a part in advanced disease, if in patients more than 55 years, where it upstages it from stage 1 to stage 2. But there's no aspect of thyroid cancer which is without a debate. And that is why this publication, again, looking at NCDB database and CR database, more than 11,000 patients with metastasis and 3,000 without metastasis. This population was less than 45 years age. And what they reported was that nodal metastasis, even in younger population, does have an impact on survival. And this impact continues up to 6 nodes. And beyond that, the curve flattens off. So up to 6 nodes, it has a detrimental survival, even in the age group below 45. So what do? Do you go about hunting these nodes? Well, let us look at what do you do to evaluate nodal metastasis. And Dr. Randolph just touched upon this, but we do ultrasound in all cases of thyroid malignancy because it is low cost, it is easily available. It can be combined with FNAC to give you a diagnosis. Usually a TG washout, generally not done unless it's a cystic metastasis or there's a discrepancy between what your ultrasound finding tells you and the cytology finding tells you. Then you do a TG washout, but rarely done in clinical practice. But there are limitations to an ultrasound because you cannot get central compartment nodes when the thyroid gland is in situ. It cannot tell you whether there are nodes in the central compartment. It cannot look at the retrosternal nodes, and of course, it is operator dependent. And Dr. Randolph showed you the use of CT scan in locally advanced disease, but lot of surgeons and lot of clinicians use CT scan to detect nodal metastasis. We'll come to the debate whether to do it or not to do it. But if you want to do it, always do a contrast enhanced CT scan, as Dr. Randolph already has mentioned. There are reports which say that if you combine ultrasound with CT scan, you will pick up more nodal metastasis. It's much better to pick up nodal metastasis when you combine ultrasound and CT scan. But till date, the ATA guidelines do not recommend CT scan routinely for thyroid cancer, except when you have locally advanced disease, when there is indication of a locally advanced disease, to look at upper aerodigestive tract invasion, or when there are bulky nodal metastasis and you expect that there may be retrosternal metastasis. That is the time you add CT scan. So for routine evaluation of the nodes, we do not use CT scan. And look at it why we don't use, and to understand why we don't use and why don't we go digging or finding nodal metastasis, we need to understand when to dissect these nodal metastases or when to treat these nodal metastases. So to do that, we need to understand the prognostic significance on the volume of nodal metastasis, and we need to balance our treatment guidelines depending on the risk-benefit ratio. You don't want to unnecessarily dissect the neck and give the patient morbidity. So we need to tailor our treatment depending upon the prognosis or the outcome of these nodal metastases. Of course, we address the central and the lateral. That's a no-brainer. But all the problems mainly, I'm not saying lateral compartment does not have morbidity, it does have its own morbidity, and we'll come to that. But central compartment is where the main morbidity lies, and that's where majority of the debate in well-differentiated thyroid cancer is. Clearly, the guidelines say that if you have an N1 disease, you have clinical, radiological, or pathologically positive proven nodes, you have to do a therapeutic central compartment dissection. Absolutely no debate on that. The debate is whether you to do a prophylactic central compartment dissection or not, or you observe these nodes. Now, there are pros and cons. That the people who say that you cannot detect central compartment nodes, imaging is no good. You probably can't detect it, and you will miss subclinical nodes, which will, if you dissect these subclinical metastases, the TG will normalize better, so the follow-up is much better. And there are papers to say that if you don't dissect these nodes, the recurrence rates are higher. However, the problem is again of the morbidity, and those who argue against regular central compartment or prophylactic central compartment say that it really doesn't matter if there are these small nodes; they will never recur. They will just stay there probably and never become clinically evident. And if you unnecessarily detect this, your chances of morbidity, chance of damaging the recurrent nerve and the parathyroids increase, and you will unnecessarily give over treatment and give radiation to most of these patients. There is no level 1 evidence, but there are a number of meta-analysis out there. Some say that there is no difference in loco-regional recurrence, and some say that there is a significant difference in loco-regional recurrence. But both agree, most of the papers agree, that if you do extensive central compartment dissection, it does have an effect on rates of hypoparathyroidism and rates of recurrent laryngeal nerve injury. And this is a recent meta-analysis of randomized trials in low-risk thyroid cancer, looking at prophylactic central compartment dissection, and it states there is no beneficial effect of prophylactic central compartment dissection on locoregional recurrence rates or biochemical cure, but there is a high risk of permanent hypoparathyroidism associated with prophylactic central compartment dissection. And we looked at our data. This is a publication from Tata Hospital, which looked at bilateral central compartment clearance. It was associated with higher rates of postoperative hypocalcemia. These are temporary hypocalcemia rates as opposed to lesser resections in central compartment. So what do you do? When do you decide to address the central compartment? Clinically, radiologically, you're not wise because it probably can't pick up. So there are some factors which tell you that you need to look into the central compartment, especially if they are male gender, if they are elderly patients, if the tumor is large, if there is extrathyroidal extension or locally advanced disease. And that is reflected in the ATA guidelines, which says that central compartment needs to be considered, and mind the words, it says considered in locally advanced tumors. It does not say you have to do it. It says considered in T3, T4 tumors, involved lateral leg. Again, there is a debate on that. And if it's going to change your therapy. Now, the evidence here is weak and low quality evidence. The evidence is strong when they certainly say that you do not need to do a neck dissection for smaller tumors, which are clinically and radiologically node negative, and especially if they are follicular thyroid carcinomas. And to understand this, why we are not going to dig into the central compartment to fish out nodes, to try and see whether there is nodal metastasis, can be understood from this paper from Dr. Randolph, which tells us the significance of these nodal metastases. What they did was they divided the nodal metastases as those with pathologically detected. That means you did not see it, you picked up some central compartment, and the pathologist reported a presence of nodes, those which were ultrasound detected and those which were clinically palpable. And look at the outcomes that are associated with each. If it was clinically N0, the recurrence rate is 4%. It does not increase if the pathologists tell you there were some nodes positive. It's just about 6%. And it even does not increase if there is small volume nodal disease. So less than 5 nodes, again, the recurrence rate is the same. So having no nodes or less volume nodes or smaller size nodes does not increase the recurrence rates. So they divided patients into low risk, clinically N0, micrometastasis, and less than 5 nodes as low risk group, and the high risk group was the clinically detectable nodes, larger nodes, 3 centimeter size nodes, or more than 5 nodes. So they divided into low risk and high risk groups. And they said that all patients with N1 disease do not have the same magnitude of risk. Nodal disease does not necessarily indicate poor prognosis, and microscopic nodal disease you unnecessarily upstages the patient without any change in survival, and hence we need better criteria to identify patients who will have nodal metastasis, and that's incorporated into the ATA guidelines, which puts that even if you have nodal metastasis, but if they're less than 5 and less than 2.2 centimeters, they still are low risk. You don't need to do anything further. As the size increases or the number of nodes increases, the risk criteria increases, and that is the time you escalate your treatment for these kind of tumors. So really don't have to act at the CN0 or the micro N1. You need to act at the macro N1 only, and that is why this debate of you don't need to actually go into the central compartment unnecessarily looking for nodes or doing extensive preoperative radiological investigations to find nodes, because microscopic nodal metastasis does not have an impact on recurrence or survival rates, or has a very little impact. So they're clear that you have to do, I showed you recommendation B and C, the recommendation A, which is again strong evidence that only if there is evidence of disease in the central compartment, you need to do a therapeutic neck dissection. Prophylactic neck dissection is only done for the factors that I mentioned earlier: large volume disease, locally advanced disease, or presence of lateral compartment neck nodes. And most of the guidelines published the world over agree with the fact that I just said, excepting for the Japanese society, which says that you need to routinely perform, which is at a little variance with what the Japanese are advocating. They're advocating, observation of less than a centimeter, but they are advocating to be aggressive as far as nodal dissection is concerned. Right. So clearly, till now, we've seen that nodal dissection is only for presence of nodes, prophylactically, you do not need to do. We also saw that radiology is not a good tool. Then what do you do with the central compartment for a thyroid disease? Do you just inspect it and leave it? Do you explore, open the fascia, because sometimes a node below the fascia lateral to the recurrent nerve may be missed? Do you pick up some node, send it for frozen? What is the extent? And we looked at our data, and we're going to publish this data soon, close to 1,500 patients. We are 12 surgeons, and look at, I'm not trying to give you the data details now, but look at the central compartment notes that I found in the operative notes. Sorry. So look at the variations in the operative notes that I found. Bilateral inspection, ipsilateral sampling plus contralateral inspection, ipsilateral clearance, so on and so forth. So really, the terminology or what to do with the central compartment. Some are just exploring, some are putting their hand and palpating, some are picking up some nodes and sending it for frozen section. So there is a clear cut, there's no clear guideline as to how much you need to do with the central compartment. So just going on to the data a bit, we had 40% occult metastasis in the central compartment. When we looked at predictors of central compartment nodes, extrathyroidal extension and extensive lymphovascular emboli. So again, larger the disease, more aggressive the disease, the chances of central compartment metastasis are higher. And when we looked at recurrence in DTC, we found that extracapsular spread in these nodes was a predictor of local recurrence in the central compartment. And what predicted extracapsular spread? Higher the number of nodes and the higher the size. So coming back to Randolph's paper, exactly what we found in our paper is that as the nodal number of nodes increase or the size of the nodes increase, the chances of extracapsular spread and the chances of recurrence go up. So you do not need to unnecessarily dissect the central compartment if there are no nodes or no gross nodes that are seen intraoperatively. Coming to the lateral neck, yes, there is morbidity associated with the lateral neck. You have your spinal accessory nerve, you have your chyle duct, you have your cervical roots, which can give rise to chronic shoulder pain, and you're guided in the lateral neck by your imaging, preoperative imaging, which is better because there's no thyroid gland there. So it is better in the preoperative setup that you can accurately detect nodal metastasis in the lateral neck, and that's what guides you to do the lateral neck. So lateral neck dissection, as per the ATA guideline, therapeutic neck should be performed in all biopsy proven. So clinico-radiologically positive lateral neck is what you should address. But I don't agree completely. We vary in our practice a little bit, and we can talk about it in our panel. We also address the lateral neck if the central neck is positive. So if I get a central neck positive, I do operate the lateral neck. We can debate on that, but because we feel that the pickup of level 3 and 4, when you have a central compartment, that's an area which is very close. We do this lateral compartment, the neck dissection, and when we analyze our 1,500 patients, I will come out with the data regarding the positivity and the size and the presence of extracapsular spread in lateral neck when the central compartment is positive. So we do add lateral neck dissection when central compartment nodes are positive. Again, as I said in medullary, and Dr. Randolph showed this compartments, central and lateral. Now in medullary, when we said central, the picture that comes to our mind is carotid to carotid. Both sides of the trachea need to be clear. Now look at the slight difference in the definition in this paper that was published in 2009. A central neck dissection includes comprehensive compartment-oriented removal of prelaryngeal, pretracheal, and at least one paratracheal nodal vessel. So when they are talking of well-differentiated thyroid cancer, we talk of at least one central compartment, and we are not saying bilateral. And that is because the prognostic implication that we saw, that is because of the outcomes of micrometastasis that it has, it doesn't really change. And that is why we want to limit our morbidity. Again, they say you have to clear from hyoid to brachiocephalic. We rarely do that. We normally limit ourselves below the inferior thyroid artery unless they're gross or bulky nodal disease in the central compartment. And that's where most of the node lies in the well-differentiated thyroid cancer, higher in the ipsilateral central compartment, then goes to the pretracheal prelaryngeal lateral compartment, and then in the opposite neck. So the strategy that we use at our hospital is that we do clear the central compartment prophylactically if there is a locally advanced disease or if there are nodes in the central compartment. In well-differentiated thyroid cancer, we would do the lateral, but the contralateral we would inspect and not clear prophylactically if there is no disease in the opposite lobe and if the opposite central compartment is negative clinico-radiologically. Of course, we try to identify the inferior parathyroids as early as possible when you are going to do the central compartment, because once you start doing the central compartment, it becomes that much more difficult. So even if you are using the superior approach, the first thing you do is try to identify the inferior parathyroids, reflect them with their blood supply, and then clear the nerve along, clear the nodes along the nerve. That will help you preserve your parathyroids. Quick word, and Dr. Randolph has covered this, so I'm not going to waste time on this. But again, if you have recurrent nodal disease, then you need to only investigate. Again, the philosophy is the same. Small nodes, lesser number of nodes, even if it is in the recurrent setting, they do not impact prognosis. Smaller nodes, less than 8 millimeters in the central neck or 1 centimeter in lateral neck, you don't even need to investigate. You need to investigate if the size increases or if the nodes are of a higher size. And that's these are some of the factors that Dr. Randolph showed, that if the initial disease was very high, so you had a high nodal burden to begin with, you had extracapsular spread, you had local invasion, then maybe you would want to clear the central compartment again. Otherwise, for a small disease of the central compartment, it really doesn't matter, because these are the diseases which are indolent to begin with. Even in the recurrent setting, small disease in the central compartment are indolent, and only 10 to 14% will grow over time. Rest of the nodes will either remain static or will go down with time. Last couple of slides, new things on the horizon, maybe in the guidelines next year or whenever the next guidelines come, they may include more prognostic criteria for helping us guide our treatment. And one of them is the lymph node density. And the second one is the molecular signature. No talk is complete without some molecular talk, but maybe molecular signature will tell us which are those small, well-differentiated thyroid tumors that are going to metastasize, going to behave more worse or poorly than the garden variety papillary carcinoma. And that's what we are interested in. Those 5%, 10%, can we identify them? Can we have some signature to tell us that these 5% are going to behave badly? So in conclusion, a rich lymphatic supply, high nodal metastasis, overt metastasis associated with reduced disease survival and should be addressed, but overall impact of nodal metastasis at best is modest. We need to consider the risk-benefit ratio. Microscopic disease in the neck need not be addressed. They do not have an impact on overall prognosis. And maybe in the future, we'll have better diagnostic criteria and prognostication for our patients. Thank you very much. I'll just stop sharing my slides. Give me a minute.
Thank you, Dr. Devendra, for that excellent presentation. In the interest of time, we will now move forward to the Bayer Symposium. We have to thank Bayer. They are the platinum sponsors for this conference, and indeed, if you've visited the exhibition booth in the on the platform, you please feel free to do so today and tomorrow, as long as the other sponsors have their virtual booths there. For now, we will move to the Congress, the symposium rather, and the title of it is the Treatment Sequencing in Treating RAI Refractory DTC. And it will be presented by a very eminent speaker here in the UAE, Dr. Imad Dawood. Dr. Eiman is a consultant medical oncologist in oncology department at SWAM, and he's the assistant professor of clinical oncology in Al-Azhar University, Cairo, in Egypt. Dr. Dawood completed his MD PhD in clinical oncology in 2010 and the Federation of Royal College of Physicians of United Kingdom Medical Oncology Specialty 2012, and a master's degree in clinical oncology in 2003. Dr. Dawood has been a graduate of Al-Azhar University since 1997. And he's a principal investigator and co-investigator for more than 50 clinical trials and abstracts, published peer-reviewed journals, and is a member of various associations such as ASCO, ESMO, and ESTRO. And he will be the presenter for the symposium today. So, Dr. Imad, the floor is yours.
So, thank you for this lovely introduction, and thanks for the organizing committee for giving this opportunity, and thanks for Bayer for inviting me for this talk. So, assalamu alaikum and good evening, ladies and gentlemen. It's my task today to talk about the how to optimize the treatment sequence in radioactive iodine refractory differentiated thyroid carcinoma. So approximately 25, even up to 50% of metastatic thyroid cancer will lose the ability to take up iodine. And this is because of the downregulation of the sodium iodine symporter and other genes involved in the sodium iodine metabolism. In a short definition, it's the cancer cells forget how to take up the iodine, and so they are immune for the treatment. Well, disease mortality from the radioactive iodine refractory is high, with the only survivor for those patients ranging from 2 to 3 years, with the median progression-free survival, which is the time from the diagnosis till the progression of the disease, in patients not treated, ranging from 3 up to 6 months. If you're looking for the 10-year survival for early thyroid carcinoma, it's more than 90%. Only 10% of the patient metastatic radioactive iodine, they have a 10-year survival. There are a lot of trials try to address a treatment for this group of patients. Initial chemotherapy, unfortunately, it has a big zero. It failed to show any significant improvement in the survival. The response rate was only 5%, with all the side effects and toxicity of the chemotherapy. There has been trial for doxorubicin, paclitaxel, and cisplatin, but all failed. If you're looking for the genetic of thyroid cancer, for example, the papillary thyroid carcinoma, which is the most common type of well-differentiated thyroid cancer, almost 50% of the patients, they have BRAF mutation, and 20% they have RET fusion, making the thyroid cancer one of the diseases that can be targeted by targetable therapy or tyrosine kinase inhibitors. So this is an example for the thyroid cancer cells, and we are in oncology. We're trying to tackle both the tumor cells as well as the vasculature. So knowing that thyroid cancer is a highly vascular tumor, so there are a lot of compounds or drugs has been tested and tried to induce cell cycle arrest and stop proliferation, as well as to inhibit the vascularization or the angiogenesis for the tumor cells. The most two tyrosine kinase inhibitors, we have the sorafenib as well as the lenvatinib. Both has been approved in the first line radioactive iodine refractory thyroid carcinoma. And if you are looking for the pattern of mechanism, so both drug inhibit the angiogenesis by inhibiting the vascular endothelial growth factor receptors. Both also inhibit the platelet degradation growth factor receptors. Both inhibit the KIT and RET gene. But only sorafenib can inhibit the BRAF, which, as I mentioned before, almost 50% of the thyroid cancer, papillary thyroid cancer, has having a BRAF mutation. Lenvatinib, it's a unique drug also. It's inhibit the fibroblast growth factor receptors, which is also involved in the angiogenesis of thyroid cancer cells. So to make it easy, and this is a case study, and a 52-year-old lady, she has no comorbidities. Her history starts since 2013 with the right thyroid lobe biopsy showed follicular variant of papillary thyroid carcinoma. She had subtotal thyroidectomy for 23N0M0. She has a risk factors such as large tumor, positive surgical margins, lymphovascular invasion, and extranodal extension. This patient received radioactive iodine refractory. This is her whole body iodine scan that's showing she has a still active disease in the neck, as multiple lung metastases. So she started with radioactive iodine therapy, and over 2 years, she received almost 900 millicurie of radioactive iodine. And in 2015, she started to have a pain in her forearm. And this, as you see in the X-ray, this is a large lytic lesion here in the forearm. It has been confirmed by MRI, as you see here. as well as she has a resection of this tumor and proved to be a follicular variant of papillary thyroid carcinoma, so metastatic thyroid carcinoma. And this is another bone lytic lesion in the iliac bone for this patient. And this is her MRI, which showing this large lytic lesion. So we did a CT scan for this patient. It showed multiple small lung lesion, as you see here. So after 900 millicurie of iodine, she has been labeled as radioactive iodine refractory. This is whole body iodine. This is her whole body bone scan that shows she has multiple bone metastasis. So this patient, according to the decision trial, which is a phase 3 randomized trial, exploring the efficacy and the safety of sorafenib in this situation. Just to highlight the data from this trial, so almost 417 patients with local advanced or metastatic radioactive iodine refractory has been randomized into sorafenib with the standard dose 400 milligram twice daily, or placebo in the control arm. Primary endpoint in this trial was progression-free survival. Overall survival was a secondary endpoint. This is a baseline patient characteristic. As you see, it was well balanced between the two treatment groups. A male to female ratio almost 1-to-1, and the median age is 63. Most of the patients, they have good performance status 0 or 1. If you're looking for the most common pathology here, papillary subtype was predominating in 57% in this trial. 96% of the patient having distant metastasis and only 4% with local advanced disease. If you're looking for the most common site of metastasis, lung in 86%, 54% having lymph node, only 1/4 of patients having bone metastasis. This trial has been labeled as positive trial. It improved the progression-free survival and decreased the risk of progression and death by 41%. If you're looking for the hazard ratio of 0.59, and median progression-free survival almost 11 months for sorafenib and 5.8 months for placebo. This is the hazard ratio for the subgroup analysis according to the progression-free survival. And as you see here, every single patient, they benefit by adding sorafenib. So we have a consistent evidence that sorafenib improve the progression-free survival in all subgroup category of patients. What about the patient with BRAF mutation? I mentioned that it's almost 50% of papillary thyroid carcinoma, they have BRAF mutation. If you're looking here, the upper part of the slide, where patients with BRAF mutation, they have almost a 20-month of median progression-free survival. So have a very long progression-free survival in this group of patients versus only 9.4 months for the placebo group. So almost double the median progression-free survival. The drug also working in patients with the BRAF wild type, we have almost 9-month median progression-free survival for sorafenib or Nexavar, and 3.8 months for the placebo group. Response rate almost 12% in this group of patients and 0% in the placebo group. But for those responding, they have almost 10-month median duration of response with the sorafenib. Overall survival was not significant this trial, and the reason behind that, almost 75% of the placebo group, they received sorafenib or other tyrosine kinase inhibitors at time of progression when the trial becomes unblinded. Safety profile of sorafenib, so we have mainly hand and foot syndrome, diarrhea. Some patients, they may have alopecia, fatigue and loss of weight, as well as hypertension. But severe grade 3 and 4 toxicity was very rare, except for the hand and foot syndrome, which is almost 42% of the patients. 77% of the patients on sorafenib, they have dose modification versus 30% placebo, dose reduction in 64%, and dose interruption in 66%, while discontinuation only was in 10% in sorafenib arm, almost versus 4% in the placebo group. So this is a patient who started on sorafenib, and after almost 4 months of sorafenib, this is what we call palmar-plantar erythema, as you see here, which is did not interfere with her daily life, just grade 2. So it doesn't need any dose modification or interruption. This is her first. This is her follow-up CT scan showing the lung showing a stable disease in her lung, and the same for a bone scan. It was showing a stable disease, and this is almost after 2.5 years with this stabilization of heart disease. A patient start to have progression of the lung nodules as well as developing renal metastasis. So this is very long. This is control with the sorafenib over 2.5 years in this patient. We did biopsy from this renal mass just to rule out another primary from the kidney, and it proved it's a metastatic papillary thyroid carcinoma. So what about the second line? And here the selected trial for lenvatinib. It's also a phase 3 trial, included patients with radioactive iodine refractory. They are a 2-to-1 randomization, lenvatinib with 24 milligram daily or placebo. Primary endpoint, progression-free survival, but secondary endpoint, overall survival and response rate. Crossover to lenvatinib from the control group, it was an optional, but was allowed in this trial. Just to highlight, in this trial, almost 25% of the patients, they received prior tyrosine kinase inhibitors. So lenvatinib can be used after sorafenib, but in 75% of patients was treatment naive. Again, the most common histology was papillary subtype in 54% of these patients. And if you're looking for the prior tyrosine kinase inhibitors, as I mentioned, 25% of the patients, 20% received prior sorafenib, 2% sunitinib, and 1% pazopanib. This trial also was positive. It did improve the progression-free survival by 18 months for lenvatinib and 3.6 months for the placebo. The hazard ratio is significant, 0.21. If you're looking for the patient, they are treatment naive. There has been a significant improvement in progression-free survival, 18.7 months for lenvatinib and 3.6 months for the placebo group. And response rate 65%, so quite effective. But more interesting for those patients having prior tyrosine kinase inhibitors, which is mainly sorafenib, the drug also working. So we have a hazard ratio of 0.22 and a response rate of 62%. Overall survival also in this trial was not positive, and this is because of the crossover from the control arm to the lenvatinib in this trial. If you're looking for the response rate was significantly high. We have almost 65% response rate in this trial, but complete response, it was 1.5%. Majority of patients, they have a partial response. This comes with a price of side effects. So we have a majority of patients, they have hypertension, almost 68% of the patient, and grade 3 and 4 hypertension was significantly high, 42%. Also, they may have diarrhea, fatigue, loss of appetite, loss of weight, palmar-plantar erythema, and proteinuria. But severe side effects, it was only single digit. So based on this data, this patient started on lenvatinib as it's working after sorafenib. And we are expecting to have a response rate for these patients according to the trial. 62% of the patients received lenvatinib after sorafenib, they have a good response rate. This is her CT scan before lenvatinib. This is the renal mass, which is showing a very good response after lenvatinib. And here the lung nodules before lenvatinib, which is shrink here after lenvatinib. What other options for radioactive iodine refractory thyroid carcinoma? We have the NTRK fusion, and currently we have 2 drugs, larotrectinib which has been approved based on the pooled analysis from a phase 2 clinical trials of the different type of solid tumors that showed almost the objective response rate with the 79%, median overall survival 44 months, median progression-free survival 28 months, and median duration of response 35 months. Quite effective, but the incidence of NTRK fusion, it's around 14%. Entrectinib, also another NTRK fusion inhibitor, which is showing also from a phase 2 pooled analysis with the different type of solid tumors, showed the 57% response rate, overall survival 21 months, progression-free survival 11 months, and 10-month median duration of response. We do have another target, which is the RET gene fusion, and it's almost 10 to 20% of the papillary thyroid carcinoma. They have RET fusion, and this is Liberto 001 for silpercatinib in RET altered tumors. So in this phase 1, phase 2 trial, silpercatinib showing a response rate of 79%, 5% patient complete response, partial response in 74%. Baricitinib, it's another RET inhibitor. This is the ARROW trial, which is again phase 1, phase 2 trial, and it showed very promising response rate. 91% of the patients, they have response rate and 9% stable disease. So the disease control rate here almost 100%. What about the treatment option after the tyrosine kinase inhibitors in the first line? And this is the COSMIC trial, which has been just presented in the European Society of Medical Oncology in the last year, in October. So the COSMIC trial, or the COSMIC 311 trial, looking for the cabozantinib as an option for second line after tyrosine kinase inhibitors. So they included patients previously treated with the vascular and cerebral factor receptor tyrosine kinase inhibitor. Is 2-to-1 randomization, cabozantinib 60 milligram daily versus placebo. Primary endpoint here, progression-free survival, and overall survival is a secondary endpoint. This is the baseline patient characteristic, which was well balanced between the two treatment groups. Just to highlight that almost 1/3 of the patient received prior sorafenib, another third have only lenvatinib, and 1/4 of the patient received both sorafenib and lenvatinib. Trial has been labeled as a positive trial. Cabozantinib, it did improve the progression-free survival with a hazard ratio of 0.22. Overall survival is still immature at the time of analysis, but there is a trend towards improvement in overall survival with a hazard ratio of 0.54. Median progression-free survival for cabozantinib in this group of patients, 11 months and only 2 months in the placebo group. Median overall survival, 19.9 months. 19.4 months for cabozantinib, but not evaluated in the control group. Response rate in heavily pretreated patients with cabozantinib was only 11%, which was 0% in the placebo group. It was interesting that showing the outcome according to the prior tyrosine kinase inhibitors. So in this trial, patient received sorafenib first, followed by cabozantinib. They have a very long progression-free survival, 16.6 months in the cabozantinib group and 3.2 months in the placebo. However, those received lenvatinib followed by cabozantinib, the median progression-free survival is almost 5.8 months, and here compared to 2 months in the placebo group. If patient received both lenvatinib and sorafenib, the progression-free survival was 7.6 months. Versus almost 2 months in the placebo group. This is the safety profile of cabozantinib. It's almost the same as this group of medications, where diarrhea and hand and foot skin reaction, hypertension, loss of appetite, and transaminases are a common side effect. However, grade 3 and 4 toxicity was only a single digit in this group of patients. So we have a dose reduction due to toxicity from cabozantinib in 67% of the patient, but only 9% of the patient discontinued the treatment. So the take-home message that the survival in patients with progressive radioactive and refractory differentiated thyroid carcinoma in general is poor. Median survival between 2.5 and 3.5 years. We have both lenvatinib and sorafenib are a standard of care for the progressive radioactive iodine DTC. Both drugs significantly improve progression-free survival with no overall survival benefit due to crossover in both trials. Lenvatinib significantly improved the response rate and progression-free survival in previously treated radioactive iodine refractory. Those received prior TKI, so could be used after sorafenib. Toxicity profile of both drugs are unique, with more hypertension with lenvatinib and more palmar plantar erythema with sorafenib. So with that, I will thank you for your listening.
Thank you, Dr. Emad, for a wonderful presentation. We will now move back to Dr. Basha for the Ask the MDT session. Dr. Basha, the floor is yours.
Thank you. Thanks, Jared. We have an interesting panel of experts, and who will be our MDT panel. Now, the two experts will be talking, giving their presentations later, but I take this opportunity to introduce them. We have Professor Andrew Bauer, who's a pediatric endocrinologist. He's a professor of pediatrics in the University of Pennsylvania. He's also the director of Thyroid Center at the Children's Hospital of Philadelphia. Dr. Bauer's research interests span across the spectrum of pediatric thyroid disorders, including thyroid hormone production syndromes, thyroid hormone resistance and transport disorders, thyroid nodular disease, thyroid cancer, and familial thyroid tumor syndromes. Within this field, he's published more than 140 manuscripts, chapters, reviews. He's a regularly invited lecturer, visiting professor at international meetings and academic institutes. In 2019, he established a translation science research program to better define the molecular landscape of pediatric thyroid cancer in an effort to improve diagnosis and treatment. In 2020, Dr. Bauer and his team were selected as a CHOP Frontier program and launched an international child and adolescent thyroid consortium to expand multi-center collaboration. He serves as a medical consultant for the Thyroid Cancer Survivors Association and for the International DISAR-1 Registry. Dr. Bauer maintains active membership in the Endocrine Society, the Pediatric Endocrine Society, and the American Thyroid Association. He's currently serving as the chair of ATA Pediatric Thyroid Nodule and the Thyroid Cancer Guidelines. Welcome, Dr. Bauer, and we look forward to your presentation later, but at this stage, we will be sort of asking you from the MDT point of view. On the same note, I would also like to introduce Professor Mike Turtle, who we have met before in these meetings earlier. Welcome, Mike. Professor Mike is a professor of medicine, chief of endocrinology society at the Memorial Sloan Kettering Center in New York. He's designated and validated as the first real-time risk assessment model for thyroid cancer management, in which individual risk estimates are modified over time as a function of response to initial therapy. His research continues to center on important management aspects of thyroid cancer, including efforts to better define the risk of recurrence and the death from thyroid cancer for individual patients, and the role of active surveillance in properly selected patients with low-risk papillary thyroid cancer, and also the proper application of minimalistic management options to better tailor the intensity of therapy and follow-up to risk of undesirable outcomes. His clinical practice is entirely devoted to the evaluation and management of patients with thyroid cancer. He's also popularly known as the most aggressive surgeon of the team.
This is true.
Right, and I also like to invite Prof. Choker. So we have 3 eminent professors here, and I would like to invite Dr. Yogesh More I must say, Professor Choker, you have mentioned quite a lot of things. We were going to put it in clinical scenarios, but hopefully we will want to translate all your talks and put them into these perspectives. And with one little apology for Professor Turtle and Professor Bauer, we are probably introducing these scenarios before your talks, so kindly apologize. And one of your talks is tomorrow. But in a real life, there will be a different audience today, different audience tomorrow. So I'm sure everybody would like to benefit with your expertise. Okay, Dr. Yogesh?
Good evening, my esteemed speakers, and welcome everyone. For those who are from the Eastern Hemisphere, good morning. Those who are from the Western Hemisphere, good evening. And let me see, I'm going to share my screen. Okay, so on behalf of the organizing committee, I would like to welcome all our esteemed speakers, panelists. We have Dr. Chaukar, Dr. Tuttle, and Dr. Bauer. We have some case-based scenarios for the multidisciplinary discussion, and I'm just going to begin with that. Okay, so the first case we have is a very straightforward young lady with no other significant risk factors, and she presents with a lump in her neck. An ultrasound is done. It's a 2.2 centimeter nodule with no high risk features. She gets a biopsy done. It is benign. So let me ask this question to Dr. Chaukar. So Dr. Chaukar, this lady walks into your clinic, no high risk features, and it's purely for a cosmetic purpose that a lump looks bad in her neck. So what would you offer to her, and what is your thought process when you're thinking about surgery?
Yogesh, first, that family history, sister thyroid cancer, I want to know what was the histology of that thyroid cancer. That will give me a roadmap to how do I further investigate this. Because if that patient, that sister was medullary thyroid cancer on histology, then I would go on a completely different track as opposed to a familial, which can be 5% familial, papillary or well differentiated. It can be 5% familial, but I would be more interested if it's a medullary thyroid cancer. If it is not, do we have the result of that? Do we know what the sister had?
It is a well differentiated thyroid cancer, papillary.
It was a well differentiated cancer, right? So then it's unlikely that this. So this is a benign, probably a multinodular goiter. The opposite lobe is normal. Is that correct?
Yes.
Or there are nodules in the opposite lobe. So it all, yeah. So it all depends on what is the size of this nodule. If it's bothering her, if it is growing in size, then I would recommend surgery for this patient. If there are multiple nodules in the opposite lobe, we'll do a total thyroidectomy. Otherwise, we can do a hemithyroidectomy, and that would suffice for this patient.
Thank you. So now, when you discuss about surgery to this patient, you talk about the risk, which includes the voice and the parathyroid. The patient gets a little scared, and let me ask this question first to Dr. Tuttle, that what are the minimally invasive ablative treatment options? And in her scenario, what would you like to offer?
Yeah, in her scenario, we probably won't offer any ablative treatment options. She's 30 years old. You've got a solitary nodule. You've got a family history of thyroid cancer. You're always going to worry about this. So in our hands, now to be fair, we treat thyroid cancer and not a lot of benign nodules. But if this was my daughter, I'd have a really hard time telling her that we would do an ablative procedure. Now, I don't have any doubt ablative procedure would work. Radiofrequency ablation has been the most. And if you're just trying to get shrinkage of 75%, it gets you there. But it's hard to imagine leaving a isolated, solitary, benign nodule in a 30-year-old forever. So, they would have to really, really refuse surgery or have some other great reason not to have surgery. To be honest with you, when I saw her, I probably wouldn't even bring up the ablative options. I would say, like Dr. Shakar, we'd be aiming for a lobectomy if it was the right surgery.
Thank you. And let me ask Dr. Bauer about this, that in case a similar nodule in a pediatric population, what would be the ablative choices available, just comprehensively based on the size, location, and what are the other factors that come into account?
Right. So the experience in pediatrics, similar to other experiences in thyroid for radiofrequency ablation of benign nodules, is very minimal. There's one paper I recently reviewed, I don't know if it's out yet in thyroid, looking at a case series, and it essentially showed that it's kind of a third. Some of them stay similar size, some of them actually decrease for a relatively short period of time and then again increase. And then some of them just don't change much and then increase. And the problem is that once you perform radiofrequency ablation, you get multiple echogenic foci within the nodule. And it just makes it harder to even follow and reassure people that things are benign. And it's an expected outcome of treatment for RFA. But if this was a pediatric patient similar to Mike, we wouldn't bring up ablative techniques. We would consider a lobectomy if it was cosmetically bothersome, or bothersome as far as like losing sleep and the parents are concerned. If it was neither of those things and the cytology is benign, then we would offer just surveillance.
So this patient actually did not want surgery. And then, a few months later, she underwent a repeat biopsy approximately 6 to 8 months down the line. And this came back as a Bethesda 3 atypia. So in this case, where the FNAC has changed from a benign to an atypical presentation, obviously all of you agree that ablation is not the ideal choice for her. So Dr. Tuttle, are there any molecular markers that can help us to guide the surgery versus observation?
Yeah, that's a great question. Yeah, the answer is there are definitely markers, but I think the tougher question is, are they going to help us here? So if we already know that our recommendation is she needs a surgery, then having thousands of dollars in molecular markers doesn't help us. But on somebody like this, if it was a Bethesda 3, I sit down and talk to the patient and say, look, all right, I know you don't want surgery. If I had this molecular testing, would you still not want surgery? And sometimes the answer is yes, we still don't want surgery. But if she said no, there's definitely a surgical option. If I knew for sure it was thyroid cancer, I'd do a surgery, then I would do it. So we've got good molecular testing that allows us to risk stratify. That, if this was a BRAF positive tumor, we would know it was papillary. If it was none of the molecular markers, it would have about a 5%. So I use it to risk stratify, but only when it's going to make a decision. So we ask the question first. I don't want to do testing and then not go to surgery, or do testing and go to surgery, so we don't spend a lot of extra money.
Would molecular markers guide to the extent of surgery, since we already decided it's a surgery? Will it help Dr. Chowka to decide between hemi versus total?
Well, I hope not. I'll cheat
probably
here in
not.
front of you.
It won't help me decide, because I've made a decision that it is a small nodule. If the right surgery would be a hemithyroidectomy, it probably helps me if the FNAC comes back negative, but because of the size, because of other factors, I think that if it was positive, I would have done a total thyroidectomy. In that instance, a molecular marker telling me that this is more likely to be malignant, that will help me do a total thyroidectomy. But for this patient, even if it was malignant, I would have still done a hemithyroidectomy. It is not going to help me change my treatment line. Yogesh, if you allow me, can we go back? Can I ask a question? I know I'm not supposed to ask questions, but is it okay if I ask one question? And this is to Dr. Tuttle. Yogesh spoke about ablation, and you said a 2 centimeter nodule, young girl, you would not ablate. So are there any criteria of size, stroke, age, and histology? If it's a proven papillary cancer, say a centimeter, what are the criteria of you selecting ablation?
Yes, that's a great question. So if you think about the benign setting first, this has largely been done in areas of the country and the world that have big multinodular goiters and older patients, right? We're not worried about what their ultrasound looks like 6 months or a year later. You're just trying to get cosmetic shrinkage. And I think that's the best place to use it. There's now been more than 1,000 patients with small thyroid cancers treated with ablation, either radiofrequency ablation or laser, or a variety of different ways to destroy these things. And there's no question that it works. In our practice, I have a really hard time finding a papillary microcarcinoma bigger than a centimeter that I'd be willing to do, because you have to kill not only the cancer, but you got to kill about 2 millimeters around the cancer, right? When oncologists do interventional radiology procedures, benign nodules, no big deal. You kill the middle of it, you don't care about the edges. But in thyroid cancers, you got to kill a safety margin. So ones that are up against the capsule, ones that have any invasion of the capsule, those are not going to be great ones to do. So we started this program, and it turns out that the application of the ablative technologies is going to be a little less than I thought it was going to be, because so many live near the capsule. Now, to be fair, we do hydrodissection, and if it's near the capsule anteriorly and near the muscle, we'd be willing to do it. But so what I find in our practice, the ones that we're really considering for laser ablation are 5, 6, 7 millimeters. I mean, the very ones that probably don't need to be treated at all. And I think I'm doing psychologic treatment, destroying little 6 millimeters. You know who these patients are. They're the patients that come to you and ask you to take out their nodule, right? They don't want a lobectomy. They don't want a total thyroid. They just want that nodule removed. And that's going to be the small group. So for right now, we still consider it in cancer experimental. We do it under a clinical trial, but I find very few that are up to the substantial size that like you would worry about and want to do a surgery that I could rescue with the thermal ablation.
So Dr. Tuttle, coming back to your thought process on ablative treatments, as of now, we have laser ablation, we have radio frequency ablation. You also talk about ethanol ablation. So can you brief us about which to use when, and also you mentioned about the location and the age group criteria?
So the real answer is we don't know when to use with which one. What you find is people that were using RFA for benign nodules are now using RFA for cancer. We don't do benign nodules. We have a big program at our place doing all other sorts of things. So it was easy for us to do laser. So I don't think we have any data yet that tells us either one is better or which one for a selected case. The general review of all those 1,000 cases that it works. It's a way to deliver heat or alcohol or whatever to that tumor. So I think the technologies have worked out really well. The ones that you want to be careful with are the same ones that you don't want to watch. So ones that are on the subcapsular location near the recurrent laryngeal nerve, right? On the left-hand side in the tracheoesophageal groove. In the right-hand side, the right lower pole, because surgeons know that nerve comes in behind the right lower pole and runs medial, right? So we have to be careful down there. And then there are even some people that worry about if the nodule's close to the carotid, because, occasionally the vagus will run medial to the carotid instead of lateral. Now, that's pretty unusual. But I think when I'm looking in areas in those locations, near the major vessels, near the trachea, the recurrent laryngeal nerve, much less likely to do it unless I have a rim of normal tissue. Anteriorly, I'm much more brave because I figure if I burn a little bit outside the thyroid, you guys can fix that for me. That's overlying strap muscles. I'm not going to hurt anything. We'll watch for there. We haven't restricted this to any specific age because the people that are wanting the ablation of the thyroid cancers, they are trying to figure out if they're more scared of the surgery or more scared of the cancer. So the people that want to watch, they're just not interested in a surgery and they're not worried about the cancer. They'll watch with you. The people that want a surgery are worried about not only that little place, but the lymph nodes around it and any little places on the other side. They want a surgery. So there's a small group that want the cancer dead, but they don't want to be on thyroid hormone pills. They don't want a major surgery. It's that small group that we would do. So I think the youngest one, we did a 22 or 23-year-old lady with a 5 millimeter papillary cancer that we all know didn't need to be treated, but she could not get on with her life. This had to be treated. Her family had had some bad experiences with thyroid surgery, and so she just couldn't imagine going down the surgery pathway. So in that kind of unique patient, we're offering it.
So if you have multiple nodules and you have decided that you're going to do ablative treatment, how do you decide like which all nodules to be treated? Is there a limit, like how many nodules can be ablated?
Yeah, I mean, the real practicality, if you're starting to worry about multiple nodules, just go to surgery. I mean, that's how do you pick out which one? So by and large, in the benign setting, you're not trying to kill all the nodules. You're trying to kill the symptomatic ones, right? Either the ones that's sitting down near the esophagus, you think it's pressing on it a little bit, or cosmetically. If we're really worried about the nodules and which ones to pick, we would just do a surgery because we know how to do that. So we're on the ablation stuff. We're using it it's just a focal treatment. It's just to treat that one little place, and we all agree we're leaving everything else behind. We don't know about everything else, so fairly selective. I have had a few of my patients get RFA, and folks have done 2 or 3 nodules on one side, and then they usually bring them back and do it a different day on the other side just to make sure nerve and everything is all chilled out. So, I mean, I think you'd have to be a pretty darn motivated patient to want RFA done on multiple nodules on both sides when you guys can take this out in about 15 minutes per side. So I'm afraid I'm still kind of surgically bent.
We'll ask one last question on ablative treatment. you have done ablation in a patient, and obviously it's going to cause thermal damage, which is going to either necrose or cause that tissue to be dead. Few years down the line, if any surgeon gets this thyroid out, and when the pathologists have a look at the section of this nodule which was thermally ablated, and they may or may not have this history that this nodule had undergone a thermal ablation in the past, is that going to affect or make their life difficult and maybe end up with a diagnosis of atypia or something abnormal, which might again, lead to excessive treatment?
Yeah, the short answer is we don't 100% know. There's not been very many people that had thermal ablation and then had their thyroids taken out. There were a few in the early experience, and you showed basically just necrosis. The tumor was dead, and you've killed 2 millimeters around it. So there's really not a lot of atypical stuff. I suspect if a pathologist looked at that, they'd say, okay, why do we have necrosis? Maybe it looks like a nodule that necrosed or something like that. So I think with that safety margin around it, we'd be fine. So, it's one of those things that I don't really worry. On the ultrasound, the ablation zone almost always goes away by a year or two. By 6 months, you can definitely see there's still scar tissue there. But by a year or 2 or 3, the ultrasound looks pretty darn normal. In fact, it's really hard to find where you ablated. So at least for ultrasound follow-up, you wouldn't be surprised if there was a place, but you'd also not be surprised if we're not left with anything big to follow over time.
Let's move on quickly to the next case. Now, this is almost a similar scenario, but in this case, it's a larger lump and the patient is having occasional breathing issues. Again, the biopsy is benign. And obviously, in this case, it is a little more clear that we are going to go for the surgery in her case. Now, again, the patient was a little bit scared of having surgery. So she underwent a repeat FNA, and this time she had a Bethesda 3, which was repeated again. So over a period of 1 year, she has 2 Bethesda 3s. And now this question is to Dr. Chowker. So, there is a large nodule on one side, and over a period of years, she has developed another small nodule on the other side. The larger nodule is Bethesda 3, the smaller nodule is benign. So what are your considerations? What is your approach first? Is it hemi or total? And if you're doing total, would you approach the big nodule first or the small nodule first?
So if I understand correctly, the second nodule is on the opposite lobe or the same lobe?
Opposite lobe.
It's in the opposite lobe. So this is the scenario that I was talking of in the first case, where it is now multiple nodules in the other lobe as well. And I have not used molecular markers because of them being expensive. I base my treatment on extent of surgery depending on the ultrasound characteristics, age of the patient, and the FNAC Bethesda. So Bethesda 2 becoming malignant, the chances are less. If it was 3, 4, them turning out malignant in a tertiary institute, the chances are higher. Because Bethesda classification has to do with your institutional incidence of malignancy. So Bethesda 2 becoming malignant are less. But this, I would treat it more like a multinodular goiter. She's developed a nodule on the opposite side. I would counsel her. Already she has pressure symptoms. I would counsel her for a total thyroidectomy.
So if you're going for a total thyroidectomy, would you approach the bigger nodule first, which is Bethesda 3, or would you approach the smaller nodule first? The reason I'm asking is whenever you approach any lobe, there is always your nerve at risk.
Right. So this works both ways, Earlier, our thinking was, if you have a bad disease on one side, when you're fresh and alert, do the normal side. But then the thinking set in that what if you damage the normal side? The bad side stays in situ, So I have changed my philosophy now. I do the bad side first, because if you get the bad side out, even if you run into problems, at least you have the normal side left back in the patient, which you can address to a later date. Suppose you lose your signal on table. You can come out. You can wait for the nerve to recover because you have a normal side setting into the patient rather than having a disease side in the patient. So I always now approach the bad side first, keep the normal side for later, depending on my extent of damage that I've done on the bad side.
So just to make this scenario what you are leading us to, that you do the bad side first and your nerve is weak. So you stop over there. In follow-up, you see that the nerve is still weak and the pathologist tells you that this is a 4 centimeter PTC. Now tell me, would you go for a completion?
Now, see that there are answers that you give on a panel and there are things that you do in real life, right? So I have not, I've rarely stopped my surgery even when I've lost signal on one side. See, you know, in thyroid cancer, you have locally advanced thyroid cancer, you resect one nerve, right? And you still do a total thyroidectomy on table. So it's good on a panel for me to say that, you know, look, I've lost signal, I'm going to stop and I'm going to come back in. I've rarely done that. I'm giving you a truthful answer. I do address the opposite side. Yes, if you have lost signal because of stretch and you know that you've really kept back the nerve, that's an option. You know, if you think the opposite side is also large, then you wait for it to recover. In our experience, 60 to 70% of the nerves which lose signal on table recover post-operative within 3 to 6 months. So if you're not in a hurry to remove the opposite lobe, that's an option for you to wait and then go back inside for the opposite lobe. But truly, let me be very frank, I've rarely done that in the last 10, 15 years.
So I'll just move to the next scenario where we will be addressing one of your part of your talk, which is about the central neck assessment. Now here we have a 50-year-old male incidentally detected multinodular thyroid goiter, and he has Bethesda 3 on biopsy, but his molecular markers show a feature which has a more predictor of having a cancerous nodule. Again, imaging is negative for any central or lateral neck node. So Dr. Chowkar, can you briefly tell us the difference between elective and the difference between prophylactic neck dissection, especially when you're inspecting, palpating, and doing thorough clearance?
Right. So therapeutic neck dissection is done when there are nodal disease in the central compartment, either clinically, radiologically preoperative, or intraoperative, you find large nodes in the central compartment. You clear that central compartment completely. Prophylactic neck dissection is done when there is no evidence of neck disease in the central compartment, but you need to do it because there are some indications that you have that this patient probably is either going to have disease in the central compartment or is likely to fail in the central compartment because of the disease character.
Palpation and comprehensive clearance.
Right. These are very fluid terms and it changes with surgeon to surgeon. You know, we really don't have a nomenclature. But in practice, what we do is, you know, just palpating really doesn't tell you whether there are nodes in the central compartment. You have to open that little bit of tissue over the recurrent nerve after you have identified the parathyroid and get into that paratracheal prevertebral plane. Where you inspect and then you palpate without doing too much damage. You have to open the carotid sheath and a little bit of fascia over the nerve and then see whether there are nodes hiding lateral to the nerve, and then you back out without doing much damage to the blood supply to the parathyroids. That's inspection and palpation for me.
And you know, when it comes back to elective neck node dissection, meaning image negative central compartment, I mean, this question is for Dr. Tuttle. The molecular markers, if they mention that, you know, this is something you're looking at a high risk tumor, would that guide us that we should be doing elective neck?
Yeah, I'm going to say no. There's a famous movie in the United States called "Build It and They Will Come." Is a line from that movie. I'll save you the trouble. In papillary microcarcinoma, central neck lymph nodes will be positive 50-60% of the time. They're there. They're 2 or 3 millimeters. There are 4 or 5 of them in that central neck. And if you do comprehensive, you'll find them. The trouble is they hardly ever make any clinical difference at all. So you enter this trap. The more elective surgeries you do, the more lymph nodes you find, and you feel like you're doing a good thing, but all you're doing is sort of reinforcing overtreatment. So in those ones, like on that one, you showed an HRAS tumor. HRAS tumors hardly ever have cervical lymph node metastasis until they're 4 or 5 centimeters. BRAF positive tumor is a little bit more likely. So on that HRAS, that would have made me be less anxious to do it. So I'd say no, we have to be really careful. Just because we can find lymph nodes with an elective dissection does not mean we've helped those persons. And remember, these are low risk papillaries. These are low risk follicular variants. You'd have to do a lot of good because those people are going to have great outcomes anyway. And if you harm leave one person hypopara, you damage one nerve. I think we've hurt more people than we've helped. In expert hands, I know we get away with that. But remember, people are getting operated all over the world. And in that elective prophylactic neck dissection, I really worry that we're hurting more people than we're helping. The few that have a recurrence in the central neck later on, that's fine. Go back and deal with that in a really comprehensive way to deal with it, behind the nerve, lateral to the nerve, reimplant that right lower parathyroid, right, do the real neck dissection. But that way we're saving most people from getting it. So that's my bias, because I get to see a lot of people that have had those surgeries, and there are significant complications.
Thank you so much. No wonder they call you a surgeon.
Yogesh, can I add something here? I completely agree. And the complications are, I think, completely underreported in literature. We see a lot more nerve palsies, be it temporary and permanent. We see a lot hypoparathyroidism. The more you do extensive surgery, you are going to land up with complications. You may not report your complications, but they occur in real life.
And that is so important, to have really, really good surgeons just say that out loud, right? I mean, the more surgery they do, it's just common sense. You know you're going to have more. So knowing that, then you look at that 30-year-old patient with a little small tumor and go, okay, how much good am I really doing? So agree with you totally.
Thank you. So let's move on to a pediatric case. We have a child, 9-year-old female, and she presents with a neck mass on the right side. There's no family history, no radiation exposure. She gets a scan which shows a diffuse enlargement of the right side, about 4 centimeter with punctate calcification. She gets an imaging. There are no obvious nodes. So let me ask this question to Dr. Bauer. What is the difference between the presentation of pediatric thyroid nodule and adult nodule? We know that pediatric thyroid nodule have a more chance of having a malignancy. Any characteristic differentiations between these two?
No, in fact. So, if you take just the general description and you say pediatric thyroid nodule versus adult thyroid nodule, there's an increased risk of thyroid cancer. It's about 3 to 4 times, depending on which data you look at. But then if you stratify based on what the ultrasound looks like, pediatric patients have benign lesions. They have non-invasive forms of thyroid cancer, and then they have more widely invasive forms of thyroid cancer. So overall, the risk is higher, but then the ultrasound is similarly helpful in stratifying whether it's a pediatric patient or an adult patient. Not only what the nodule looks like, but what the lymph node status is. And that's what you use then to decide if you're going to do a biopsy or not. So it's the same approach, despite there being a higher risk.
And Andy, is there any difference in, like, I mean, I get an email every once in a while about a 3-year-old or a 4-year-old with a nodule as compared to a 14 or a 15-year-old. Do you think about those as differently or the same?
It's continuously, as you know, Mike reported, and I'm actually just reviewing another paper about prepubertal versus pubertal. So the numbers, there's more adolescent patients with thyroid cancer and more numbers with invasive thyroid cancer. But if you look at prepubertal patients, they seem to be more likely to present with more invasive thyroid cancer. So it's not like it's not present in adolescents or in adults, as you guys know more than I do. But it is more common, I think, in the prepubertal versus pubertal. But again, it's not thyroid cancer, it's what that patient has on their ultrasound. And then, you go from there.
Yeah, that was the second question about the age categories, which Dr. Bauer already answered. So Dr. Bauer, are there any molecular markers, especially in the pediatric category, that will help us to complement our biopsy results?
So the only testing has shown clinical utility in pediatrics, because I think there's enough data now, and some of the data is on post-operative samples, not all on cytology. But we know the oncogenic landscape in pediatrics. We don't know the RNA-seq, the gene sequencing classifiers. We don't know microRNA data. So the only testing that is helpful is somatic oncogene analysis. And then you have to have a panel that's, covers the broad known driver alterations. And again, similar to adults, as Mike just mentioned, there are certain oncogenes that are associated with less invasive cancer, like RAS, PTEN, DICER1, PAX8, PPAR gamma. And the difficulty, of course, with those is they can be benign and they can be poorly differentiated. But again, it depends on what that individual patient has on their ultrasound that help predict if they have a RAS mutation and it's encapsulated and it's a solitary nodule, it's going to be a benign or a non-invasive thyroid cancer. It's unlikely to be poorly differentiated. And then the more widely invasive ones, as you're showing in the ultrasound here, that don't have a capsule, that just seem to be widely infiltrative, are more likely to be either most likely to be a fusion, with RET fusions being the most common, and not just RET PTC, but now there's an increase. There was already enough RET PTCs, right? I think we're up to 8 or 9 or whatever we're up to. But now there's even more unique RET fusions if you do broader oncogene panels that have a more comprehensive fusion analysis. So RET fusions, NTRK fusions, NTRK3s are more common than ones, but they're both present. ALK fusions, BRAF fusions. All the fusions are more likely to be associated with infiltrative. And then in between, there's BRAF. BRAF can be encapsulated, it can be infiltrative. But that's kind of the landscape currently in pediatrics, that it is helpful. It is, it does predict histology, as I'll mention on 1 or 2 slides in my talk. But it still comes down to the individual patient, what they have on their ultrasound, to how to interpret the oncogene analysis and what to do with it. And if we can get approval to get it paid for, which is another obstacle in pediatrics. So.
This question is for Dr. Tuttle. You know that doing a biopsy on a child is challenging. There are high chances you'll get a suboptimal result. So what is your take on doing a thyroglobulin washout in case the result is suboptimal?
So I don't know anything about biopsying kids because I send all those to Andy. And we've got a peds endo group that takes care of all that for me. So I see him down the road. We routinely do thyroglobulin washouts in the setting of lymph node metastasis outside the central neck. You have to be careful in the central neck because it's usually in the recurrent setting, right? They've had a surgery. Central neck, what you think is a lymph node, sometimes is normal tissue, and you can get really high thyroglobulin washouts. So our standard practice is if we're biopsying any lateral neck lymph node or even upper mediastinal lymph node, we routinely get a thyroglobulin washout. Most of the time, I don't need it because the cytology is pretty darn good. But every once in a while, you get like this sort of, there's epithelial cells, we're not sure what it is, and the thyroglobulin number comes back at 500. Well, that tells you what it is. We get a lot of thyroglobulin washouts of 1 or 2 or 3 that probably are not cancer. Once that washout gets to be more than 10 or 15 or 20, it's almost uniformly thyroid cancer, as long as you're doing it in the lateral neck. So we don't even think about it anymore. If we're biopsying lateral neck lymph nodes, it's automatic cytology and TG washouts. It's an automatic process.
Yeah. Thank you so much. Let me ask this question to Dr. Bauer again, that not this nodule, but if the nodule is very benign looking, any role of T4 suppression in pediatric age group to regress or kind of solve their problem?
No, it's been looked at. There's some data that maybe in patients that are oncology survivors that develop thyroid nodules that it may help as far as leading to regression, but it's absolutely uninformative. And then you're treating a patient that has a benign nodule with levothyroxine, which is a benign medication, but it still is a medication that requires labs. And so it hasn't shown, one, to help predict malignancy versus benignity. So whether it grows or not has nothing to do with it. And 2, then you're not addressing what the nodule is. And if it's benign, it's benign. And if the data is that, then it's reassuring. And if it drives the family crazy, then you talk about if there's something we should do about it surgically, like lobectomy. And if it's, I just don't see a role for T4 and TSH suppression to help determine what the nodule is and what to do about it. I think it's just better to address it with ultrasound and FNA and just normal approach that we would use in an adult setting as well.
Thank you. So we did a biopsy of this patient. The patient had a biopsy and it was positive for malignancy. So Dr. Chowker, can you tell me, like, how would you approach a pediatric nodule which is biopsy proven malignant, considering that the other lobe is normal?
Yeah, Yogesh, see, if you look at the guidelines that tell us, they use this word in majority of the cases, you will do a total thyroidectomy. And they have used this word because most of the cases in pediatric will present in an aggressive manner with lymph node metastasis. And the presence of lymph node metastasis is a harbinger of distant metastasis or lung metastasis, which are often not picked up on an X-ray and picked up only on the first radioactive iodine scan. And that is why they are saying majority, they have changed their language. In adults, they say always do hemi, don't go do more. But in pediatric, where you're likely to have more complications, they have said majority of the time do total. Now, I don't think that's the right way to do it. You have to go by case to case. If this patient does not have aggressive tumor, use your guidelines and do only a hemithyroidectomy. You don't need to do total thyroidectomy just because he's a pediatric age group. He's not likely to have metastasis if he does not have lymph nodes in the neck. So I would do a hemithyroidectomy for them.
And
so Yogesh, in our hands, if this was an adult with that ultrasound, we would not believe for a second there were no lymph node metastasis. As Andy mentioned, right? This is not what a RAS tumor looks like. This is a papillary thyroid cancer. So we would be saying, okay, let's go back and look at the ultrasound intraoperatively. We're not going to be surprised if we find it. It's what Andy was saying, right? It's this individual case to have a nodule this big that looks like that with no lymph node metastasis. It's possible, but man, I'd be really surprised intraoperatively if that's what you found.
So I'll agree with both. One, the 2015 guidelines were not adequately stratified, right? We talked about papillary thyroid cancer as it had no variance, right? There was no discussion on variance on ultrasound features outside of minimally invasive follicular thyroid cancer, which had a small section in our 2015 guidelines. And our next version, which we're currently working on, we go into the data that Dr. Chokar just mentioned. Like you're not going to do a total thyroidectomy if all you have to do is a lobectomy to achieve surgical remission. And so the same is true in pediatrics, and I absolutely agree. You can't just blindly remove all the pediatric thyroids if they have a positive biopsy, Bethesda 5 or 6. Our goal is to save healthy tissue while at the same time, achieving remission when possible. To Mike's point, absolutely, this looks like a widely invasive follicular form, a widely invasive form of papillary thyroid cancer, which is either going to be classic widely invasive follicular variant PTC or diffuse sclerosing variant PTC. It has a high chance of bilateral disease, even if the preoperative ultrasound does not show a lesion in the other lobe. But I'd be surprised that there weren't even ultrasound evidence of intrathyroidal symomic calcifications. There's going to be bright spots in that other lobe, is more likely than not. More likely than not, they have level 6, potentially 7. And I would really look at the lateral net, because we have had some patients that were caught early that don't have N1B disease, but you really need to make sure before you go to the OR that someone who knows what they're looking for is holding the transducer and doing an adequate neck ultrasound, because this patient would benefit from a total and some degree of lymph node dissection, depending on what the ultrasound showed.
So Dr. Chowkar, coming back to you, that, since we are looking at something aggressive in a child, we think about doing total with some form of central neck dissection. Can you tell me in a pediatric setting, what are the nuances of handling the central neck? And you already mentioned that the chances of having complication are very high. So this child is going to have rest of her life probably, risk of a voice injury or parathyroid and leading hypocalcemia.
Right. So yes, and I completely agree. If you find nodes either preoperatively or intraoperatively, the extent of surgery is going to change, because then this is more aggressive in the pediatric age group. So yeah, as I said in my talk, that handling or identifying the parathyroids is a challenge. They are more translucent. They're not the tan brown color that you see in the adults. So identifying and preserving the parathyroids is a real challenge. More importantly, in clinical practice, I don't know if it's reported, and I would like to have opinion of the other panelists here, is that the nerve is more sensitive in the pediatric age group, is my understanding from whatever little pediatric thyroid cancer I've treated. In adults with neck nodes, you dissect the nerve, you remove the nodes, you completely bed the nerve, you retracted the nerve, and the nerve functions. In the pediatric age group, you touch the nerve a little bit and the nerve goes into temporary palsy, has been my clinical experience. So I don't know whether that has been reported or that is true, but yes, there is higher chance of parathyroid injury and higher chance of at least temporary nerve injury because the nerves are very sensitive, is my clinical feeling.
Thank you. So we are looking at surgical choices. We try to be aggressive. Dr. Chowkar mentioned that the chances of complication are very high, but we also are aware that radioactive iodine in adults and radioactive iodine treatment in pediatric is a completely different ballgame. We are aware of the high risk side effects and the chance of secondary malignancies. So this question is both to Dr. Tuttle and to Dr. Bauer, that if we are a little more aggressive in the initial surgery, and let's say in the hand of experts like Dr. Chowkar, where the chances of complications are less, would that lead to a lower reliance on radioiodine as an adjuvant setting, and this will prevent the side effects of iodine in pediatric age group?
So as a pediatric endocrinologist with my surgery hat that Mike apparently wears once in a while too, maybe even more frequently than I do, we don't have the data. We think it clinically, right? That the most important thing is that the right surgeon does the right surgery, right? That's the absolutely most, which requires that the right ultrasound was done prior to the person even seeing the surgeon, or at this, prior to going to the OR. So it just makes clinical sense that the more you can resect without causing complications, the less likelihood the need for radioactive iodine, or potentially the lower the delivered activity of radioactive iodine and the higher the chance of achieving remission. But all of that has not been ever proven in a prospective study. So, lack of data doesn't prove a lack of benefit. And there really still is a benefit to making sure that the right surgeon does the right surgery in every patient, let alone in pediatrics, where they have a longer lifetime to deal with, whether it's medical complications or surgical complications.
Yeah, I agree. I mean, while I'm not a big fan, obviously, of central neck dissections, if somebody does it and there's 6 benign lymph nodes, that makes you feel more reassured, right? And then the post-op thyroglobulin is undetectable. That makes you more reassured. I think that's probably too high a price to pay with side effects to let me sleep better at night. But, it definitely goes into the risk stratification. At least in the adult setting, if you take a lobectomy or a total and you take out a few little millimeter-sized lymph nodes, I'm not going to give radioactive iodine. If you don't take them out, I wouldn't know about them. I'm not going to give radioactive iodine. So I told Greg Randolph before, knowing that there's some little positive lymph nodes doesn't change my decision. I'm not giving radioactive iodine either way. But it's different in different parts of the country, right? In different parts of the world. Some people do want to see those negative lymph nodes. Otherwise, everybody's getting radioactive iodine. But I find that, to me, that's just not a good risk-benefit balance ratio in those people. Their risk is already so good. And I think we don't have to make a decision 6 weeks after surgery. This is papillary cancer. This is not melanoma. This is not pancreatic cancer. That you can make a decision in 3 months and 6 months and see what the thyroglobulin looks like, see what the ultrasound looks like. If you have the bad luck, somebody has a rapid recurrence in the first year, we all know radioactive iodine was not going to touch that. That's not the tumor radioactive iodine works on. Radioactive iodine kills stuff that's going to change over years. So I try to get my young folks away from making an absolute decision right now if it's not really clear, and then reevaluating when they come back.
We won't have time to talk about it, I don't think, but I'm actually a believer in prophylactic central neck in pediatrics, and actually converted even lobectomy with prophylactic central neck. But again, I think it's institute dependent. So at our institute, we've performed over 800 thyroid surgeries between 2 surgeons in 10 years, and the complication rate is less than 1% for hypopara and damage to one recurrent laryngeal nerve and no bilateral recurrent laryngeal nerve damage. And so you really just have to understand where you are and what the patient has and what information you're trying to gain. But there are some data in pediatrics. The most recent was Sugino, even looking at papillary thyroid cancers and doing lobectomy with prophylactic central neck, not to impact disease-specific mortality, which thankfully in pediatrics is amazingly low, but to help define the behavior of the tumor and if a completion would be worthwhile and if radioactive iodine would be worthwhile. And so there are some data now, and there's even multiple studies with dynamic risk stratification using our pediatric ATA risk levels that incorporate lymph node numbers, which the 2015 guidelines said incidental. We realized that was annoying, but there's actually data now, maybe less than 5 is being reassuring, even if they're microscopic lymph nodes, to help define that that's a low risk patient that wouldn't benefit from radioactive iodine and doesn't need a completion. So there are some data in pediatrics. Again, though, it has to be, you have to understand it. You have to have an institute where you know what the risks and benefits are, and you have to have a patient that's informed of what the risks and benefits are to go through it. It takes much longer now, I think, for me to talk about this with a patient for a disease that 99% of our patients survive than it did 10 years ago when we just approached it all the same. So stratifying has been a benefit, but stratifying is more time consuming, absolutely.
So if you decide that any pediatric case is going to go for an adjuvant radioiodine treatment, can you brief us on the dose recommendation, and would you be based on the size, weight, empirical or dosimetry techniques?
I'll talk about it in my talk, so I won't go into it much, but there isn't set dosing. So one, ablative radioactive iodine we're trying to get away with. We talked about that in our 2015 guidelines, that there's just no benefit to using radioactive iodine ablation. What we're trying to use is therapeutic radioactive iodine therapy for persistent post-surgical disease. And so within that context, then you have to know what the histology was, you have to know what the degree of metastasis was, and I believe anyway, and if you're going to go through the post-surveillance evaluation, looking at the diagnostic whole body scan to help determine which patients you might benefit from radioactive iodine. And then depending on where the uptake is and what the disease was, then you can do empiric or dosimetry, and I won't talk about it now, it's in my talk. Again, there's no great data one way or the other. Most of us use empiric dosing and weight-based dosing depending on where the uptake is and what we're trying to show. But I have a couple of slides in my talk, so I won't go into the details.
Sure, we'll look forward to that. So as you know, this patient had a total thyroidectomy with central neck dissection. And the pathology is in front of you. It's a 3 centimeter PTC and a microscopic extrathyroidal extension. Now let's come back to the other topic, which is surveillance in pediatric thyroid cancer. So if Dr. Tuttle can brief us, what is the value of thyroglobulin? Does thyroglobulin level indicate the burden of disease?
Well, I'll talk about it sort of in young adults, then Andy can weigh in because the kids are a little different, but it's fairly similar. I would point out your central neck dissection found exactly what I told you it would find. I could have predicted that without a central neck dissection, right? There's your little 3 lymph nodes and they're 3 millimeters. So we know they were there. Thyroglobulin is a great tumor marker. Just like calcitonin, it does not always correlate to burden of disease, right? There are good TG producers and there are not good TG producers. The well-differentiated, the fusion genes, the kids tend to be well-differentiated. If anything, sometimes they're too well-differentiated because I don't think I can cure any of them anymore. Our assays can read down to 0.1. So I look more at the trends in the thyroglobulin over time. In adults, the suppressed thyroglobulin less than 10 is usually lymph nodes in the neck. In the lungs, it's usually 20, 30, 50, a few hundred. In the bones, it's in the thousands. So, you can use those as rough estimates. And the other thing patients have to understand is if the thyroglobulin doubles, that doesn't mean the tumor volume is doubled, at least in what we can see, right? They have to disconnect that. In the United States, there's all these tumor volume doubling times, and that's part of our work, and it's my fault. I saw somebody last week who her thyroglobulin doubling time was 6 months because it went from 0.1 to 0.2. And to Andy's thing, that was an hour's discussion and somebody that was cured, and I was hating myself. So understanding where to put those. So good marker, following the trend over time. And then last concept, never order a thyroglobulin without a thyroglobulin antibody. I don't care if the thyroglobulin antibody has been negative since they were 6 years old. Sometimes the first indication of recurrence is a switch in the antibody. So here at Memorial, it's actually impossible to order a thyroglobulin without the antibody automatically coming as part of that. So put those two together.
Dr. Bauer, would you like to add something?
No, it's exactly right. So, thankfully in pediatrics, most of our papillary cancers are differentiated and they're fair to robust thyroglobulin producers. And so there is some, correlation between the degree of thyroglobulin and the burden of disease, but it's certainly not 100%. And we have patients that are in this, whatever you want to call it, smoldering, non-specific, less than 10. And if it stays there and their ultrasound's negative, then we just keep surveilling them. It's only when we start to see a trend going up. And again, absolutely it's always a TG, anti-TG. It should just be written and said at the same time. It's all one word, but it's the same. So we follow for surveillance, we typically do, post-surgery. I'm an every 3-month believer for the first year or two. I think most of our patients are unwilling to wait for 6 months, but there are some people who will go to 6 months post initial treatment. And then it's not just the number, but it's the trend and following what they do and always comparing it to what the TSH is.
Thank you.
Yeah, and
I'm surprised they only had 3 lymph nodes though, and this was microscopic. So
yeah, for this case, I agree. But for the other, yeah, and we do our first thyroglobulin about 6 weeks after surgery because the point that Andy made, was this concept of deciding on adjuvant therapy and treatment of known disease is no longer just the path report, right? Think about all the stuff that he said, all the pre-op imaging, the intraoperative findings, the post-operative thyroglobulin, diagnostic whole body scan. If I don't know who the surgeon was, I may do an ultrasound post-op. So all of that information. So we look at that over sort of the first 6 weeks. We typically grab our first thyroglobulin in about 6 weeks because most adult patients will wait that long and not much longer. And then if everything is fine, then 3 to 6 months, depending on what I can negotiate them to.
Thank you.
And there are some data even at this 6-week mark now in pediatrics that we're reviewing to hopefully incorporate in our revised guidelines about the stimulated TG, whether you're using radioactive iodine or not, to look for persistent disease, to Mike's point. So it's not just obviously a whole body scan. If you're doing a whole body scan, you're getting a stimulated TG. But even if you're not, you're just doing an ultrasound, knowing what the TG is early kind of helps you, at least it's suggestive of how thorough the resection was and what's the likelihood of persistent disease. It's not perfect, but it's at least informative.
Right, and how hard you need to go look for other things, right? I mean, especially in the PEDS case, if you get a really high bounce, maybe pulmonary nodules or that sort of stuff.
Right.
So
we've seen that they're like 250. I'm like, well, that was clearly not time for radioactive iodine. This person needs reevaluation of their neck because they have persistent disease. And sometimes it's after they've already had the whole body scan that shows multiple uptake in the neck. And I tell them, you would have known that without that by just looking at the TG, without putting the patient through a 2-week low iodine diet.
And Dr. Bauer, could you tell us your take on TSH suppression in pediatric age group?
So we follow the adult guidelines because there is no data in pediatrics. In fact, I just emailed Matt Ringel and to try to get what their update is for their revised, whatever we're up to, the 4th version, which has now been separated into 2 treatises because they're so massive for the ATA guidelines. So if it's invasive disease, high risk for persistent disease, we try to get it to less than 0.5, less than 0.1. Although it's not a scientific process, it ends up being somewhere in that ballpark. Depends on what the dose you use, without making the patient symptomatic. And if it's low risk disease, as far as a low likelihood and low evidence of metastasis, we try to keep it around 0.5 to 1. So it's within our ATA guidelines, and we try to follow what the adult guidelines suggest. Maybe someday we'll have some other pediatric data. The one question, and we have hopefully some research coming out next year, is what's the risk to, especially if you do TSH suppression, to bone mineral density during a time of acquisition? There hasn't been, unless people just aren't informing us in the adult world, people with osteopenia, osteoporosis that are papillary thyroid cancer survivors from pediatrics. So clinically, we haven't seen it, but that is an important question to know. Again, what's the risk of TSH suppression versus what's the benefit of TSH suppression? So there are some data that we're still looking into, but for the most part, we follow the adults as long as the patient isn't symptomatic and try to hit the same targets.
Thank you. So as you can see in surveillance, the child had a right-sided level 2 lymph node, and because it's quite common for children to have level 2 lymph nodes. So initially, nobody intervened in this. But over a period of 1 year and almost 2 years from the initial treatment, it was a stable lymph node, about 2 centimeters. A biopsy was done, which showed a reactive node, and you can see the trend of the thyroglobulin is going up. So let me ask this question to Dr. Chowker, that you have a child, right level 2 lymph node, which is persistent. Now the thyroglobulin trend is increasing. What would be your approach to this neck?
A tough one. Unless I know that this is probably a reactive node, FNAC is said is reactive. Unless there's a marginal increase in thyroglobulin, but if the node remains stable, if the ultrasound characteristics don't change, and the size doesn't go up. See, this is the lateral neck, right? So lateral neck, I can go in at a later date and it won't affect the prognosis. And I can easily clear the lateral neck even at a later date. So till the size, the characteristics of ultrasound remain the same, I don't have an alarming rise in the thyroglobulin. I'm not worried. I'm not going to rush in to do surgery. I'll keep this patient under surveillance and go in when any one of these things change. Either the thyroglobulin goes up, the ultrasound characteristics of the node change, or the node increases in size and I get a positive FNAC of the node.
Dr. Tuttle, would anti-thyroglobulin antibodies guide us if we need to address the neck, if that trend is rising or they are stable?
Not really. The antithyroid antibodies are kind of surrogate markers. Sometimes they go up when somebody's having recurrence. Sometimes they don't. Even when they go up, they don't always mean recurrence. So I do follow the trends over time, but I've got a healthy disrespect for them. If this was in a teenager and adult, the first thing we would do is a CT scan of the neck and the chest, because you got a thyroid globulin that's slowly growing up, right? Your ultrasound's not showing you anything changing. So we'd be looking other places in the lateral neck and upper mediastinum, and where's the lymph node that we were missing? Because we have to go back to where this kid started. That first ultrasound that Andy and I were so worried about those lymph nodes, they're still there somewhere. And I see some of these people get followed years and years and years with ultrasound, and then you do a CT scan, and in 2 seconds you find that lymph node that's high on the right side that you can't see, or deep to the carotid, or in the upper mediastinum. So with this trend going up, I'd be worried, thinking probably lymph nodes, but in a kid also worried a little bit about pulmonary mets as well. So at least in our older folks, we'd be doing CT scans to take a look and see if we could find it.
So if you, Dr. Chowker, I'll come back to you that, Dr. Tuttle mentioned his concern about having lymph nodes elsewhere.
Yeah.
And we did imaging and we found that there are nodes. Now, just how would you address if it's a selective right neck level 2 node and it is, let's say, biopsy positive for malignancy? Would you do a compartmental, just a level 2, or would you do a full modified neck dissection for a child, considering the morbidity?
Yeah. So first, I completely agree that if the thyroid globulin is going up, we probably get a CT scan done and check for other sites. If there are no other sites and this is the only site, if this neck has not been addressed previously, then I would do a comprehensive clearance of the neck. If this neck has been addressed very well, completely in the initial and just a recurrence, I'll probably clear that level. But if not addressed, I would do a comprehensive neck dissection, not just a nodal excision at level 2. I'll do a comprehensive neck dissection.
Thank you. And let me just to summarize this case, I'll come back to Dr. Bauer. That can you brief us on the use of radioiodine for regional and distant metastasis?
Sure, just 2 quick comments. One, again, the ultrasound looks like a widely invasive, infiltrative form of thyroid cancer. And if it's diffuse sclerosing variant, they may have had positive antibodies. And if they're decreasing, that might also affect what the persistent TG is if they didn't get radioactive iodine. And 2, other locations, this is level 2, which are notoriously hard. They look shape-wise, it looks okay. It looks like a hilum. We don't see Doppler to know what the flow is. But level 7 is not uncommon. So if you do your own point of care ultrasounds, taking the transducer and just angling it down is informative, especially turning on Doppler. And every once in a while, you'll find them just hiding right along the upper part of the clavicle, especially 2 or 3 fingertips in from the sternal notch. And again, you just have to take your transducer and just kind of rock it along the carotid and you'll find lymph nodes there. So for someone who just had central neck disease, I'd be looking more in the lower central neck, lower level 4 than level 2 as far as a likelihood of having persistent disease. And as far as doing a completion or not, I guess we won't go into that. But we occasionally do partial laterals. It depends what the ultrasound shows. But I won't be a surgeon, and we're probably over time to talk about what an actual surgeon with more information has as far as when they're in the OR and the risks and benefits of that. For radioactive iodine, again, it just depends on what the histology was and what the lymph node metastasis was, and what the post-op TG was, and if you performed a whole body scan, what that was. So I'll show a slide where I kind of come up with, but it's 1 to 1.5 millicuries per kilo, for central neck disease, 1.5 to 2 for lateral neck disease, and 2.5 to 3 millicuries per kilo for pulmonary metastasis as empiric dosing. And then you kind of adjust that based on what the histology was, the degree of metastasis, and what your post-operative data is. And so we use it only when we think it's of therapeutic benefit, and when we think that the benefit outweighs the need for repeat surgical dissection. So we don't treat bulky lymph node disease with radioactive iodine, right? If you have persistent lymph node disease, it's a centimeter or bigger, your ability to clear that with radioactive iodine is amazingly low, unlikely. You're better off, if it's a single node, considering ablative techniques. We occasionally use alcohol. We also are incorporating laser, or resecting it and then seeing if they even need radioactive iodine at that point. but you can't treat bulky lymph node disease and clear it with radioactive iodine.
So in sake of time, we have to cut short our discussion. Before we take off, I would just like all the three esteemed panelists to give one message to the audience based on their practice. So let me start with Dr. Tuttle.
So I think the one message is we've made thyroid cancer very complicated. It used to be easy, one size fits all. It's not. I have longer discussion with the low risk than the high risk. But I think what you heard here is sort of 3 or 4 people thinking out loud about not just a path report to decide what to do, not just an ultrasound image to decide what to do, but in the context of that patient's. That means we're moving thyroid cancer to oncology thinking and not just traditional surgery and endocrine thinking. So I think that individualized, risk adapted, making sure that you have all the information together to make decisions in all aspects from surgery to neck dissection to radioactive iodine is really key. And I think you've done a nice job in these cases, allowing us to sort of think out loud about those issues.
Dr. Bauer?
I agree. As I mentioned, it definitely takes longer now to counsel patients than it did previously. So for pediatric endocrinologists and adults that may happen to see kids, stratifying disease is important in pediatrics as it is in adults. And for pediatric endocrinologists, learning how to at least read an ultrasound, if not actually perform and read an ultrasound, is a task that should be undertaken. Everyone can learn how to perform and read an ultrasound, and you'll be surprised how informative it is to you as a thyroidologist, rather than relying on a report. You just have to do it, and it's not a complicated skill, and it's actually kind of fun. Again, it's not a time saver. It's not going to save you time in clinic, and we don't charge when we do point of care ultrasound, but it's unbelievably informative. And then the other thing is making sure, because we have on our panel, you've partnered with a good surgeon, and now even an oncologist, as I'll talk in my talk. But you need the full spectrum of people that are as passionate about this disease as you are to make sure you provide the best care.
Thank you. And what is your message, Dr. Chowker?
I'll talk from a surgeon's perspective. You may be the best surgeon in the world, but you don't have to do surgery just because you're good. You have to balance risk-benefit ratio. Really, you have to think hard, because that one patient that you make hypoparathyroid or injure the recurrent nerve, he's going to live and he's going to come back to you, and you're going to have sleepless nights over that. So really be careful about what extent of surgery. As a young surgeon, you always want to, you are confident that you can do extensive surgeries in oncology, but that's not the way you treat thyroid cancer. You have to balance your risk-benefit ratio.
Thank you so much, our excellent panelists. It was a great discussion. We will come back to you in panel with the question answers related to your talks. So we are going to move on. I'm just going to hand it over to Dr. Basha.
Yeah, we have Prof. Bauer here, so I think his talk is next. We are a little behind time, but I think we really enjoyed the talk. So I don't think we should be under pressure to cut down your talk or anyone else. So let's go ahead, please.
Okay. So my assigned task for today was to talk about haploid thyroid cancer and specifically pulmonary metastasis and what the right treatment is for our pediatric patients. So first, thank you for the invitation. Thank you to the steering committee and for actually the conference assistants who've been really wonderful and making sure I'm organized and on time to submit things. I'm honored by the list of presenters to be included in that group. It really is a esteemed group that I've looked up to and actually been mentored by over the years. And so I'm happy and lucky and honored to be a part of that. And then of course, thanks to the attendees who are listening to us as we hopefully provide some information and hopefully hear some questions from you too as well. So I don't have any disclosures on this particular topic. As I mentioned in the tumor board discussion, I am on the committee now that's revising the ATA pediatric guidelines. So what I'll mention is my own opinion, but much of this is being discussed and much of it hopefully will be included in our revised guidelines, which probably will come out the beginning part of next year is what our goal is, but please don't hold me to that and hunt me down if that's not true, but that is the goal, that we get there. So how many pediatric patients have M1 disease? And M1 disease in pediatrics, for the most part, with uncommon exception, is pulmonary. We're going to mostly talk about papillary thyroid cancer because that's the more common across all of our age groups. And between the differentiated forms of thyroid cancer, that's the one that most commonly goes to the lungs. So if you look at national data, this is US national data, just looking at reported data in kind of an insurance or tumor registry kind of format, you can see the percentages for pediatrics having lymph node metastasis and lung metastasis. And for people practicing, I think both of these are a little bit on the lower side, which I'll show you on the next slide. But if you look at it compared to adults, it still is higher than adults. So it's more likely for pediatric patients to have regional metastasis and more likely for patients to have pulmonary metastasis. This slide reviews a study that Christoph Reiner's published in 2013, and then individual, not just registry data, but individual institute data and a summary table showing what the incidence of pulmonary metastasis, and it's actually more likely 15 to 25%. So it's a fair number of pediatric patients that present both with regional and distant metastasis. To our luck, as we talked about in the previous, much of this is differentiated. And so disease-specific mortality, even with high burden of disease, is low in pediatrics. So 99% of our patients survive disease. And it really is our mission, even though it's harder and it takes longer and it's more complicated, to stratify care, because some patients will clear disease with a lobectomy. Other patients may never clear disease if they have pulmonary mets, despite giving multiple doses of radioactive iodine. And how do we approach that with each individual patient? What you'll see in this survival curve, though, is patients with distant metastasis will have a lower disease-specific mortality. So even if it's still in the 90s, which is a benefit, we do have patients who die from disease, either during pediatrics, from either the primary tumor or potentially from overtreatment and lung fibrosis, or ultimately later on when they eventually have progression of disease. So we always say lifelong surveillance is important, but it's particularly important, of course, with patients that have pulmonary metastasis diagnosed during pediatrics. The lymphatic drainage of the thyroid is shown here just in a cartoon format. And as we all know, it goes from the thyroid typically to the central neck, and central neck then to the lateral neck, and then from the lateral neck, it enters the lymphatic chains, and it can go distally, most commonly in pediatrics, to the lungs. There are patients that have skip lesions. They'll have relatively little regional metastasis, but still have pulmonary metastasis. I think in practice, when that happens, oftentimes it's noted on a whole body scan, and it's less likely to actually have anatomically detectable disease. But it is possible. In Stephen Wagesback's paper from last year, skip lesions were reported in about 5 to 15%. I just looked at our cohort as I was preparing our talk. We've had about 226 patients in the last 11 years with papillary thyroid cancer with primary operative and radioactive iodine care provided at our hospital. 20% have lateral neck disease, N1B disease, and of those, up to about 50% will actually have M1 disease. So we've had almost 40 patients in the last 11 years that have had pulmonary metastasis. So in 2015, when we published the guidelines, we said radioactive iodine is the only effective medical therapy and happens to be the only therapy that's cidal. And in 2022, that still holds true. So radioactive iodine really is an important part of our treatment for patients with pulmonary metastasis. Most patients that are picked up with pulmonary metastasis, it's either during initial preoperative evaluation, if they happen to get a chest CT, or during the postoperative time based on what their TNM was, if they had lateral neck disease and they're going, or enough invasive disease that you're pursuing postoperative stimulated TG and a whole body scan, that you pick it up. Chest X-ray is listed as a possible way of detecting pulmonary metastasis. It's not very sensitive, but if you do see it, it's highly consistent with having high burden, a high amount of pulmonary metastasis. And this is just a patient, a late adolescent, who presented actually with some mild hypoxia, who you can see the burden of disease they had at the time of surgery. So how do we prepare patients for radioactive iodine? It's the same, I think, or similar between pediatrics and adults. So these are the recommendation numbers from our ATA guidelines. Our patients go on a low iodine diet for 2 weeks. There are some discussions about if 1 week's adequate. I provide 2 references there. We mostly pursue thyroid hormone withdrawal rather than recombinant human TSH. There are some data in pediatrics, again, quite limited as far as, yes, we know recombinant human TSH will increase the TSH, but will it actually is it similar as far as destroying tissue? And there's really only 1 or 2 studies in pediatrics. It's all regional disease. There are no data in pediatrics to look at preparing patients for radioactive iodine with pulmonary metastasis with recombinant human TSH. So for the most part, we're using thyroid hormone withdrawal for most of our patients, even with regional disease, and certainly for our patients with M1 pulmonary mets. Salivary gland clearance, I'm a believer. Again, it's up for discussion. Some people believe, some people don't. There's almost no risk to it. So we typically initiate it within a couple hours of administration of radioactive iodine and continue it every 30 to 60 minutes for 24 hours based on data from Doug Van Ostrand at Washington Hospital Center. So the question which came up actually in the tumor board is, how do you decide on the delivered activity, the amount to give? So empiric versus dosimetry. If we think about dosimetry, there's at least 2 ways of thinking about it: highest safely administratable, and that's mostly to make sure we're not over treating and causing bone marrow suppression. And we look at total body exposure as well as bone marrow suppression. The other way of thinking of dosimetry is low is reasonably achievable. That's mostly for lesional dosimetry. And most of our patients, pediatric patients, if they have pulmonary mets, have diffuse micronodular disease. And so if you use dosimetry, it's less likely you're going to use that form of dosimetry to identify it. And in fact, even RECIST criteria when we get to defining refractory disease is almost unusable in pediatrics because we have micronodular disease, not macronodular disease, if we're deciding if and when it's refractory and if we're thinking about systemic therapy. Between dosimetry and pediatrics and empiric dosing, there's no comparative data. There's never been a prospective study looking at both of these, but there is a nice review article that I list as a reference at the bottom that was almost 10 years ago now, but it still is applicable even today. So our AT recommendations were the first dose is typically empiric. We think about dosimetry if there's diffuse pulmonary metastasis in patients that are younger. So potentially less than 5 we would think about it, potentially less than 10, but even in those patients in our institute, we typically start with empiric, or if they have limited bone marrow reserve for whatever reason, that's a clear indication to think about dosimetry, so you're not over treating them and worsening their bone marrow disease. If you look at what's happening in the world, there's not that much data, but this is a nice data publication from 2018 looking at a couple of different practices across different countries, mostly Europe and then the Middle East, as you can see listed at the top here. Looking at 2 things: do they use diagnostic whole body scan to help determine dosing, and then do they use weight-based empiric dosing, age-based, or dosimetry? And you can see across the board, it's kind of mixed for diagnostic whole body scan, which I'm a believer in, plus minus SPECT CT, and most patients are receiving only empiric treatment, not dosimetry. The Netherlands have a more recent updated, and dosimetry is not mentioned in their 2020 guidelines that were just published. And the UK currently has guidelines that are under review, and dosimetry is similarly mentioned as it is in ours, as I summarized in the previous slide, that we think about it in kind of unique situations, but it's not the general approach to deciding on the initial or subsequent doses. Again, in the tumor board, I mentioned, like, how can you kind of have a table to say, well, how much is typically given for depending on where the disease is? And so you can see here in this table, central versus lateral versus distant mets, millicuries per kilo, and then what max doses is, and how do you decide to adjust per patient? You use the other data that you have at your disposal because this is post-surgery. So what's their diagnostics show, how body scans show, their histology show, and there is some at least consideration for what the somatic alteration was, because some patients with BRAF will not respond as well, where patients with fusion oncogenes are more likely to be more responsive to radioactive iodine. How often to give it is, again, the next question. So you give a dose, and then what do you do after that? The one thing that is been proven is for patients that have anatomically detectable pulmonary disease, so not just on their whole body scan, but on anatomic imaging, most commonly CT, non-contrast chest CT, 1 dose is not going to be enough to clear it. And patients and families need to understand that even as you approach into the first treatment. So figure 4 from our guidelines in 2015 is what to do after the initial treatment. And so you give a dose and then you follow them, as we talked about for surveillance. And it's the surveillance data and the response to the initial data that helps determine if that first dose was beneficial, if the patient would benefit from additional dosing. And so we'll follow TG, anti-TG. Is it rising? Is it plateaued? Is it lower? And we'll look at anatomic imaging neck ultrasound, and for chest, we do chest CT is what we do at our institute for following. Based on what the response was to initial therapy, did it grow after initial therapy, or is it stable, or did it decrease? That will help determine if that patient was and even had early evidence of refractory disease or not, and then you can decide on subsequent dosing. Where the 12 months came from, well, it's mostly based on TG data as far as how often to give radioactive iodine, as well as the concern that bigger doses given more frequently may increase the likelihood of side effects, including toxicity to the bone marrow and an increased risk for mutagenic transformation in the leukemias. But the TG data that initially came out of Chernobyl, looking at 20 patients, showed that even after you stop treatment, so these patients received multiple doses of radioactive iodine for pulmonary mets for the first 5 years post-diagnosis, and then for reasons that were actually administrative, not medically purposeful reasons, they stopped getting radioactive iodine and their TG continued to go down. And so that was an early lesson that the treatments actually have benefit, not just within 3 months, 6 months, but 12 months, 18 months. And Memorial Sloan in 2012 published similarly important data, but this was in adults, but showing the same thing, that 6 months, 12 months, 18 months after a treatment of radioactive iodine, the TG and the anti-TG may continue to show a downward trend. And following that out is important, along with anatomic imaging. The other thing to realize is that it's not always linear. And so if you have a bump in TG or anti-TG as a one-timer, people shouldn't go crazy. You just have to say, all right, what is it 3 months from now, to determine if it really is a blip or if it really is a trend. So we do initial whole body scans, SPECT-CT, and radioactive iodine. Then we do neck and ultrasound every 6 months, chest CT if they have pulmonary mets. And then, as I mentioned, we think about a second dose based on that biochemical and the anatomic data. And we try to use defining disease status. I think the most recent article from Stephen Wagesbach's group and MD Anderson is a nice way of thinking about persistent disease. Is it biochemical? Is it structural? And trying to be consistent with how we're describing what our patients are doing after our initial treatment. How much radioactive iodine is too much is a question that may not be answered today, but it's a question that we ask with every patient and every treatment. All of us know about the early toxicity versus intermediate toxicity versus long-term toxicity, and we're worried about all of these things, and we try to institute things to help prevent all of them. As far as the long-term toxicity, pulmonary fibrosis and increased rate of second malignancy are high on the list. And again, it comes down to like how much, at what point does the risk of a second radioactive iodine-induced malignancy go up? And in adults, it's a little bit more defined. 600 millicuries, I think, is how they came up with, defining refractory disease. And hopefully during our discussion, we can clarify if that still holds true. In pediatrics, we've lowered that a little bit and maybe say about 300 millicuries cumulative dose. We start to ask, because that's usually after 2 to 3 treatments, is there of any benefit? I mean, we've achieved 200 or 300 millicuries. If there's no benefit, don't keep giving it. And you could say that to some patients if they've had no response after the first dose. I usually wait and have a second dose before I confirm that there's no response to radioactive iodine. Although it's a little different now that we have systemic therapy, which I'll mention. So how well do we do at clearing pediatric patients with pulmonary disease? I'll kind of cut to the chase, as we don't do very well, as it turns out. So this was, again, in 2010, a systematic review looking at 9 studies, and not just pediatrics, but young adults also up to age 21. And about 47% of these patients, by the definition, as you can see there, achieved a complete response to radioactive iodine, which leaves about 53% of patients who had persistent disease. And you can see how they defined it in their paper. So it's like 50-50, at least in this initial look, of us being able to anatomically clear pulmonary metastasis in a pediatric patient. If you ask the question, if you give more, are you more likely to clear it or not? It's mixed. And so if you look at the studies that are listed here in the table, some of the patients that had complete response versus partial response, they had a higher dose associated with complete response, others did not. And so it's completely mixed. It almost comes down to, if the person's going to respond, they're going to respond. And if they're not, despite how many doses you give, they're still not going to respond. But what is noted is that multiple doses are required. It's usually not one just to clear it. If you look at the patients that had no response, even if you get up into 1,200 millicuries, so above 1,000 millicuries, 2 to 5 treatment doses, if they're not going to respond, they're not going to respond. And I can't say that enough, and I've already said it probably 3 times. So don't keep beating patients up. If they're not responding, more isn't going to do it. So some of our patients, it could be 50%, it could be 60%, 2/3, depends on the data you look at, will have persistent disease. And then it's our mission to determine if it's stable, non-progressive, or if it's progressive. And so this can be a chronic cancer. And I go into patients' discussions if they have pulmonary mets, and I tell them that up front, that this is not a race. We have to take our time. We have to be patient. And I'm not saying that that's going to be easy. But the goal is balancing over-treating for undertreat and versus undertreating. And all of our mission is to make this go away. But sometimes we just can't do that. And we are looking at trying to figure out how to reduce the patients that have even stable non-progressive disease versus patients, in addition to the patients that have progressive disease. A study by Christoph Reiners, which I brought up just partially earlier, was a little bit more fortunate. I'm not sure how they were so fortunate, but if whatever it was, we should figure it out, because at 85% with complete response or near complete response for their patients, 100 patients that had pulmonary mets compared to patients similar number without. But it took 2 to 12 doses per patient, 100 to 1700 millicuries. Of median dose was 450, and about 7% developed lung fibrosis. So there is a cost to increasing this, and that has to be balanced between benefit. More recently, now there's 4 different papers that came out in the last 2 years looking at pediatric patients with pulmonary metastasis. And this goes back to the thing that I cut to the chase to earlier, and that's we're not great at clearing this. So Al-Zahrani had 20 patients, 1 to 8 doses, up to 680 millicuries. None had a complete response. Jonathan Wasserman's group in sick kids in Toronto had 19 patients, up to 600 millicuries, excellent response in 3, structurally persistent disease 13, 68%. The group out of Japan, the Shijino group, 29 patients, up to 600 millicuries, complete response 20%, 3 patients, 10% died from disease. And then the study from MD Anderson, Stephen Wagesbach studied 144 over decades. This is over, I think, 4 decades of treatment. Median dose 238, 93% still had structural disease, and 11 patients died, and several of them decades after their initial diagnosis. So the summary is what I cut to the chase to: complete excellent response is uncommon, and disease-specific mortality for this group of patients is not as good if you don't have pulmonary metastasis, even within the pediatric age group. So how do we define refractory disease? No radioactive iodine uptake on whole body scan with anatomic disease. That's pretty clear and not very common in pediatrics. We occasionally have patchy uptake on whole body scan, and so we may have mixed, avid, non-avid disease. Or it's avid, but it just grows anyway. And I'll show you a patient that kind of led me into my initial delving into systemic therapies, a patient who clearly had avid disease, but still progressed despite that. And then do we reach a cumulative dose or not? And we won't go into it for time, but it is a discussion. And there's some groups that say if it's working, there is no maximum dose. You just keep giving it, try to spread it out as much as possible. But others that think if you've reached a ceiling, all you're doing is increasing the risk of second malignancies. And now in 2022, there are other treatment options we could consider. So in 2015, there was systemic therapy available. It wasn't oncogene-specific inhibitory therapy. It's mostly multi-tyrosine kinase inhibitors. And so we mentioned them, sorafenib, lenvatinib, but we really didn't make any recommendations because we had very little data. At the bottom of this slide, you'll see the kind of case reports that have been published, treating pediatric patients, but there's really been no clinical prospective study within this, but we have one that we're just starting this year. So this was the first patient that I mentioned. That this patient actually went on lenvatinib, but she had clear diffuse micronodular disease with radioactive iodine uptake, both on her initial radioactive iodine treatment as well as on her second radioactive iodine treatment, and despite that, had progressive anatomic disease. So what do we do now in 2022 when radioactive iodine doesn't work? Well, the oncogenes, as we mentioned in the tumor board, are similar in pediatrics and adults. But on the positive side for pediatrics, most patients with pulmonary mets, or at least a higher number of patients, are going to have fusion oncogenes, which are highly targetable with the drugs that we have available today. And so there really is a genotype-phenotype relationship. There's clear data to support this. And some oncogenes are associated with a lower risk of invasive disease, and there's some oncogenes associated with a higher risk of invasive disease. But just because the oncogene's there, you still have to look at the patient and say, well, what do they have for their burden of disease to help treat? We don't just treat the diagnosis as far as histology. We just don't treat the diagnosis based on oncogenic variant and the somatic analysis. We take all that information and look at our patient and decide what would be to their benefit, from minimal treatment to the maximum treatment. The one thing that's shown in pediatrics, and we just published on this, is in contrast to the TCGA data, which kind of, with a multi-omic analysis, ours was not anywhere near as complete. We didn't have $9 million to do multi-omic analysis, but when this was completed, there was RAS-like, was less invasive, and BRAF-like, which in adults, the fusions were included into that group to help predict behavior of disease. The limitations of TCGA are twofold. There was very few patients with M1 disease, and there was really almost no pediatric patients. I think there may be in 2 out of the 500 or so patients that were analyzed. So we just published in JCO, looking at a more comprehensive oncogenic analysis in about 130 pediatric patients. And what it looks like is, in pediatrics, it separates into least invasive, mid-invasive, a high risk for N1A and N1B disease, and then fusions, which have an increased risk of distant metastasis. And you can see that with the bar graphs here and down here looking at M1 disease, that it's more likely to have fusion oncogenes. Of the 64 patients out of 144 that the MD Anderson group had with pulmonary Mets, again, you can see the distribution. Many more patients with pulmonary Mets had fusion oncogenes compared to BRAF. So BRAF is possible. This is more likely to be fusions in the pediatric setting. So this patient went on lenvatinib because that's all we had at the time. And this is her scan in 2019. She started in 2017. And she's had regression of disease. It's been stable even in 2022. She still has stable disease. She has a RET PTC fusion form of diffuse sclerosing variant PTC. So we have now 2 drugs that we could use if she progresses, but she's having no side effects and not progressing. So we've kept her on lenvatinib. But now in 2022, we have all these new drugs. Some of them, like larotrectinib, are approved all the way down to birth because they're not tumor agnostic. They're used across the variety of cancer treatment. And some of them, like sarcomas, neonatal sarcomas, are responsive, have unchecked fusions and responsive to larotrectinib. So approved all the way down to birth. And other ones are approved, selpercatinib to age 12, and others then in the teens. And so we have an increasing number of patients. We have about 6 or 7 now that are on systemic therapy. This is just one of our patients on larotrectinib, and you can see within 6 months the very nice response that they've had, and they had patchy uptake on their post-treatment scan, as you can see here in the upper right. And so again, I'm an endocrinologist, not an oncologist. I know when people aren't responding, but I'm not prescribing chemotherapy. And so I work with Ted Leitch, and we have a center that he helps us evaluate. We've now actually organized and are launching this year a multi-center study using systemic therapy, not only for patients with refractory progressive disease, but actually starting to look at using this prior to the first dose of radioactive iodine to see if we can decrease the number of patients that end up with persistent stable disease. And we were just awarded a DoD Translation Award to help fund the clinical as well as translational research. Why these therapies might improve the efficacy of radioactive iodine is kind of based on the resensitization data that's been shown in adults, initially for MEK and BRAF inhibitors, and more recently with oncogene-specific inhibitors like NTRK inhibitors, and there's even some data now in pediatrics. And we know that it increases the avidity. We still have to figure out if it increases the effectiveness. So those are things that we're looking at, not just in clinic, but also in the lab as well. So to wrap things up, I think we're in a very exciting time. It is more complicated, but it's actually more satisfying at the same time. It takes more time to talk about these things with patients, but it's nice to be able to stratify disease and to really look at patients and say, a lobectomy is all you need, and we're going to be clear, or patients with pulmonary Mets where we had nothing to offer as far as 50% of them are going to have chronic disease and the subset's going to progress, and now we actually have some therapies that we may be able to reduce. So we don't know for sure, but at least we have that potential opportunity. As a community, we still need to decide how to incorporate these systemic therapies. There's fewer patients that will benefit from these than more patients, but those patients really may benefit from them. And I think as a community, not just an individual institute and not just the United States, but our global community needs to decide what's refractory disease. When do you start these meds? When do you stop these meds? How do you follow these patients? How do you define refractory disease? All those questions need to be addressed as a community, not just as individual people or individual institutes. And so it's neat that these medicines can increase the expression of the sodium iodine symporter, but we also need to figure out, is it also leading to increased cidal treatment? And if it's not, why isn't it? And are they developing escape mechanisms so that even though it's more avid, it's not more cidal? There's a lot of work still to do, and it's very exciting. And I have a great team at CHOP, and I just wanted to say thank you to them. It's grown over the years. We have both a clinical and a translational research team. Amy Franco leads our lab, and we have a robust clinical team and a robust multidisciplinary team. So thank you to all of them, as well as our patients, for teaching me all these things over the years. And in our lab, Amy has 3 mouse models. We're developing pediatric thyroid lab, cancer lines. We have a lab repository. And potentially one of the most exciting things that we just launched in the last year is an international child and adolescent thyroid consortium to make it easier for us to do multi-center studies and collect data, not just for one institute, but multiple institutes. So for those interested, please contact me. We're very interested in collaborating. So with that, I will end, and thank you, and look forward to questions that you have.
Thank you very much. And can we proceed with Prof. Turtle's talk, and then we will come back to questions. I'm sure the audience have quite a lot of questions to ask as expected. So can I invite Prof. Turtle? You're muted, I think, Mike.
Yep, I think mine's going to be on a video for the talk, and then I'll answer questions. Thank you very much. In this next session, we're going to talk about selective use of radioactive iodine therapy as adjuvant treatment. When I look at all the emails I get from around the world from terrific clinicians, it very often is about this issue. An intermediate risk patient, and should I use radioactive iodine or should I not use radioactive iodine? As we're all struggling to understand how we move from this one-size-fits-all approach that we used in the 1970s and 80s and 90s to now a much more selective use pattern. So let's start with a real case. I'll show you this case. We'll talk about all the information we need to consider. And at the end, then we'll work through the case like you were with me in clinic, and we'll see what we really did. So a 35-year-old gentleman, an asymptomatic 2.5 centimeter nodule. He was evaluated by pre-op ultrasound and a CT scan of the neck with contrast that identified just that nodule. No abnormal lymph nodes were found, and the biopsy showed papillary thyroid cancer. He underwent a total thyroidectomy and central neck dissection by a very high volume surgeon in a specialized center. No gross extrathyroid extension, nothing special, not a bunch of lymph nodes, just a very straight operative report that was easy to read. And on the pathology report, it was a 2.3 centimeter tall cell variant papillary thyroid cancer. No extrathyroid extension, no vascular invasion. 5 very small lymph nodes came out of the central neck. One of them had a small focus, a 5 millimeter focus of papillary cancer in an 8 millimeter lymph node. So 35-year-old gentleman, 2.3 centimeter tall cell variant, an 8 millimeter lymph node with thyroid cancer. Before he came to see me, about 6 weeks after surgery with a TSH of 0.5, the thyroid globulin was only 0.5 and the antibodies were negative. And the question that the family had for me is they had seen one group of physicians that said you have to have radioactive iodine. They saw another that said you definitely don't need it. And then they saw the third that said, well, it's kind of up to you. Why don't you make a decision? And so you can imagine they were struggling to know what to do. So when we look in this sort of area, that when do we use radioactive iodine, we're really talking about what are the indications for treatment, what are the optimal administered activity, and we're not going to have time to get to that today except just briefly. But I think the real key is understanding when we say adjuvant therapy, which patients are we talking about? How do we identify those patients? And what are the real critical factors that help us understand that?
Now, with the nuclear medicine doctors from the United States and Europe and the thyroid doctors from Europe, we all got together several years ago and said, look, we need to work on our language. When we say radioactive iodine, what do we mean? And in fact, there were sort of three different things that we meant: ablation, adjuvant treatment, or treatment of known disease. And when we say ablation, what we're really talking about is just destroying that residual normal thyroid tissue. Yeah, I know ablation can kill some little microscopic stuff, but the goal is to destroy that residual tissue so that we can facilitate follow-up. On the other hand, treatment of known disease means we know there's metastatic disease. It's on the CT, it's on the physical exam, it's on the diagnostic scan. That's a whole different ballpark. Nobody argues about using radioactive iodine in them. This middle group is the one that we've talked about, adjuvant treatment. Now, I showed the scans positive, but their diagnostic scans were negative. And the only way we saw something on the disease is if we gave radioactive iodine, and we saw it on the post-therapy scan. So in this adjuvant treatment space, we're trying to destroy subclinical disease that might or might not be present. And we don't have an abnormal thyroid globulin, we don't have an abnormal scan. We just have all the information about the patient that says you're at risk of something, recurrence or death or distant metastasis. Now, this adjuvant therapy is a term that's used, as you know, all through oncology. And we've used it in that sense because we're trying to move thyroid cancer from endocrinology to the language of oncologists so that we think about this like cancer doctors do, because this is cancer. And so if you ask a cancer doctor about adjuvant therapy for breast cancer or colon cancer or whatever, they'll say those are additional treatments given after surgery. All known disease has been removed, and they're going to do something to try to kill microscopic disease that might or might not be present. But if it was present, it would be a bad thing. And so the goal is to decrease recurrence rates and really improve overall survival. Now, this third bullet is really the key, because adjuvant therapy is given for a risk. We're not treating demonstrable disease. We're not treating a positive radioactive iodine scan. We're not treating a post-op thyroid globulin of 100. We're treating you because you're at risk of recurrence. Now, our risk stratification is not 100% perfect, so we're going to have to accept that some people that we give adjuvant treatment to were probably already cured. But because the risk is there and because the outcomes could be bad, we're willing to give an additional treatment, in our hands, radioactive iodine, to decrease that risk of recurrence, and being willing to overtreat a few people. And so the selective use approach is just that. How do we select the people that are most likely to benefit versus just treating everybody? Now, if we look at our goals, so here we are, if we're doing remnant ablation, the goals are really initial staging and to facilitate follow-up. And in many patients, that's important. Say if the patient has intermediate risk and they've got anti-thyroid globulin antibodies, having some additional staging with radioactive iodine would likely be helpful. If they were a follicular thyroid cancer with extensive vascular invasion, now we're going to worry about their distant metastasis rate and risk. They may not have a high TG right now, but could we do something to lower that risk? In the adjuvant treatment setting there, that's where we're going to try to lower that risk. Yes, with adjuvant radioactive iodine, you get the staging, it facilitates follow-up because it's doing ablation, but hopefully we're decreasing recurrence and we're trying to sort of cure the patient. I tell the patient it's cleaning up the dust in the corners, the icing on the cake, that little bit that we can do. And then, of course, the third group is treatment of known disease, which is, we're not talking about that today. So from a practical standpoint, how do I think about this? Well, after surgery, I ask the simple question, is there structural or functional disease present? If there is gross residual disease or lung metastasis or lymph node metastasis, that's not adjuvant therapy, that's not ablation, that's treatment of known disease. That's a whole different ballpark. But if there's no structural or functional disease, then I use the serum thyroid globulin to kind of help me. Does the serum thyroid globulin indicate persistent disease? We all measure a thyroid globulin usually about 6 weeks after surgery. And this is what we're doing with it, trying to define, Was everything resected? Is there a bunch of normal tissue left? How good was the surgery? Is there distant metastasis? And while the exact cut points are not known, I usually expect the non-stimulated thyroid globulin 6 weeks after surgery to be less than about 5. Now, if I'm honest with you, in our high-volume surgeons that do really phenomenal total thyroidectomies, we hardly ever see a thyroid globulin more than 1. So you'll have to sort of figure out for your center, for your surgeons, for your approach, what is the usual thyroid globulin you see after surgery. If that thyroid globulin is less than 5, or in our hands less than 1, then we're really talking about adjuvant therapy. So there's no structural disease. 6 weeks later, the post-op thyroid globulin is very reassuring, no definite evidence of disease. Maybe that post-op thyroid globulin is just small volume residual normal tissue. And then we have to say, okay, what's the risk? What's the likelihood that you're going to recur? Because you don't definitely have disease now, but do you have a high enough risk? And do I have a treatment that would impact that risk to help us make the adjuvant therapy decision? Now, in some aspects, the table we put in the guideline was a little bit misleading last time based on the way we sort of think about this now. And if you just looked at the table, you would just say, what's the risk and do we do radioactive iodine, yes or no? And this table really didn't convey the importance of all these other factors I've been talking about. The post-op decision, were we doing ablation? Was it adjuvant treatment? Was it known disease? So what was the post-op thyroid globulin? It wasn't in this table. Now, to be fair, we did have a footnote in the table that said, in addition to the ATA risk and staging and TNM, lots of other factors needed to be considered, but that really wasn't sort of grabbed onto by most people, I think. In the text, we did go through several different areas where we did talk about, in recommendation 50A, what's the post-operative disease status? That really was, at that time, we hadn't sort of figured out ablation, adjuvant therapy, treatment of known disease, but that's the concept. Are we treating known disease or are we treating a risk? Clearly, by that point, we understand the importance of a post-op serum thyroid globulin, probably without TSH stimulation, although you can definitely get information with a TSH-stimulated thyroid globulin, but 6 weeks or so after surgery, that's an important number. We did recognize that there's no specific absolute cutoff number for thyroid globulin because, as I mentioned, it will be dependent on how aggressive your surgeon is, how much they really believe in a complete total thyroidectomy versus subtotal, so that'll vary at different places around the world. The other piece I think we've probably underappreciated, despite our nuclear medicine physicians trying to convince us of this, is the role of the post-op radioactive iodine diagnostic scan. I will admit I largely quit doing these about 10 years ago, and I was probably wrong. I'm now starting to think with our nuclear medicine colleagues which patients could benefit from a diagnostic whole body scan, because if they were intermediate or high risk and I did a diagnostic scan and it showed RAI uptake, that would make the decision easy. A, it's no longer adjuvant therapy, it's treatment of known disease. And B, we've identified people that radioactive iodine would likely help. So there's a lot of us sort of working through now. I don't think you need a diagnostic scan on every patient after total thyroidectomy. I think you need it on all the high-risk patients. And we're trying to figure out which are those patients in that intermediate risk group that have a significant risk of having RAI avid disease you can see on a diagnostic scan, because that's when it would make the difference. Which one of those patients, not only are they high risk, but are they at significant risk of having disease that you could actually find with a separate diagnostic scan? Now, when we begin to think about this, these factors that we have to think about, traditionally we've taught about post-op risk assessment. We've been pretty good about that. That was the sort of first move away from everybody gets it to selective use. And so we identified people that were at very low risk of recurrence. And if you're at very low risk of recurrence, then doing adjuvant therapy really doesn't help very much. We also began to think about, well, does radioactive iodine make any difference? you can identify patients that are at very high risk for having their cancer come back, and yet well-meaning adjuvant therapy doesn't do anything. There's examples in all of oncology of tumors that they know are going to be bad and recur and possibly cause mortality, but yet additional adjuvant therapy doesn't impact that. So we have to separate out this idea that automatically having a high risk automatically means you need radioactive iodine, because we have to ask that second question is, does radioactive iodine change those outcomes? And does it changing it in a meaningful way? As I mentioned, many times we needed to improve staging and to facilitate follow-up. And that's particularly if you work in areas that don't have a big medical disease management team like we do. Maybe you don't know the surgeon, you don't know the ultrasonographers, you don't know the quality of the thyroid globulin. All of those things would make us more likely to lean toward adjuvant therapy, really to help staging and to possibly decrease recurrence rates. These are those other factors that we have to think about that, the guidelines mention, but this is the reality. What's the preference of our local disease management team? If you're a surgeon and you know your endocrinologist always wants radioactive iodine, you're going to do a total thyroidectomy unless you talk to them otherwise, because they'll send it to a different surgeon. What's the experience of the thyroid surgeon? In a situation like mine, working at a very high volume team where 60 of us do thyroid cancer every day of our lives, and I know the ultrasonographer, and I know the radiologist, and I know the people that run the lab, and it's going to be easy for me not to use radioactive iodine because I feel much more confident in the data that we have. What's the side effect profile? Now, I've seen over the years people that are starting to realize they're using too much radioactive iodine begin to really major on the side effect profile. And while I don't think radioactive iodine is apple juice, by and large, it's a safe treatment. Minimal effects on secondary malignancies a long time down the road, unlikely to cause a complete dry mouth, some salivary gland issues, but most of the time when I'm deciding not to use radioactive iodine, it's usually not about the side effect profile. Now, for some of the patients, it is about the side effect profile because what they're willing to accept or not accept would be different. I've got professional voice users that are singers or judges or people like me that lecture for a living. Having a dry mouth would have a tremendous impact on what I do for a living. And so I'd have to really balance, even though you tell me it's a very low risk, for me, that would have a big deal. And patients, some people want everything done. If there's the least chance this could help me, give it to me. Other people are like, if there's the least chance it could cause a side effect, I don't want it. So I don't think this means we leave the decision up to the patient to make a final decision. But as I'm discussing with them and talking about what's their risk and how much radioactive iodine would want to work, I'm sort of watching them and listening to them to get a better understanding of what are they valuing. Are they valuing as much treatment as you possibly can? Let's not worry about the side effects. Or are they worrying about, well, is this really necessary? What are the side effects? If I delay the therapy, could it be effective? And so working through a much more selective approach in those patients. Now, as we look to the future, I find myself when I'm sitting in clinic, there are parts of this story that I'm not sure about. What is the real risk? We'll come back to my patient in a minute, a 2 or 3 centimeter tall cell, but most tall cells have a ton of lymph nodes, and by the time they get to 3 centimeters, they have extrathyroidal extension. So using the risk of recurrence for the average tall cell may not be appropriate for him. Or likewise, a follicular thyroid cancer with only one focus of vascular invasion. That's an ATA low-risk tumor, no question about it. Very unlikely to have a distant metastasis or die, but if radioactive iodine was ever going to work, it'll be in a follicular thyroid cancer that's RAS-driven. So a low risk, a side effect profile, maybe you just give 30 millicuries, so a side effect profile that's very low, but if they had persistent follicular thyroid cancer, little doubt you could improve their outcome. So trying to balance that risk and benefit back and forth. I think we still need better trials on how does it really impact the outcomes of interest. Which patients really do we improve survival? Which patients do we decrease recurrence rate? I don't have any doubt in some of the patients that I give radioactive iodine to, I definitely decrease their recurrence. I definitely make them live longer. The trouble with these studies is recurrences that are affected by radioactive iodine. That tends to be the slow-growing disease, and studies that look at 5-year time horizons are too short to be able to tell if there's a significant difference. We need longer studies and ideally randomized clinical trials. The other important part of it is I think we really need better studies understanding the patient's values. How does that vary in New York? How does that vary in the Middle East? How does that vary in South America? How does that vary? It may not vary as much as what we think. How does it vary from the surgeons asking the questions versus the endocrinologist asking the questions? And how do we ask those questions? How do we find out what the patient's values? It's kind of nebulous, and I'm kind of doing it by talking to them and listening to them, and I'm largely trying to guess what they think is valuable. So better studies to help us, because if there was some checklist that before I walked into the room, I knew this patient was a maximalist. They wanted total thyroidectomy. They wanted neck dissection. They valued therapy. They weren't worried about side effects. They valued staging. That would make this decision and discussion much easier, right? I would say, hi, I understand that you're sort of down this pathway of doing everything we can to make sure things are good. So to me, it would make the consult feel a little bit differently. The other components of everybody always says it's easier in a fancy academic medical center, and that's probably true, but it depends on which components are the most important. Is it the ultrasound? If you don't trust your ultrasonographers, could you do a CT scan of the neck with contrast? Most radiologists can read those very well. If you can't trust the thyroid globulin, but you're doing it in the same assay time over time, would that help you? So not just making the assumption that expensive and a centralized system is better, but which components are better. And then I think lastly, this is one we really haven't incorporated very well. And Dr. Fagan, who's in our group over here, has really helped me understand this over the last several years. That in that sort of outcomes of interest, if we give radioactive iodine, what impact is it going to have? That we need to understand that based on the histology and probably the molecular profile. To take it to an absurd, we know we don't give radioactive iodine for anaplastic thyroid cancer, right? Very high risk of recurrence, but it's not going to work. We don't give radioactive iodine for medullary cancer with extensive lymph node metastasis. Why? Because that histology, it doesn't work. And then there's a lot of questions about whether it's going to work in tall cell variant papillary thyroid cancer. Those are usually BRAF V600E mutated tumors, and the vast majority of them downregulate the TSH receptor, thyroid globulin, the thyroid peroxidases, everything you need to concentrate and make radioactive iodine stay in that tumor is downregulated in most of those tumors. Now, not all of them, about 10% will signal RAS-like, and some of them will concentrate radioactive iodine, but how do we sort of tease that out? And how should that sort of impact not only our risk assessment? Yes, we're pretty good with histology and risk assessment, but how does that impact our decision about how much radioactive iodine is likely to help? In follicular thyroid cancers, follicular variants that have RAS-driven tumors, I think radioactive iodine is very, very likely to help in them. The fusion genes, the RET PTC, they're kind of more in the middle, often helps, but not always. And then the BRAF V600s are ones that tend to be not so responsive. So as we're going through this list, I think we have to think like oncologists and say, yes, I not only understand your risk, I not only understand your concern, I understand the side effects of this, but you need to understand with me what's the likelihood that a well-meaning adjuvant therapy will make any difference whatsoever. I'll finish with this. So how did I think through this gentleman? This gentleman was taken care of at a famous center. So I happened to know the people that were taking care of him. He had phenomenally good ultrasonography and neck CT. They sent those images, no question about it. So no worries from my standpoint of upfront staging. He had his surgery done by a high-volume surgeon. I had the operative note. If I wanted to talk to the surgeon, I could have. I didn't need to in this situation. But there was no question that the intraoperative decision-making was well done. His slides were read by my pathologist, Ronnie Gossain, who reads all these for me. So there's no question about the histology and tall cell variant, no extrathyroid extension, no vascular invasion. He carefully looks at everything, the entire thyroid. No question, not only the number of lymph nodes, but he gave me the size of the lymph nodes, the size of the metastatic focus, and I didn't have room on the slide, but he also told me there was no extranodal extension. So I've got a good understanding of the path report. And now I've got an early response to therapy with a thyroid globulin of 0.5. So his risk of recurrence, I would say, is actually fairly low. I know he's intermediate because he's a tall cell and because we had a 5 millimeter lymph node, but in this particular tall cell, I think his risk of recurrence is probably about 3, 4, 5%. As I mentioned before, I don't think radioactive iodine is likely to help. He's already got a low risk of recurrence. This is a tumor that traditionally does not concentrate radioactive iodine. So I told him there was about a 10% chance that radioactive iodine could lower his recurrence. So I write down on pieces of paper, disease-specific survival more than 99%. Risk of recurrence, I think I wrote down 5%. If I gave you radioactive iodine, I could lower that risk in about 10% of the patients. Not lowering it by 10%, but 10% of the patients, 1 out of every 10, if they swallowed the radioactive iodine, the risk of recurrence would be lower. I don't think it would affect his overall survival. He was sort of more of a minimalist and felt very reassured with the thyroid globulin value and actually chose not to do radioactive iodine. And so we're following him with repeat ultrasounds in 6 months and a repeat thyroid globulin, and we'll reevaluate at that point. So at the end of the day, I think it's gotten much more difficult in this adjuvant therapy setting to decide who needs radioactive iodine and who doesn't. But I think if you think through these various factors that we've talked about, you'll understand why some people that I did not give radioactive iodine, you would, which is perfectly fine based on the situation and the setting and all of those factors that we talked about. Thank you very much.
Right. That was excellent, Mike. Now we have a few questions from the audience. And I mean, obviously we need to restrict to some in terms of time, but let's start with something a little more broadish, but probably Andy will be the best to answer this. We do see more and more thyroid cancer in peds. Is it related to ultrasound use or increase in radiation? What other than radiation is causing non-hereditary cancer in peds?
It's a great question with an unknown answer. So it's a mix. You know, there's a group of people who sometimes dismiss it and say we're finding small cancers, but I think it's across the spectrum. There's more radiology that's being used, and you find incidental thyroid cancers on unrelated head and neck imaging. But it's actually not how you find it; it's what you find, right? That's more important. And so we are also seeing more patients present with lymph node metastasis, and I think more patients present with pulmonary metastasis. And so it's across the spectrum, and it's the individual patient. Just depends on what they have. Why it's happening is another great question. We can always fall back on maybe we're all exposed to more carcinogens, and of that list, of course, radiation is the most likely as far as causative explanations, but as far as likelihood of exposure, it's pretty low for most of us. So we think about surveillance in our onc survivors where radiation was used as part of their primary treatment. I'm a believer in ultrasound surveillance, but it's restricted not to all pediatric patients, but those exposed particularly less than age 5 at the time of their radiation exposure, potentially 10. And then once you enter into teenage years, I think the risk of radiation-induced thyroid cancer decreases. We've known that for a period of time. If you think about oncogenes, there are now an increasing number of familial predisposition syndromes that are associated with thyroid cancer, from P10, hamartoma tumor syndrome, Dicer-1 syndrome, and FAP. It turns out most of those are increased risk of multinodular goiter and thyroid cancer, but low invasive forms of thyroid cancer, not invasive forms of thyroid cancer. And then we're left with the group that we wave our hands and ask, why are we seeing more of it? And it may be lymph node based, I swear, and then I don't know if Mike sees it in New York too, but in the Philly area, I don't know. It seems it's not just our center that maybe we have a reasonably good reputation and we get referrals, but if you look at the zip codes, it just seems like we have a high incidence of of differentiated thyroid cancer in the Northeast. I won't throw stones at New York. I'm from New York originally, but it's not even just the state, it's like the location. So it's in the Philly area and the New Jersey area. It just seems that there may be some geographic distribution that maybe we'll figure out why it is. And Julian Sosa published on maybe it's flame retardants in textiles. Or there's things that are in the environment that are probably increasing the risk, and we just haven't either figured it out or figured out how to avoid them. Probably both of those things.
Right. There's a question for Marius. Thank you for coming back. They said, do you try steroids first to see if they are steroid responders? And then they says, do you compare between Tosi and Tepezza, which will be your first line?
I think that's a poignant aspect of our practice now as to where do steroids fit in if we have teprotumumab at hand. I think that we have to go beyond the aspect of inflammation. What teprotumumab is able to do is to reverse proptosis. Steroids, on the other hand, are cheap. We know their side effects. They are well established in the literature. So if I'm looking just to reverse inflammation, I don't think we need teprotumumab. I think steroids can achieve that, and they can do it with a much better known side effect profile than this potent, but yet still unknown drug for many of us. On the other hand, if somebody has 3-4 millimeters of proptosis and we're thinking surgery might be coming down the road, I see no need for steroids there. I think that's where we need to use teprotumumab, embark on the upfront cost because it might avoid a difficult surgery for some patients. As far as tocilizumab, that is a challenge because we don't have the approval for it, and it does bring on a cost. So I think the decision is typically between steroids and teprotumumab. Tocilizumab is probably my second or third gun if I'm still looking for an anti-inflammatory agent.
Excellent, thank you. Now, this the probably two questions were addressed to Greg, but there's one surgeon. Let me see if Prof. Choker has any experience on using MKI neoadjuvant therapy before surgery. The question is, does it really affect the wound healing? And second is, what would be the extent of surgery once you have actually reduced it? I'm sure Tata is using this for head and neck squamous cell carcinoma. So do you think we should apply that? You started with big disease, you gave neoadjuvant therapy, you reduce the tumor burden. So would your extent of surgery change?
I don't have an answer to that because we've not yet used it. We're just embarking on a trial for that, which is in the pipeline. But certainly for squamous carcinomas, giving neoadjuvant, we certainly can reduce the extent of surgery. I'm not sure in papillary well-differentiated thyroid cancers, the locally advanced ones. Really, I don't have an answer because I've never tried.
I mean, can I ask the other panelists, Prof. Tuttle, have you any experience of watching in your center?
None that I'm aware of. Don't know anything about it.
Okay. Right. There were several questions on thyroglobulin levels, and then they say raising thyroglobulin but negative imaging. Then some say stable thyroglobulin but the antibody is raising. And then a lot of questions on, are they really reliable in terms of monitoring the disease? So.
Yeah, I mean, I'll go first. Yeah, it's useful. We can always find exceptions, right? I mean, there's always going to be exceptions. So as a general rule, yes, if the thyroglobulin is going up, you probably have structural progression somewhere. You can get assay problems, interference problems, but those are usually really apparent because the thyroglobulin numbers don't make sense. It's 5 one day, it's 15 the next day, it's 3 the next day. There's a problem in there. So if the thyroglobulin numbers are going up, you probably have disease. The difficulty with the thyroglobulin antibodies is in my few patients that their recurrence was heralded by thyroglobulin antibodies, it usually takes me 3 to 5 years to find the disease. That's a long time. patients are patient, but they wear out about year 3 of me going, yeah, I'm going to probably find it. Because it's, my view is it's the immune system. It finds it very small. So, papers that say, well, antibodies went up for 2 years and it didn't mean anything. I go, well, yeah, I know that. You just didn't follow long enough. You have to see them over time. So I think it is helpful, and certainly that. The other caveat that always surprises people, but it's been published now for many years, is that you can have small lymph node metastasis without the thyroglobulin going up. Now, in the old days, when we used to find lymph node metastasis with our hands, I assume you guys still do physical exams, right? We don't do those in the United States anymore. We don't train people to do that. But back when we could feel stuff with our hands, the thyroid. Oh, sorry, Marius. I know they do it at the Mayo Clinic, but other than that, up there, when you had big palpable lymph nodes, the TG was always up. Now, on these millimeter-sized lymph nodes, sub-centimeters, there's a reason that the follow-up is thyroglobulin and ultrasound, right? The additive value of the ultrasound. So particularly in young people, the papillary cancers with N1B disease, we'll see small lymph nodes change that we all know are thyroid cancer, but yet the thyroglobulin doesn't go up. So it's not perfect. You just have to be aware of those caveats. Lastly, I'll say thyroglobulin does a really good job generally finding stuff that's bad. Big lymph nodes that you're missing somewhere, distant metastasis. And even in the poorly differentiated, while we don't trust the poorly differentiated to make a lot of thyroglobulin, they almost always make some. Like you hardly ever see a Hürthle cell cancer come back without at least some thyroglobulin. So, you may be a little bit more worried about a poorly differentiated thyroid cancer with a thyroglobulin of 5 versus a well-differentiated with a thyroglobulin of 5. But still, it's a useful marker to follow over time.
Is there anything different in pediatrics?
I think it's generally the same approach. When I was in training, we talked about TG positive, scan negative, but of course it matters. What do you mean by TG positive? If it's 5, you may have a scan negative patient. If it's 50, you need to be asking, what are you missing? And so it just depends on what that positivity is level-wise and what the trend is doing. I think in general, radioactive iodine negative, scan negative disease in adults, FDG PET or other radioisotope imaging has proven to be helpful. It's been relatively unstudied in pediatrics, but kind of anecdotal from our institute, which is certainly a handful of the times I've tried to use it. It's been uninformative, and talking to other people as well, potentially a little less informative in pediatrics. And that may be because we, again, are fortunate that we have more patients with differentiated disease than undifferentiated disease. And as far as the antibodies, highly helpful. That patient I showed you, that was the first patient I put on systemic therapy, lenvatinib, had diffuse sclerosing variant PTC, and her marker was an increasing TG antibody level. So for the patients that are antibody positive, that are significant, again, not just above the upper limit of normal, but in the hundreds, and some of them are in the thousands, when they're going up, their disease is progressing, and you have to figure out why it's progressing and where it is. And for many of them, it's pulmonary mets, and chest CT is adequate to figure out that answer.
So the selective raising or high antibodies, do you really need to treat them with the stable thyroglobulin?
So we don't. We don't. I mean, there was a time probably 10 or 15 years ago when we were throwing radioactive iodine at everything that people did. I don't treat rising antibodies alone. I also don't generally treat rising thyroglobulin alone, just to be consistent. Ian Hay told us years ago, nobody ever died of a thyroglobulin number, right? It's a tumor marker. Thyroglobulin's not a cancer. Thyroglobulin's not going to kill you. Now, if somebody has a TG that slowly goes up over 5 years and I can't find it, sure, I'll throw a dose of radioactive iodine. It hardly ever does anything. But so no, I separate sort of, we talk about what's detectable versus what's actionable. So slowly rising thyroglobulins or thyroglobulin antibodies or small lymph node metastasis, what's detectable and I'm going to keep an eye on versus what's actionable. What do I need to do something about? And I think these days, with our tools being so good at finding all this minimal residual disease, we really got to separate finding something versus needing to do something other than surveillance.
So the same in pediatrics. We try not to treat a number. We treat anatomically detectable disease. And I warn our patients, it's the good and the bad. It's the curse these tests are so sensitive, even ultrasound. I mean, you can find things that are millimeters in size, and it's not an obligation to chase every little thing and every little number. You have to have anatomically significant progressive disease or persistent disease.
Yeah.
To
Yeah, I mean, we could. Yeah, but we couldn't agree more. Ali Al-Azrani, who you guys all know very well, and I spent a long time talking about this and wrote a review in JCNM where we talked about what persistent versus what we need to do something about. Then we identified sort of 5 factors in structural disease. What's the size? What's the location? What's the rate of change? Is it causing symptoms or likely to cause symptoms? And then the last was patient preference. So just because you can find something, we have to go through all 5 of those to decide, is it time to do a surgery? Is it time to ablate? Is it time to do a TKI? Those same 5 factors, just like pilots have a checklist before they take off, if you're dealing with structural disease, you can use that to help you make decisions about, should I do a surgery? Should I give radioactive iodine? Should I give a TKI? Should I do external beam radiation? Those 5 factors, the few times I've gotten in troubles, I've left one of them out. I didn't do something because I didn't think about all 5. So size, location, rate of change, symptoms, and patient preference. And if you can check through those boxes, that generally tells you when you can keep watching and when you need to do something.
There's another question regarding the risk stratification. Okay, within the 88 different risk groups, do you think age makes a difference? A 60-year-old intermediate risk, is it different from a 30-year-old intermediate risk patient?
Yeah, so years ago, either for good or for bad, I decided when we were doing low, intermediate, and high, I was not putting size in and I was not putting age in. Because if you look at the ATA risk, there's not an age and there's not a size, right? And we did that on purpose because we wanted people to be thinking about them individually. Most of the time when you're thinking about differences in age, you already capture that in the ATA. So the 20-year-olds that have a high risk of recurrence, why? That's because they had 25 positive lymph nodes and they had lateral neck lymph nodes that were 2 or 3 centimeters. So age is often just a surrogate of the type of disease that you see. So if I have exactly the same histology features, that sort of stuff, not a great big difference between 20 and 60-year-olds. It's just that 60-year-old thyroid cancer, we hardly ever see, 2-centimeter papillaries confined to the thyroid. Those tend to be bigger. So I'd say yes, age has a minor factor. The older you are, it's like a U-shaped curve, younger and really old, higher recurrence rates, and the older you are, more mortality. But we elected to leave them out of the ATA for risk because we thought all those other factors would catch that for us.
Probably I can ask this of Choka. If thyroid cancer meds that do not take radioactive iodine, difficulty is know whether these are active meds or just post radiation fibrotic nodules. So if you see them in the neck, what else can we do? It's very difficult to monitor if they're not taking up, but ultrasound shows them or a CT shows them. Would you be thinking about surgery, or what would be your...
Sorry, I didn't get the question.
For thyroid cancer meds that do not take up radioactive iodine, the difficulty is to know is whether these are active meds or just post-radiation fibrotic nodules. You PET them
in the neck. In the neck, you have your ultrasound characteristics. But in the recurrent setting, well, ultrasound doesn't do that well as it does in per prime setting. We know that. You have your CT scan, and of course you can, in the neck, it's easy to target them. Plus you have your other markers such as the thyroglobulin. So you should look, also you should look at what was the initial disease status. So if the disease was high volume disease status and their thyroglobulin is going up, then probably this is probably a disease rather than just postoperative fibrosis. So instead of looking at this in isolation, you have to look at the complete picture right from the initial disease to the thyroglobulin and your ultrasound, CT scan, stroke FNAC findings.
Okay, right. If it's in a non-medullary setting, what should be your threshold to think about PET CTs for these now?
Non-medullary setting, again, I would go by the initial disease status and the rise in thyroglobulin. if you have a sky-high rise in the thyroglobulin, I'm thinking that this is not the only site of disease. This person probably has failed elsewhere as well, and that is why you're seeing not only local, regional, but distant disease as well. But if there's a slight increase in thyroglobulin, only site of disease, I would not want to look at distant sites in this patient.
Right, a 30-year-old female with papillary thyroid carcinoma after total thyroidectomy takes 30 millicurie radioactive iodine. After 1 year follow-up, thyroglobulin is 0.2 ng per mil on thyroxine. What's the target TSH for this lady? We have a target TSH for a...
Sure. Yeah, we got target. We don't have any data, but we got targets, so I'm going to say it's perfectly fine. So this has changed a lot. It's a great question because when I was a fellow the last century, we kept everybody's TSH 0, right? That's just where we kept everything. A 30-year-old with a typical papillary got 30 millicuries, which should imply it's a fairly low risk thing. We would keep her TSH around 1. In 2015, we wrote the guidelines. For some reason, we picked 0.5 to 2.5. Don't ask me why. We were all sitting around the table, and Steve Sherman and I, we're like, yeah, it's a good number. I swear to God, I wished I would have picked 3 because so many people are 2.5 and 2.6, and everybody keeps emailing me. So I think the key in this patient is not suppression, but avoiding excess stimulation, right? You just don't want TSHs of 4, 5, 6, or 7 to make something grow back. So I would tell her we want the TSH around 1 in that ballpark and not suppressor.
There's another question is, what's the role of MRI? Is that more sort of safer for children? Basically they're trying to compare with CT radiation. Is there an increased risk? Is there an increased role of using MRI, or do people use more MRIs for children?
I think it's institute and radiology specific. CT is much faster, and there's pediatric protocols that it's a low radiation risk. So in our institute, it doesn't require sedation. If you're trying to do MR, at least chest for sure, maybe neck, depending on the age of the patient, you may then be heading into, requirements for conscious sedation. So if you're using it frequently, and we have patients that come to us actually ask for MR versus CT, because there are some data showing that even low dose exposure repeatedly over years, whether it's panorams for x-rays of your teeth or chest CTs, might increase the risk. So we think about it. I don't know that there's an advantage one or the other. I think for lungs, non-contrast chest, 5 millimeter, 3 millimeter cuts are really high resolution enough. And for the neck, some people will use MR rather than CT. There's some questions about gadolinium and if there's a risk to that contrast agent also. So it's the risk balance, the age of the patient, conscious sedation, not conscious sedation, and what the radiologist needs as far as their comfort level for detecting persistent or recurrent disease.
And in the adults, it's largely what my surgeon is comfortable reading. Shaha and I are both old. We can't read MRIs, so we do a lot of CTs. Some of our surgeons are younger, Rich Wong and the guys, and they're very comfortable doing MRIs. So I tell the endocrinologist, before you order a test, because this is going to be all about, do we operate or do we not operate? Talk to the surgeon that's doing the patient with you, and if you guys have a strong preference one versus the other, most of the time I know the surgeons in New York City, and I know the ones that operate based on MRIs and other ones based on CT scans, and I tend to pick ones that they're comfortable and can help me read and know what's going on.
Right, there's a beautiful question for Marius. Right, exciting field in the management of thyroid eye disease. Great talk. Is there a way to use the name of drugs easier to remember?
Yes, make them your password, and then you'll remember them every day. It is, what can I say? We've seen this in the field of the new drugs for diabetes. Almost all of those SGLT2 inhibitors and GLP-1 receptor analogs, they all have drug names that we cannot pronounce, and then the pharmaceutical name is an easy one or has a connection with the practice. So what can I say? This is beyond medicine. It's about probably shareholder value.
Some of us are still struggling with cephalosporins. Right.
Yeah, so
There's another very broad, but I think strategies to lower risk and increase efficacy of radioactive iodine in children, stroke adults. Any short 2-minute talk?
And what's the question? How to lower the exposure of radioactive iodine?
Decrease the lower risk and increase efficacy of radioactive iodine. Can we do anything to make it more effective? Or is there anything with sort of compounds and doesn't let it absorb to the same extent?
Not that I know. I think selecting the patient that benefits is the first most important step, and realizing that not all patients benefit. That's the easiest first stratification.
Yeah.
As far as using low dose, like 30 and 50 millicuries, there's no data in pediatrics. I think that is something that would be worthwhile studying. Like, what does it take to get rid of minimal, if you have 3 or 4 areas of foci in the central neck and you're not sure is it thyroid remnant, is it 1 or 2 small leftover lymph nodes, and you're really thinking about just giving a treatment dose just to put this behind us because there's a high likelihood of benefit from it. It's what I tell our patients, it's surprisingly non-scientific how we pick the dose, right? It's like a negotiation. The nuclear medicine doctor called, at least in my clinic, hopefully I won't get in trouble, but they call, we're like, they started 100, I started 50. He's go, it's like the trade where it's like at a car sales thing, and we're trying to pick a dose. And it would be much nicer to have some prospective study that said 30 is enough to get rid of minimal central neck disease, and 50 or whatever for the next level, and 100. But we need those studies, and we need to figure it out. It's been done in adults. There's no reason not to do it in pediatrics.
Yeah.
And maybe having like our consortium would be helpful to figure that out. So we can get a couple different centers working together to figure it out, because one center is not going to do it. And then the length of time for follow-up, then we'll have to obviously work with our adult colleagues, because at some point they do leave our practice, and we still need to figure out what happens to them 20 years and 30 years down the road.
Yeah, I agree. So from a practical standpoint, we tell folks to hydrate a lot, because obviously radioactive iodine goes out the kidney, right? There's half of us do sour candies, the other half don't, so we can't figure that out for salivary gland side effects. We do make sure they have a bowel movement within a day or two, and people often forget that radioactive iodine can stay in the stool for days and days and days. We have them do that. And then if I look forward, I hope there's the day in the not too distant future that we base how we do the radioactive iodine on their histology and their molecular findings, right? Where this whole redifferentiation, making tumors grab back onto radioactive iodine, is really in the RAI refractory setting. Why not move that all the way up front? Because we wouldn't do radioactive iodine now without a low iodine diet and TSH stimulation. That's being done to maximize uptake. Well, maybe in a BRAF, you need a week's worth of MEC, or you need a BRAF inhibitor, or a RAS, you need something else. So I really do see the day when some sort of redifferentiation becomes part of our radioactive iodine up front. Because if you could ablate with 5 millicuries instead of 30, that's probably a good thing. If you could do adjuvant therapy with 25 instead of 100, that would be a good thing, right? So we're not there yet. I don't mean to even imply we're doing that. But as we sort of look at how we make these tumors grab back onto radioactive iodine, strategies to do that allow us to minimize the administered activity would be a really good thing. So lots of us are thinking that way. We're designing trials that way. We're a long ways from that. But I think if we look where we are 10 years ago, I'd be surprised if there weren't some people that on that very first dose of radioactive iodine, we knew standard therapy wasn't going to work, and we'll add some redifferentiation agent in. Not for weeks and weeks, but for a week or so before we do it. So in a forward-looking answer.
To Mike's point, the hydration and making sure you have frequent bowel movements is absolutely key. We have a roadmap, we call it, and we prescribe Miralax if we need to, or at least instruct patients to get it over the counter, and encourage hydration so that their urine is clear, not dark yellow. And we even go through the discussion of what it should look like. And that's one reason, as far as resensitization or sensitization for our pulmonary patients, like that's why we're starting to think about if we have a targetable alteration like a fusion as a somatic alteration, maybe we can increase the effectiveness of the first dose of radioactive iodine. That's the question. and maybe decrease chronicity. Because if we decrease it from 50%, if that's a fair number, even to 30%, you decrease one, the chronicity of the disease, and two, the potential for someone giving them 2 and 3 and 4 doses that isn't going to clear the disease and just increase the risk of exposure. So we really do have to incorporate oncogenes and start thinking about, and it's for a short term. It's surprising how quick people resensitize. I had to read the papers 4 times before I'm like, that's not possible. It's not possible that disease shrinks in a month, or or that it takes radioactive iodine up in a week or 2 weeks. Like, but apparently it happens. So, it was news to me and very surprising. But it really does work in a short period of time. And in that setting, you may not be obligating the patient to months and years long of exposure, but just a very short term, and then radioactive iodine, and then see.
And especially with these very targeted selective agents, like the selective RET inhibitors are the best example, right? Very few off-target effects with those. And, we could incorporate those things into our practice with you wouldn't even have to be an oncologist to use those particular ones in a very discrete setting and taught right. So they're, it's not like we're using really toxic drugs for long periods of time. So I could see that bleeding over into a nuclear medicine, thyroid endocrine oncology sort of setting, completely different than lifelong systemic therapy in the RAI refractory.
Right. But it really has to be a study, prospective study, multi-center.
Absolutely.
Because we don't have the answer. We're just asking the question, and the patients have to be consented to the whole thing.
Absolutely.
Excellent. And now I wish to thank everyone. Thanks, Mike, Andy, and Marius. Thanks for joining us back. And special thanks to Dr. Choker. I'm sure it's quite late for you back in Mumbai. And I think we had an excellent day. And thanks, everyone. Hopefully, we'll see you. Some of
Thanks,
tomorrow.
everybody.
Bye-bye.
Great
Thanks,
discussion.
everyone.
Thank you. Bye-bye.